would like to welcome you all to the Endocrine Pathology Updates, focusing the thyroid gland 2023. And this event will be followed by a 2-day workshop on diagnostic thyroid pathology on 13th and 14th of May, where we plan to have an extensive glass slide sessions for the participants. This event has been organized under the guidance of Honorable Vice Chancellor Lieutenant General Bipin Puri sir, and he has given us his tremendous support to make this happen. It is a collaborative effort with the Department of the Endocrine Surgery, King George Medical University, and I am very thankful to both the HODs, Professor U.S. Singh sir, Head of the Department Pathology, and Professor Anand Mishra sir, Head of the Department Endocrine Surgery, who have been a guiding force in planning and executing this event. So I welcome all the eminent speakers who graciously accepted our invitation and took out the time from their busy schedule to be with us. I would also like to extend my welcome to all the guests who have come from all around the state to join us here for this event. Our faculty members and all the residents have put a great efforts in putting this event together, and I hope that this would translate in a good scientific feast. So without any further ado, I would request and invite Professor Nuzhat Hussain ma'am, Head of the Department Pathology, Ram Manohar Lohia Institute of Medical Science, Lucknow. Ma'am, I would request you to please introduce our audience with the theme of the CME today. Thank you.
Thank you, Chanchal, and thank you for giving me this opportunity to give an overview of what's new in pathology of the thyroid. A warm welcome to all the speakers. Dr. Radhika, great to have you here. Dr. Pandey, Dr. P.K. Agarwal, your blessings are always wonderful. And Dr. Madhu Goel and all the esteemed audience that are present here. When we ask a question of what's new in the thyroid pathology, let's look at what's happened after the WHO gave their edition, the 5th edition. And in the overview, I will just kind of broadly look at what happens with the borderline lesions, what's happened to the high-grade lesions, what's happened to the medullary cancers, and do we have something with the pediatric neoplasms. So in the borderline lesions, this is just an overview to kind of incite you to get into the lectures, which will give you all the details. And so just an overview to tell you that the borderline lesions, as we know in the WHO 5th edition, are the NIF-TP, which we have been talking about for a while. Then you have the thyroid tumors of the uncertain malignant potential, and you have the hyalinizing trabecular tumors. But apart from that, you have several case reports in literature, as well as some case series which describe lesions which are again and could be later in the WHO put in the borderline lesions. For example, we have seen that we report MNGs, multinodular goiters, and then we find that some of them turn malignant. So the further studies looking into the genetics of these have shown that some of them may be associated with syndromes like the Dicer syndrome, or you may have like the gene mutations which are present in them, which then incite them to go along the papillary, follicular, or medullary pathways. So that's another thing that one can look at when we are looking at the borderline lesions. Catherine Eloy gives a very nice statement when she says about the borderline lesions. When you give a borderline diagnosis as a pathologist, most people talk about the uncertainty and they say the pathologist is not able to define this lesion. But we have to understand that the uncertainty is different from error. It's not an error. We are talking about a lesion which is borderline and we don't know how this lesion is going to behave. So what helps you in determining how this lesion will behave is maybe you can look at the molecular, the mutations that are occurring in these lesions, and maybe you may be able to define further into which pathway these lesions they are going to progress. The other thing that has helped in these borderline lesions is computational pathology. So computational pathology, as we are all aware of it, I'll not get into what it is. The point is that what is it looking at in the thyroid? So in the thyroid, computational pathology is doing like a 3D approach to look for invasion. The other thing it is doing is to look for PTC-like features, because now we know you have those percentages which clearly tell you that if this PTC-like feature is less than 1%, if it is so much, that's how you're going to categorize it. So it also does that percentage of the PTC features. It also identifies the true papillae from the false papillae. It helps in classifying the oncocytic type of lesions, and also it helps in diagnosing the micromedullary carcinomas. And needless to say, when they did a kappa of 3 pathologists versus this AI system, the AI obviously had a better kappa, which was more than 0.9. So that's there. The other is about the neuroendocrine tumors. So in the neuroendocrine tumors, there are 3 markers that you need to put in all thyroid neoplasms, and these are your calcitonin, your CGRP, and chromogranin. And then you have neuroendocrine tumors which can be positive for all 3, and this definitely is your typical MTC or medullary thyroid cancer. You can have a neuroendocrine which is not showing calcitonin, and this can show CGRP, in which case this is an atypical medullary. And if it is not showing both the CGRP and the calcitonin and showing only chromogranin, then you're looking at a primary neuroendocrine carcinoma or metastatic neuroendocrine carcinoma not coming from the C cells. So that's what's there in the neuroendocrine division. Coming to the high-grade neoplasms, the high-grade neoplasms, earlier we were putting them as you had that insular carcinomas, which were like somewhere in between your well-differentiated and the anaplastic lesions. So these intermediate sort of high-grade malignancies have been better defined in the new WHO. And these, you have now a fancy for the residents out there. The examiner is going to ask you what an HGFCDNATC is, right? So it's more than an NFT this time. So it is a high-grade follicular cell-derived non-anaplastic thyroid carcinoma. And then these would further get divided into the polydifferentiated ones and the ones which have obviously a follicular or a papillae structure. What I would like you to remember is that there is a 5 mitosis thing which has come up in the new WHO. That 5 mitosis borderline is there both for these high-grade intermediate lesions and also applies in the medullary cancers. Coming to the pediatric nodules, with greater risk of malignancy, and the SEER data actually shows now that at less than 20 years of age, almost 1.8% of new thyroid malignancies are coming up in children at less than 20 years of age. And the Bethesda system of reporting thyroid cancers has, there's a large meta-analysis series reported in 22, which is a series of more than 3,800 cases. And they said that the Bethesda works very well in defining pediatric malignancies. So therefore, an FNA is definitely advised in all pediatric nodules before you go for a final diagnosis. And then also the pediatric cancers, how are they different from the adult ones? The BRAF 600VE, as you know, is the marker for the adult PTCs, but in the pediatric age group, the BRAF ones are less common. And what you get more are the translocation type associated PTCs that are present there. And finally, just a word about the medullary cancers. As Dr. Pandey, I'm sure will get into the grading there, but then you have a low grade and a high grade medullary cancer now. And there is a specific system of reporting these low and high grades. As I said, that 5 mitotic count has been picked up here as well as for the intermediate high grade lesions. And this less than 5 mitosis, more than 5 mitosis, as far as mitosis is concerned, then for the medullaries, then you have the Ki67 and you have the tumor necrosis. So with this presence, you will then either the high mitosis or the necrosis, you will push it into the higher grade lesion. So that's the grading of your medullary lesions. And you will need to do the RET activation in these medullary cancers, because the RET activation is kind of different when it is a normal activation versus the tumorogenic activation, the oncogenic activation. And the oncogenic activation is different for the syndromic type, the MEN syndromes, versus the sporadic type of activation. So the kind of activation that is occurring in the RET gene will determine what therapy these tumors will get. So the RET activation is definitely a mandatory part of the medullary carcinoma treatment protocol. So thank you very much again. That's just a small introduction to the CME. I'm sure you will be getting great details all along. Thank you.
Thank you so much, ma'am, for such a useful insight into the topic of today's event. I now request Professor Madhumati Goyal, ma'am, Professor Seema Sharma, ma'am, and Professor Anand Mishra, sir, to kindly join us on stage and also facilitate Nusrat, ma'am. Thank you so much. I request Professor Madhumati Goyal, ma'am, Professor Seema Sharma, ma'am, and Professor Anand Mishra, sir, to please chair the next session for us. We shall move on to our next session. I now request Professor Madhumati Goyal, ma'am, to please introduce to us our next speaker, Professor Rakesh Pandey, sir, Professor at SGPGI Lucknow, who shall be discussing with us the WHO updates in classification of thyroid neoplasm, what and why.
Thank you, Isha. So I have been given this task of introducing Dr. Rakesh Pandey, who has been a professor at SGPGI. And fortunately, I'm grateful to Chanchal, who has invited me for this event. Dr. Pandey, most of you might be knowing, but he is my batchmate. So he did his MBBS, his 1972 batch, MPS and MD from KGMC. Then he became faculty at KGMC. And in 87, he left KGMC and joined PGI, SGPGI Lucknow. Dr. Rakesh has been a very favorite student of Professor R.M.L. Mehrotra, and he was instrumental in establishing hepatorenal registry at KGMC. I've been a witness of that, and I have learned a lot of things from him after doing my MD from KGMC. He did not look back when he joined SGPGI, and in SGPGI, those who are from old days might be knowing that he established the Department of Pathology in SGPGI. So a big round of applause for him. Now, and he has been very modest, so he would not like what I will say now. He has been a very good, excellent teacher, par excellence, a good, very excellent analytical approach, and a wonderful and careful exposition. So what he will tell you, in fact, he has been my guiding force as well as a mentor. Meticulous person, very hardworking, and any adjective will be not sufficient for him. So I invite Dr. Rakesh Pandey for his talk. Thank you. वो ये कि that was the first one to get into the HIS development there.
Thank you. Let me first start taking me here, and I am sure you all know hyperbole when you hear it. I'm overwhelmed actually, but you know what this is. This is just well, hyperbole is enough. I don't need another adjective. I feel I need a minute to respond to what she has said. And let me just say one thing, that doing anything needs a lot of people. It is never one person who does anything. It is just a matter of chance that who goes where first and starts what. But ultimately, anything that is established needs a lot of people. So anything that I don't think that anything is really credited to me at PGI, but if anything is, it is due to a lot of people and their support. Well, the topic that Chanchal has given me, I don't know whether it's her thought or she thinks that it was my thought or somebody else had advised her, but she has added two loaded words, what and why. And both, I thought that both are very detailed and philosophical and words which I may not be able to do justice to. So I may summarize what up to some point, and about why we will see. We will talk a little about why as we go along, but let us see why these changes have happened. As all of you know, the classifications keep happening all the time. And sometimes the classifications are just a result of, or the new classifications, so-called new classifications, are a result of arguments between the two groups. And sometimes one group wins and sometimes the other group wins. And that is why there are sometimes semantic changes, as we will see again later in the thyroid. I suppose I have half an hour, and I would request, please warn me if I exceed time. So this was the classification that we used to have when in the 70s. And it was very simple. If the tumor had papillae, it was papillary carcinoma. If the tumor had follicles, it was follicular carcinoma. And to the extent that Dr. Woolmer of Mayo Clinic, this was quoted by Dr. Ronald Hossain in his talk, that Dr. Woolmer used to say that the classification of thyroid tumors was very simple. There is a group of differentiated slow-growing tumors that never killed anybody, and a group of undifferentiated rapidly growing tumors that killed everybody. There are just two kinds of tumors. Obviously, like all such statements, there is a bit of truth in it, but there is a lot that happened over the years. And during the following years, the WHO classification, in the old days, WHO classifications were not that important. And I hope old-timers will remember classifications of lymphoma, where you had several classifications which were in vogue. And thyroid was a great comfort because it was the simplest of classifications that we have. So then we had classifications like follicular variant of PTC, which created a lot of problems, as we will see. And other variants were described. You had minimally invasive and widely invasive follicular carcinomas, medullary carcinoma, and anaplastic carcinoma. And so the WHO editions kept getting published. You had 74, then you have 88, then you have 2004, and in 2017, the last classification that we had before the new one came up, The peculiarity of this classification was that all tumors were designed separate chapters and there were no groups. And it consisted of some benign tumors which were separate, follicular adenoma and its variants, hyalinizing trabecular tumor, and then the borderline tumor that Dr. Nusrat referred to, or the encapsulated follicular pattern tumors, papillary thyroid carcinoma and its follicular thyroid carcinoma was described as minimally invasive, encapsulated angioinvasive and widely invasive, and Hurthal cell neoplasm as Hurthal cell adenoma and Hurthal cell carcinoma. The further types included poorly differentiated thyroid carcinoma, anaplastic thyroid carcinoma, squamous cell carcinoma in the last classification was a separate type. And then you had medullary, mixed medullary and follicular, mucoepidermoid, mucinous carcinoma, thymomas, etc. So what happened in 2022? Last year we had WHO classification available in March, I think. It is not out in print yet, but the beta version is available on the website. Obviously, you need to subscribe to see that or read that. But I don't think last I checked, it wasn't available in print. So the authors claim at the same time there were a lot of commentaries and summaries of the classification that were published. And the authors of the classification claim that the emphasis has now gone back to taxonomy. In the sense that the similar tumors are now grouped together and dissimilar groups are kept further apart. The basis of the classification generally remains the same, except for the fact that as the time goes by, the molecular changes get more and more important. However, we should remember, despite the increasing impact of molecular biology, the molecular biology also emphasizes the value of classical histopathology because many histological patterns reflect specific molecular alterations. When we talk about taxonomy, I hope some of us remember who gave this taxonomy classification. You remember Carl Linnaeus? The binomial nomenclature that we use so often for organisms, plants, bacteria, animals was started by him. So what are the major changes in the classification? These are the major revisions that have happened. There are two things that are important before we go to individual tumor entities. One is that the Hurthal cell tumors, the tumors which we used to call as Hurthal cell tumors, it is recommended that we call them oncocytic. And because Hurthal C cells or parafollicular cells, and that is why it is recommended that we should not use the term Hurthal cell anymore. The other relatively unimportant thing is that the earlier classification used terms like variants. So you had variants of papillary carcinoma and so on. Because the term variant is used in genetic classification as a standard term, so it is recommended that in histology, we should use the term subtype and not variant. The mitotic count should be reported as per 2 millimeters square. But traditionally, we have all been using per high power field or per 10 high power field. The area can be easily obtained by knowing the field of view of your eyepiece of the microscope. Generally speaking, if your field of view is 20, then 10 high power fields equals 2 millimeters square, roughly. The other changes include the name thyroid follicular nodular disease, which has now been given to the entity which we used to call as multinodular goiter. Follicular adenoma with papillary architecture is now a separate subtype. You have invasive encapsulated follicular variant papillary carcinoma, which is now separated from papillary carcinoma. Papillary microcarcinoma is removed as a subtype. It is recommended that it should be subtyped according to the type of morphology that it shows. Oncocytic we already referred to. And then, as Dr. Nuzhat again told you in the beginning, that there is now a follicular derived carcinoma which is high grade. This is a new term. And differentiated high-grade thyroid carcinoma is one type of follicular-derived high-grade carcinoma, other being poorly differentiated carcinoma. The cribriform modular variant, which was earlier called as a variant of papillary carcinoma, is now considered a separate subtype, separated from papillary thyroid carcinoma. And squamous cell carcinoma is now considered a subtype of squamous cell carcinoma. Sorry, anaplastic carcinoma. And malignant teratoma of the thyroid, or carcinosarcoma, which we used to call, is now labeled as thyroblastoma. So these are the broad classes in the new classification. The broad classes are follicular cell-derived neoplasm, which include benign, low risk, and malignant. Then C cell-derived carcinomas, mixed medullary and follicular carcinomas. Then salivary gland type carcinomas, thyroid tumors of uncertain histogenesis, thymic tumors, and embryonal tumors. Let's spend a little time on each of these categories. The follicular cell-derived neoplasms include benign tumors, low-risk neoplasms, and malignant neoplasms. The multinodular goiter, which we used to consider as a hyperplastic lesion, is now considered a benign neoplasm, or is included under that group. Although it is still controversial because all multinodular goiters are not neoplastic. However, it is true that multinodular goiter term is a little problematic. The problem is that multiple entities can have multinodular thyroid enlargement. Carcinomas can have multinodular enlargement. Hashimoto thyroiditis can have multinodular enlargement. And obviously, multinodular goiter can have a multinodular enlargement. Pathologically, we have been calling them as various terms by adenomatous goiter, adenomatoid goiter, or adenomatoid hyperplasia, colloid nodules, or even multinodular goiter. So it is now recommended that we call it as thyroid follicular nodular disease, which avoids calling it either hyperplastic or neoplastic. It is also realized now that many a time the nodules, at least some of the nodules in multinodular goiter, are clonal. And that is how neoplasms, malignant neoplasms, and ultimately anaplastic carcinoma may evolve from these nodules. This is another of benign neoplasm that is now considered a separate subtype. This is follicular adenoma with papillary architecture. The important thing to remember is that the papillae grow towards the center, centripetally. On the other hand, the papillae of papillary carcinoma grow outwards, centrifugally, towards the periphery. And this is usually associated with hyperfunction. And that is why, and because it has different mutations, thyroid stimulating hormone receptor and GNAS mutations, that is why it is now considered a separate subtype. This is a tumor that you all know. As I said, Hurthal cell is a misnomer. It is now considered a separate type because it is again associated with distinct molecular alterations in mitochondrial genome. And for a diagnosis of oncocytic neoplasm, at least 75% of cells should have oncocytic appearance. This is how they look in hyper. An important aspect of the new classification is description of low-risk neoplasms. The low-risk neoplasms include something which is now popular, NIFT-P, or non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Remember that there is no carcinoma here. The papillary, the word is only papillary, not papillary carcinoma. Then thyroid tumors of uncertain malignant potential and hyalinizing trabecular tumor. NIFT-P was first included in the previous 2017 classification as a type. We should remember that it can also be subcentimetry, and that is a factor which caused the removal of micro NIFT-P. The diagnosis of NIFT-P requires very strict criteria. It has to be encapsulated or circumscribed. There should be no invasion, and we should actually have examined all of the periphery or the capsule to exclude invasion. It has nuclear features resembling that of papillary thyroid carcinoma. The papillae should either not be there, or if an occasional is there, it should be less than 1%. Generally, many people consider that if you see true papillae, then it is possibly not NIFT-P. There should be no Samoa bodies, no mitosis, no necrosis. And although the genetic analysis is not mandatory for diagnosis yet, but if you find that there is BRAF V600E mutation, then it is not considered as NIFT-P. This is an example of a tumor that is circumscribed. It has a thin capsule and it has nuclear characteristics like grooving, oval nuclei, irregular nuclei, and nuclear pseudoinclusions. And there is a category called thyroid tumors of uncertain malignant potential. They are capsulated or uncapsulated, but the invasion is questionable. You cannot say whether the invasion is there, or you can't say that it is not there. And basically there are two subtypes: the follicular tumor of uncertain malignant potential, which lacks papillary carcinoma-like nuclear features, and well-differentiated tumor of uncertain malignant potential, which has nuclear features resembling papillary thyroid carcinoma. This is an example of questionable invasion. There is a small tongue of tumor which has breached the capsule, but it has not yet gone out. There is no mushrooming. And that is why it will not qualify, at least for most pathologists, as invasion of the capsule. And that is why this will be classified as follicular tumor of undetermined malignant potential. The idea of describing these low-grade neoplasms is to avoid over-treatment. Because if you label them as papillary carcinoma just based on nuclear features, then the patient will have to undergo total thyroidectomy with lymph node dissection. And this is to be avoided. The morbidity associated with total thyroidectomy, that is why there is a lot of emphasis on diagnosis of these borderline tumors or low malignant potential tumors. The other type is a relatively rare hyalinizing trabecular tumor, which also has PTC-like nuclear changes, but it has a peculiar prominent intratrabecular hyaline material associated with the cells. And it also has specific molecular alterations, but lacks BRAF and RAS mutations. The malignant thyroid follicular cell-derived neoplasms include follicular carcinoma. Invasive encapsulated follicular variant papillary carcinoma is now a separate type and is not included with the papillary carcinoma. We will get to that in a minute. Then you have oncocytic carcinoma and high-grade follicular-derived carcinomas. Broadly speaking, the thyroid tumors are divided into two groups based upon molecular alterations. The one group has BRAF mutations and the other is RAS mutations. And when genomic analysis of these tumors was done, it was found that the invasive encapsulated follicular variant actually grouped with the follicular thyroid carcinomas. And with time, each group of these tumors will acquire or may acquire additional molecular alterations which can lead to development of differentiated high-grade thyroid carcinoma or poorly differentiated thyroid carcinoma and anaplastic carcinoma. I suppose you will get all the details later. You can organize this into a kind of diagnostic flowchart where the mutations, BRAF and RAS mutations, you can use to classify with the morphology into different types of these follicular cell-derived tumors. Follicular thyroid carcinoma is still defined by capsular and vascular invasion. It is classified into minimally invasive, which only has capsular invasion, angio-invasive, which can have limited vascular, and in the thyroid and beyond thyroid. It is to be remembered that just the presence of extensive angio-invasion does not make a tumor as widely invasive type. This is the invasion seen in follicular thyroid carcinoma. You have characteristic mushrooming, and you also have characteristic vascular invasion. The invasive follicular variant papillary carcinoma, it has been separated into a different subtype because it has RAS-like mutation changes, differs from usual papillary carcinoma, although the nuclear changes are those of papillary carcinoma. The true papillae are absent, and there may be capsular or vascular invasion as you see in follicular carcinoma. There still remain rare occasional tumors which will conform to the type of invasive encapsulated follicular variant but will show BRAF-like mutation changes. It may also show papillae at multiple level sections or at the examination of additional sections, and it is suggested that in future these may probably be grouped with papillary carcinoma. Papillary carcinoma you are all familiar with. It has several subtypes. The aggressive subtype diagnosis is important. These aggressive subtypes include tall cell, columnar cell, and hobnail. The tall cell type definition has changed again. To begin with, the definition was 3 times tall as wide. Then in the 2017, it became 2 to 3 times tall as wide, and now it has changed again to 3 times as tall as wide. So as I said earlier, this is just which group wins. The other high grade or variant or subtype with poor prognosis is columnar cell, and columnar cell variant is rare but has vacuoles in the supranuclear or subnuclear region and might resemble endometrial hyperplasia. The hobnail variant shows a lot of cellular discohesion and loss of polarity, but remember that this has to be differentiated from cystic changes with hobnail-like morphology, which does not have poorer prognosis. The oncocytic thyroid carcinoma, as I said, depends on the presence of 75% or more oncocytic cells. It can also show capsular or vascular invasion, and the subtypes are similar to that of follicular carcinoma. An important change in the new classification is follicular cell-derived high-grade thyroid carcinoma. This is a new category, and this has been designed or this has been labeled to include 2 types. One is poorly differentiated thyroid carcinoma, which was described in the authorities, but there still remain tumors which behave similarly but do not conform to the definition of poorly differentiated thyroid carcinoma. And these are called as differentiated high-grade thyroid carcinomas. They still have distinct architectural areas which may resemble papillary carcinoma or follicular carcinoma or oncocytic carcinoma. And so these are the two types that are included with the follicular cell-derived high-grade thyroid carcinoma, poorly differentiated as well as differentiated. One major difference is both necrosis is a defining feature of both of them, but one difference is that mitotic count for poorly differentiated is 3 or more per 2 millimeter square, while it is 5 or more per 2 millimeter square for differentiated. Convoluted nuclei as originally described in the Turin proposal is still there, although it is a little iffy. This is how they look. The left one is poorly differentiated carcinoma, which has a nested or insular pattern, and the right one is differentiated but high-grade papillary-like features which shows necrosis. The anaplastic carcinoma, all of you must have seen. It can have either epithelioid or giant cell or rhabdoid or sarcomatoid morphology. An important thing that has happened in this classification is that the squamous cell carcinoma, which was considered as a separate type in the 2017 classification, is now considered as the subtype of anaplastic carcinoma. And that is because on molecular analysis, we find that a large number of tumors that we study show changes similar to either papillary carcinoma or follicular carcinoma. That is either RAS-like or PRAF-like changes. It is also recommended that these carcinomas, anaplastic carcinoma, including squamous cell carcinoma, should be tested for presence of BRAF V600E mutation. This can be done also by immunohistochemistry. You can have antibodies to VE1 clone, and they can help you quickly identify tumors which will respond to therapy which acts against these changes. This is how the squamous cell carcinoma and the sarcomatoid carcinoma look. And we have had papers also published which have done the immunohistochemistry for these tumors. And one of the commentaries also gave a decision tree for differential diagnosis of follicular cell-derived neoplasms, where you can have features like presence of PTC nuclei, encapsulation, vascular and capsular invasion, and presence of follicles or solid or trabecular pattern to arrive at the subtype. And now you also need to incorporate identification of mitosis as well as necrosis for diagnosis of high-grade types. An important change has also occurred in medullary carcinoma. The medullary carcinoma is also now classified into two grades, low grade and high grade, and it is considered essential to classify them into low grade or high grade because of significant difference in prognosis between the two. And the high grade is defined by 5 or more mitotic figures per 2 millimeter square and or presence of necrosis. It has also been suggested that mitotic count and Ki67 index in this tumor, that is medullary thyroid carcinoma, may function as continuous variables. What this means is that as these features increase, as the number of mitosis increase or as the Ki67 index increases, the prognosis worsens. One important criticism that you have of this grading system is that the necrosis is not quantified. So maybe in future, you might have quantification of necrosis for more precise grading of these tumors. So I suppose all of you can identify mitotic figures in medullary carcinoma. See increased Ki67. How much do you think it is? 25, 30? Okay. And then you have thyroid tumors of uncertain histogenesis, where sclerosing mucoepidermoid carcinoma with eosinophilia and cribriform mollular thyroid carcinoma have been clubbed together, but only in the sense that their histogenesis is not known. The molecular profile of cribriform mollular carcinoma is distinct from papillary carcinoma. It has beta-catenin associated changes, and that is why it is kept in a separate group from papillary carcinoma. Then you have thymic tumors and embryonal thyroid neoplasm, thyroblastoma, which is associated with DICER1 mutation. So, summarizing the major changes, we have a major category or a major concept of low-risk neoplasm, which is emphasized in the new classification, although the borderline lesions or the encapsulated lesions were emphasized even in the 2017 classification. Then we have separation from papillary carcinoma of invasive encapsulated follicular variant as well as cribriform mollular carcinoma. Introduction of two-tiered grading system, both for follicular cell derived as well as for medullary carcinoma, as low grade and high grade. All these changes will have impact on the upcoming releases of clinical guidelines, cancer staging protocols, and thyroid histopathology and cytopathology reporting standards. In fact, there is recently an article about impact on the cytology reporting of this classification, and the Bethesda guidelines are soon going to come for according to the new classification. Obviously, like any other classification, this is also not foolproof or permanent. So as we noted as we went along the classification, that there are areas which are still controversial and which possibly will change as we learn more. And so compared to the original statement of Dr. Woolmer, who said the thyroid carcinoma is very simple, we had this lament by Dr. Pierre Mason, who was a leading histopathologist of his time, a French-Canadian pathologist, who said no classification is more difficult to establish than that of thyroid. Very few tumors are adapted to a precise classification, and of all the cancers, they teach, perhaps, the greatest lessons of humility to the histopathologist. Even if you don't agree with the first part, I hope we all agree on the second part, and on this note, I will end. Thank you.
Thank you, sir, for finishing time. And it is always a treat to listen you, and this is not hyperbole. Now, session is open for questions.
Thank you so much, sir. And I consider myself fortunate for having one of your students. For the objectivity you bring to the histopathology, 75% on precipitate, 4 vessel criteria. I mean, these are so good, we cannot always know molecular things. So the question may sound silly, but do we have any role of the samoma bodies in this all new classification, or they are just there that it is follicular variant?
The presence of samoma bodies will be used to exclude papillary carcinoma. If you have samoma bodies, then you will have to call it papillary carcinoma. You cannot call it NIFT-P. So the importance lies there.
Neoplasm and carcinoma.
Thank you, Dr. Pandey. As usual, it was a nice presentation. One question which just arose in my mind. We talk about necrosis in papillary carcinomas as consigning it to the bad category. And we have cystic change so frequently in papillary carcinoma. I'm just wondering that is usually cystic change is a consequence of necrosis. Am I right or wrong? I suspect I am wrong because otherwise this will happen that way. But then what is the genesis of this? In multinodular choroid coitus, it is also said that the nodules are large, they pinch the blood vessels, and as a result, you get necrosis or to be followed by calcification and cystic change side by side.
I think the cystic change that we usually consider as cystic change in thyroid is not due to necrosis. The cystic change in multinodular goiter is thought to be because the follicles enlarge and some of them rupture, and then you have fluid in the nodules, which enlarge again. And in papillary carcinoma, probably a similar mechanism is at work.
Another question about hobnail cells, hobnail variant of papillary carcinoma. The nuclear features of papillary carcinoma are preserved despite the hobnailing.
The nuclear changes are not so prominent. The nuclear changes are subtle. They may at places resemble or have nuclear changes of papillary carcinoma, but many a time the nuclei are hyperchromatic and may not show you characteristic changes like grooves or pseudoinclusion.
Third thing, in Dept we use the word papillary like nuclear changes. I mean, is there a difference between?
They can be as florid. They can be as florid.
Thank you.
Thank you, sir, for this elaborate talk. Obviously, we were afraid to ask the questions when we were SRs, and I'm fortunate enough to ask them now. So, one question: I recently reported follicular neoplasm of certain malignant potential. The physicians were asking that what is the prognostic impact of the patients? So, any experience or any publication to refer to that?
I think Dr. Nusrat gave you that answer earlier. The clinician is thinking that you are uncertain. You have to tell them that you are not uncertain. So, sorry, say it again.
The uncertain word, anyway,
Yes, I know. As she said very rightly, it means that the pathologist is uncertain. You have to emphasize that you are not uncertain. It is the tumor. See, there is a famous saying, tumor is as tumors do, not as they look. So that means that we still don't know how this tumor is going to behave. Most likely, the impact on management is that you should avoid over-treatment. This is what the classification recommends, that if you have a tumor of undetermined or uncertain malignant potential, then lobectomy should suffice.
Thank you so much.
Thank you, sir. Thank you, sir, for this wonderful talk. Thank you, sir.
Thank you so much, sir, for such an intriguing session. Listening to you, sir, was really a good pleasure. I now request our respective chairpersons to kindly present a memento to Professor Rakesh Pandey, sir.
It doesn't look like thyroid, but
Formulation of thyroid. Artistic expression.
I request our chairpersons to please stay on stage while I call on the dais Professor Nusrat Hussain ma'am and Professor Vinita Agarwal ma'am to please facilitate our chairpersons. Thank you, ma'am. I now request Professor Nusrat Hussain ma'am and Professor Vinita Agarwal ma'am to please chair our next session. Our next discourse is by Professor Radhika Srinivasan ma'am, Head Cytology and Gynecological Pathology, PGI Chandigarh, who would talk us through the molecular biomarkers of adverse prognosis in follicular-derived thyroid carcinoma. And I request Nusrat ma'am to kindly introduce our speaker.
It's indeed a pleasure to introduce Dr. Radhika Srinivasan. We all know her, she really doesn't need an introduction, but we know that she heads the Department of Cytology and Gynecology at PGI Chandigarh. She's a good friend and we have been in touch quite frequently over conferences and meeting at PGI. And I know that she's provided the department with a very dynamic leadership. She's much respected in the international and national community. And I met her recently at the ASCAP conference at New Orleans. And I could see that she was a much wanted figure there in all the, the gatherings, especially the cytology group and the OBGYN group, where we know that she has co-authored 2 chapters in the WHO group. And she also is the secretary of the Indian Academy of Cytology, and she's actually given in a lot of vibrance to the society as in her leadership. And she started all those orations and the CME programs at the cytology group. She has also, chaired the EQUAS program, which is run by the cytologists, now taken up subsequently by Dr. Nalini, who's running it now. And actually, we get their slides, and it's an extremely good experience to be part of this EQUAS program, which the PGI Chandigarh is running, which has been mentored by Dr. Radhika. She has more than 250 publications, and she has taken up more than 5 research grants in the ICMR and DST. We all know her primary interests are molecular oncology, cytopathology, and gynecology. And it's really a pleasure to have her here today at Lucknow to deliver her lecture. So thank you very much, Dr. Radhika.
Thank you, ma'am, for that very kind introduction. And again, a big thanks to Dr. Chanchal Rana, Dr. Mishra, Dr. Singh, the entire organizing team of this wonderful CME. And I think more than the CME, like I said, the fun part is going to be the workshops which follow the CME. So what we are going to tell you is more theoretical, but maybe this will stimulate you into seeing the slides, the real fun part which is going to follow this. And I congratulate and compliment Dr. Chanchal for all the, her enormous enthusiasm and energy for putting this meeting together and giving me this opportunity to come back to Lucknow to meet so many of my friends here. And thank you so much, Dr. Nusrat and Dr. Vinita, for this. So the topic again was given to me by Chanchal, and she said, "Can you cover molecular?" Some months ago, and I said, "Ha ha, theek hai." head comes to me, so I'm fine with that topic. But I never read the entire topic properly that was allocated to me, which I looked at about 15, 20 days ago. And I got really a bit of a shocker because it said molecular biomarkers of adverse prognosis. And what I had really worked on was something in the field of FNAC and where we could apply molecular markers for diagnostic to improve the diagnosis of thyroid FNA. And this was something completely different, and I had to look at it from the prognostic angle. So it was quite a bit of a learning experience for me for the last 15 days or so, to pull down a lot of review articles and go through them. So I thank you for this learning opportunity, and I hope to share with you. I have become wiser after reading them, and really wanted to share with you what has been happening in this field in the last few years or so. So this is, of course, there are many people have written updates. There are at least 3 or 4 groups who have written updates on the 2022 WHO classification. And we had this wonderful talk by Pandey sir, and which has actually set the foundation for this, meeting. And so this is one such thing which I just took this table from there. Just to look at the follicular cell-derived malignant neoplasms. And basically, again, Dr. Pandey has taken us through the entire list, but I'll be concentrating essentially on, papillary thyroid carcinoma and follicular thyroid carcinoma, and of course the FVPTC, the invasive encapsulate, and so on. We'll just be looking at the differentiated follicular cell-derived thyroid carcinomas. So this is the question, actually. Can we predict the behavior of differentiated thyroid cancer? What is the role of genetic and molecular markers? In essence, this is what I'm going to try to answer. And this has been again reviewed in this very nice review article. I hope you can see the bottom lines there because most of the references are below. This is by Nichi Poruka et al., published recently, which gives you a good overview on this. So let's see whether we can or not. So we know that thyroid cancer is 9th place amongst all newly diagnosed cancer cases, and estimated incidence of 6.6 per 100,000, mortality of 0.343 cases per 100,000. Now the differentiated thyroid cancer, PTC, FTC, comprises more than 90% of all the thyroid cancer cases. Now vast majority, to reiterate, they're relatively inert and have an overall favorable prognosis, and it's a small minority which behave badly. But this differentiated thyroid cancer can, have aggressive features because some 2% of these patients can have distant metastasis at the time of diagnosis. About 10% can come with systemic metastasis later, and up to 20% will suffer from regional or local tumor recurrence and also become refractory to iodine therapy. Now, these were the traditional prognostic factors, well established are age, the gender, the extent of primary thyroidectomy, and also the post-op stimulated thyroglobulin. And recently recognized and maybe not very well established are a family history, the presence of autoimmune thyroid disease, and also the type of certain types of surgery and preoperative TSH. So if you look at the traditional prognostic factors, one is, of course, age. We all know that with increasing age, the prognosis is bad, but, in most of the articles, 45 years is kind of taken as the cutoff. More than 45 years, tumors tend to do badly. Then children almost always have a better prognosis, prognostically good tumors, even though they can have extensive disease or even with metastasis at presentation. But with older patients, it's usually a bad outcome. Then we have, as far as gender is considered, obviously males have a worse prognosis. And regarding the extent of surgery, total or near total thyroidectomy obviously is good, and it improves recurrence and the survival rates of tumors when they are more than 1 centimeter. But of course, now we are moving away from radical surgery to a less morbid surgeries. And then, of course, you have tumor histopathology and the stage of the disease. We all know that when it's multinodular, extrathyroidal invasion, vascular invasion are all poor prognostic parameters. We've been shown in just the last talk certain variants like the tall cell, the columnar cell, and also these which have aggressive behavior, and also the multinodular form of FEPTC which have aggressive behavior, and the oncocytic variant which is less responsive to radioiodine. So what really is evolving, the evolving approach is to incorporate these molecular features into the prognostic evaluation of not just the DTC, the well-differentiated thyroid carcinomas, but also to some extent in the poorly differentiated carcinomas. Now, besides talking of prognosis, I think the clinicians are also moving. They want us to tell about the predictive markers. So we have emerging predictive markers, particularly I'll talk about it later. And of course, what to my interest is also to incorporate into FNAC the molecular data to be able to provide a more precise diagnosis in indeterminate or the borderline lesions, and thereby aid better surgical management. Now, as a concept, this was again told in the previous talk, and I'll reiterate further that if you look at differentiated thyroid cancers, you have one group which is the RAS-like and one group which is the BRAF-like. So in the RAS-like tumors, mostly it is the follicular patterned tumors which FTC and the invasive encapsulated FEPTC, which again, you all know that minimally invasive, angioinvasive, widely invasive, etc. And in the BRAF-like, it is dominated, of course, by the PTC, which could be the classical or the conventional PTC, and then you have the other subtypes of PTC. So in order to understand this, what is this RAS and what is this RAF-like, which pathway do they actually come, and this is the pathway that it's all about. It's all about mostly the MAP kinase pathway, which is also called the mitogen activated protein kinase cascade. So you have the receptor tyrosine kinases. So this is the receptor tyrosine kinases to which this growth factor binds. And then there is, cross-phosphorylation of the tyrosine kinases. And then they, activate the downstream molecules on one side, which is the RAS. Then you have the BRAF. Then you have the MEC, and you have the ERK here, which again in turn moves into the nucleus and it regulates gene expression. And then on the other hand, you can have the PIK3 kinase pathway, the AKT, the mTOR pathway, which in turn, of course, is negatively regulated by PTEN and which can be affected, of course, by the PAX8 PPAR gamma. So you have the Dept PTC gene alterations, which again can affect the receptor tyrosine kinase here. You have the RAS mutations, which affects RAS signaling here, and the BRAF mutation, which affects BRAF signaling. In general, there is a constitutive ligand independent activation of the pathways leading to uncontrolled cellular proliferation. So keep this in mind when we're talking of RAS, RAF and all. You should understand, especially for the students, what pathway are we talking about. But these days, I can tell you our students know very well about molecular and signaling pathways rather than basic ABC, bread, butter, cytology and histology. So I guess they know more than me here. Now, if you look at the RAS gene mutations in thyroid neoplasms, they frequently involve NRAS and HRAS, unlike KRAS, which is more commonly seen in the epithelial malignancy. So that's again something you have to know, that it's NRAS and HRAS, which are important players in the thyroid. It can be seen in about 10 to 20% of the FEPTCs and 40 to 50% of the FTCs, and also seen in follicular adenomas. So basically, RAS mutation marks neoplasia, but not really malignancy, because they're also seen in follicular adenomas. So obviously, you would expect that RAS mutations do not have any role in prognostication. So again, it's important as a concept to remember that when you have a tumor with a RAS mutation, it has an expansile pattern of growth and less florid nuclear atypia. But when you have a BRAF mutation, it gives rise to infiltrative tumors. It gives rise to florid nuclear atypia. And the next things have already been told to you in the previous talk. So this is where was my little bit of work. We have Ojas sitting here who did quite a bit of work on this molecular testing for BRAF V600 RAS mutations, and we did it from cytoscrapes of the thyroid fine needle aspirates. and we actually looked at its role, whether it improves the accuracy, whether it really helps us in indeterminate thyroid nodules. And the answer was that it is definitely useful. We used a very simple Endocrine 5-gene kit, the same kit which we use to detect EGFR mutations. It's easy to run, and it was a useful rule-in test. So it was not perfect, but it did help us in the indeterminate category. So here are some of the pictures from that paper. So this was, for example, a PTC, and this is what it was. Frankly, it was a frank PTC, of course, both on cytology and histology, just to show you that this showed the BRAF V600E mutation. And then, of course, you have this was a follicular, and it turned out a follicular adenoma, and this had NRAS, for example. This was a follicular carcinoma. This had an HRAS mutation. And again, this was an FVPTC, which I think had an NRAS mutation. So RAS mutations are there, may help us in the indeterminate nodules, but certainly they're not of any prognostic value. So what about the red PTC gene rearrangements? Just a word about what red PTC gene rearrangement is. You have the three prime portion of red, the cytoplasmic domain of the red oncogene is there, and then you have the partner. The chimeric oncoprotein has a 5 prime from some other gene, and these are long list of fusion partners. So basically, this leads to constitutive dimerization and ligand independent activation of the red tyrosine kinases. Now, red PTC rearrangements are more frequent in children and young adults, and also populations that are subjected to these radiation leak. For example, we had the Chernobyl incident in Russia some years ago, and so these all there it is kind of enriched for this red PTC gene rearrangements. They've also been seen in some benign lesions such as Hashimoto's and FDA, and really the bottom line is they have no value for prognostication, but they could have some value as predictive indicators for the use of RET inhibitor therapy. Now, coming to the hero of the thyroid mutation story is, of course, BRAF. We all know that. And so this is a BRAF gene with 18 exons, and of course, the most important mutation. It's again a gene that has been extensively studied in the thyroid. Besides, of course, other cancers, we also know that BRAF comes up in a whole lot of other cancers, but this is where it has a very prominent role. Exon 15, we have V600E, which is actually due to this missense mutation, T1799A mutation, which gives rise to this V600E substitution there. Now, there are more than 40 mutations identified in the BRAF gene, and 90% of it are usually this. And again, this leads to constitutive activation of the kinase. Like I say, remember the MAP kinase pathway. Besides this, we also have some other mutations like the K601E, and even V, you also have 600K, D, R, and all of them are there. And this is again the mutational profile in the BRAF gene in PTC. So, of course, besides PTC, you can also have BRAF coming up in anaplastic thyroid carcinoma. Again, there it is more like a predictive marker rather than a prognostic marker, where maybe the clinician will think of a role for institution of anti-BRAF tyrosine kinase therapy. So this is going back nearly a decade. There were lots of papers on BRAF and what is its prognostic. Line was, it is an important prognostic marker in thyroid PTC. It serves as a marker of poor prognosis. So what are the poor prognostic histopathological markers? One is extrathyroidal extension and nodal metastasis, and clinically, of course, the stage and distant metastasis. So whenever you're talking of prognosis, remember these things: extrathyroidal extension, then lymph nodal metastasis, then of course you have distant metastasis. It was also a predictor of treatment failure or tumor recurrence, and of course, they went to the extent to say that it's good to do BRAF, know the BRAF status pre-operatively in FNA samples, and such patients who are BRAF positive would benefit from more extensive initial surgery, a closer follow-up, and also higher doses of post-surgical radioiodine treatment and lower suppression of TSH. Now, this was again a meta-analysis done in 2012 by this group, Tufano and Justin Bishop and all of them. And then they So this is 2012. Remember, a decade earlier. 14 articles, 2470 patients, 9 different countries. Overall prevalence somewhere around 45%. And then look at the risk ratios and how it is predicting. So basically, it predicted it was a poor prognostic markers. PTC recurrence, yes, this was the risk ratio there. Lymph nodal metastasis, yes. Extrathyroidal extension, yes. But it did not actually predict for distant metastasis. But for advanced stage, yes. So it was a poor prognostic feature to have BRAF mutation in a PTC. It was strongly associated with that. Now come to 2022, 10 years down the line. Okay, and this again is a review article, again a systematic review by Wei et al. So they looked at more, almost double the number of patients, and then they came up with a slightly higher average. They have looked at whatever the studies that were included. This was the average BRAF mutation, and then the following variables were associated with an increased risk of, BRAF mutation. One was age, more than 45 years. We already know that this was a poor prognostic feature, but they tend to have BRAF. Male gender, again, we knew from the traditional prognostic factors. Multifocality, yes. Extrathyroidal extension, yes. Vascular invasion, yes. Tumor node metastasis, yes. But what about the no? What did not correlate with BRAF? That is also important for you to understand. One was the tumor size. It didn't make a difference there. Nodal or distant metastasis, it didn't make a difference here at all with the BRAF. Tumor size, yes, sorry, it did correlate with BRAF, but not the lymph nodal or distant metastasis. Whereas in the previous systematic review a decade earlier did show some sort of a correlation with nodal metastasis. So there's another analysis again in children. What about BRAF mutations in children? Again, we know that the pooled prevalence in the pediatric and the adolescent population was much lower than the adults. So we know that in children, I already told you, red PTC comes up. So that is where BRAF, the proportion of BRAF actually goes down. And again, a lot of these things did not have any risk association or with BRAF mutation among the pediatrics. So in the pediatric population, BRAF did not have the same prognostic impact as it did in adults. So then we all talked of the histological subtypes. So the question is, do these what about BRAF in these specific histological subtypes, which we know have features and they also have a higher rate of recurrence? Tall cell variant, BRAF is seen in 90% of the cases. So yeah, morphology is such a good predictor there itself, but also BRAF also comes up. Columnar cell, again, you have BRAF, but in addition, you have a whole lot of other things also happening in the columnar cell variant. And of course, you have the hobnail also has BRAF, but again, these tumors, besides BRAF, you're starting to see some other mutations, and we'll talk about them, particularly the TERT, TP53, loss of CDKN2A, and also the PIK3CA mutations. Now then, there is another review article, again a meta-analysis by Chen et al. And here what they did was they looked at the overall impact of BRAF, and then they stratified it by continent. So when they looked at Asian countries versus the Western world, there was a difference. So the predictive effect of BRAF was different. In Asia, it really did not make much difference at all. Whereas in the other continents, it did impact prognosis. And that explains to us why 1 decade ago, BRAF had such a major impact on prognosis, as all the studies told us. Subsequently, the Asian countries started producing more and more data. We had data pouring in from Korea, from Japan, from China, and so on. And then, of course, it started showing that in these countries, the frequency of BRAF was so much higher. It was nearly 70 to 80% in Korea, whereas in the West, it is somewhere around 45%. But there it made some impact on the prognosis. But here it had no effect. Obviously, if 85% of your PTCs have the same mutation, it's unlikely to be of any prognostic value. That explains it. So you have to be very cautious. They said you have to be very cautious in interpretation because it may have a high negative predictive value for PTC recurrence, but a very low positive predictive value. In other words, if a tumor did not have BRAF mutation, it's likely to do well. But if a tumor had BRAF, you don't know whether it's good or whether it's actually bad. So this is where the controversy actually started. So they said it's present in so many PTCs, nearly half the PTCs, and among them, only about 10 to 15% would actually go on to have an aggressive behavior. So this is what is, and all this comes, then we started learning more. There's more to it than just BRAF, because these tumors, which all had an aggressive behavior, had more than one known oncogenic mutation. And इसीलिए कहते हैं picture abhi baki hai mere dost. So we, the last word has not already been said. This is just the intermission. And so here comes, for the next half, the hero or the villain of the piece is actually Dept. Dept really was the twist in the tale of BRAF. BRAF was the queen of the previous decade. I think the next decade is going to be dominated by Dept. So this is one of the original papers by Vinagre et al., Nature Communications, 2013. And then they looked at Dept in a whole lot of tumors, CNS, bladder, etc. And then they showed something around 10% frequency in thyroid. And of course, these Dept promoter mutations also, when occurring together with BRAF, is significantly associated with higher Dept mRNA expression. So this we knew nearly 9 years ago. And then the technology to detect Dept promoter mutations is still the Sanger sequencing, DNA extraction and Sanger sequencing. And I think Chanchal has a project running on Dept perhaps. And I just, as I walk through, I just saw one poster which I have to go back and see it in greater detail. One of your students has put a poster on Dept promoter mutations in thyroid cancer, and I would encourage all of you also to go and have a look. Not just that poster, all posters, of course, but I'm definitely going to have a look at that poster in greater detail, because that's producing some data from the Indian population. Now, there are two hotspot mutations in the Dept promoter. One is this, the C228T, and this is the C250T, which correspond to these -124 and -146 base pairs located upstream from the start codon of Dept. And just to show you, this is something taken from this Polish paper, who looked at 189 consecutive PTC specimens with known BRAF mutational status, and Dept promoter was seen in about 8.5% of the cases, with C228T the most frequent. So the frequency is very variable. Again, data is still pouring in, but they have seen that it can range so much, 7 to 22% of PTCs, 14 to 70%, 17% of FTCs. But in the poorly differentiated and the dedifferentiated thyroid cancers, it has a much higher proportion. So this is again a Korean study which has just looked at Dept promoter mutations in the real world. So they looked at consecutive 2,092 patients, and they pegged it at 3.4%. And of course, when they looked at papillary thyroid microcarcinoma, it was very, very low, 0.5%, but these patients did not have any initial metastasis. In PTCs, more than 1 centimeters, 5.8% Dept promoter mutations. And of course, in FTC and PDTs, then the frequency really goes up. And it's 228T, which is seen far more frequent. 64 cases versus 7 cases. Then whether it was this or that, there was no difference clinically or on pathology. So here's again, immediately people go and write systematic reviews, and this is 12 studies, 4184 PTC patients. So I suppose that more and more data comes in from more countries, I think we will get a clearer picture. But at the moment, this is what it is. Roughly 57.6% of the patients of PTC patients carried either BRAF or Dept promoter. 6.9% had both mutations, and Dept promoter was more common in patients who already have a BRAF mutation there. So this is again from the various forest plots in this systematic review and meta-analysis by Chen et al. And really, we should learn how to understand these forest plots. For many days, I didn't know how to understand, but broadly, anything that goes this side and anything which has these kind of things means it is highly significant. So generally, this is mortality. So here is mortality, here is disease persistence, here is recurrence. In all, you can see that the Dept promoter mutations have a role to play with higher. So it is again a bad prognostic feature. Look at gender, male gender, again TERT promoter mutations, higher frequency and therefore bad prognosis. Look at extrathyroidal extensions, same thing, TERT promoter mutations come up in tumors with extrathyroidal extension and also with capsular invasion and also with distant invasion. So metastasis notably higher incidence, and this is the pooled OR. So this is another meta-analysis by Mao et al. And these are from, this was a systematic review published in Computational Mathematical Methods. So, this is way above my level of understanding of statistics, but I just also look at the p-values and also the OR. And what I can understand is that age, gender, tumor size, again, all of them are, we knew that they were poor prognostic parameters, but again, this is where TERT promoter mutation also has a role to play, but not in multifocality, lymph nodal metastasis, and vascular invasion, but definitely in distant metastasis and also in extrathyroidal extension, when these are the pooled odds ratio, and that tells you what is the effect or the impact of TERT promoter mutations. So Liu et al. In this very nice article published in JAMA Oncology, they call it a genetic duet. एक जुगलबंदी होता है, BRAF और TERT का जब जुगलबंदी होता है, patient को बहुत बुरा होता है. That's the bottom line. So this is the mortality risk stratification, and they develop what is known as a synergy index. So you have two mutations. So do they act in a cooperative manner? So this is what it says. This is what it is. Anything more than one is significant. If it is greater than one, it is evidence of synergism. So let's look at the degree of synergism. So this is the TERT promoter mutations in all PTC with, of course, BRAF mutation. It was something like 3.67, but when you look at conventional PTC, it is 7.83. It is much more. Okay, so similarly with 2 to 8 only, it is 8 points. So C2 to 8 mutation and BRAF, they have the highest synergy index in classical or the conventional PTCs. Then they looked at the thyroid cancer specific deaths. Okay, so no mutation, deaths per 1,000 years is only 0.8. If you had BRAF, 3.08. If you had only TERT, 6.2. But when both occur, 29.86. Marked difference. You looked at, that is for all PTCs, all subtypes of PTCs. Again, we are not supposed to call them variants. For the simple reason, we use variants in the molecular, genetic variants. So they don't want us to confuse that variant with this variant. So for histology, we stick to subtypes. So then you look at these classical PTC. So you come to BRAF plus TERT, it's 30.78, and that is shown in this Kaplan-Meier curves. In all patients, if you have BRAF and TERT promoter, the patient does very badly as compared to no mutations, or when they have either of the mutations, they do badly, but slightly only badly. But when both are present, it's an extremely poor prognostic indicator. So this is what it is. The ability of a mutation status to predict poor prognosis in PTC is BRAF plus TERT promoter far more than either BRAF alone or TERT promoter alone. So why does this happen? You have to again go back, and this is a very nice article and a very difficult article again to understand. But I just took this last cartoon where they conclude, and they've done a whole lot of experiments to show that, okay, you have BRAF, we know that MEK and ERK and all that, but this is where it comes, that it goes and phosphorylates FOS. And FOS then in turn affects this GAP-PB. This GAP-PB in turn goes and attaches itself to the TERT mutated TERT. So then it leads to activation of TERT. Besides this, there is also another pathway through MYC, which plays a little lesser role, but this through ERK, FOS, GAP-PB, this is the pathway why TERT gets upregulated when you have the synergism between BRAF and TERT is via the FOS and the GAP-PB pathways. So what about the other tissue biomarkers? What about Ki-67? A whole lot of papers. Histopathologists desperately wanting to have some marker in the hand to predict prognosis, But, bulk of it, majority, I think the bottom line is simple. No Ki67, nothing, cyclin D1, some papers show, but nothing survived in P27, E-cadherin, P53, and all that. Probably none of them have stood the test of time. What about microRNAs? Now, this is an emerging area. So there are a lot of microRNAs which go up and come down. And the advantage of microRNAs is also they can be detected as serum biomarkers. So you have this 146B, 222, and I think there's one more, 221. These kind of are important markers. And one, just to quote one papers, that they said they did it pre-surgery, post-surgery, and if these levels were higher in post-surgery, it predicted for a poor prognosis. But I think it's just emerging data, and we really have to wait and see whether microRNAs are going to have any role. But I predict that they are going to have a role. So I didn't touch about poorly differentiated thyroid cancers, which also fall into follicular cell-derived thyroid cancer, because we already know that they are poor prognostic tumors, and besides just mutations, they have whole-scale alterations in a whole lot of genes. The SW1 SNF complex, and then you have chromosomal gains, chromosomal losses. So you just can't address this issue by simple next-generation sequencing. You will have to have MLPA assays and so on and so forth. But in general, if somebody wants to read, here's a very good article that you can go back and read on the genetic alterations in poorly differentiated thyroid cancers. So I already talked of predictive markers, why kinase inhibitors, all these sorafenib, sunitinib, blah, blah, can be used. And of course, you have BRAF inhibitors, vemurafenib, dabrafenib, would be effective treatment options, in recurrent cases, systemic metastasis in tumors which have the BRAF V600E mutation. Just a word on iodine refractoriness. Cancers, 31 uptake gradually, indicating redifferentiation of the DDC known as radioactive iodine refractory differentiated thyroid carcinoma. And we have all the genes, the MAP kinase, the PIK3 kinase, AKT signaling pathway. Whenever there's an alteration in these pathways, this affects and results in iodine refractoriness. Now, how does this actually do? And that, again, you have to really understand is the sodium iodide symporter system. And this is very important. And again, this itself would take, half an hour to go into the details of this. It's a very crucial system which is required to concentrate the iodine into the cell. So this is what it is. You have the NIS, I call it for short, and it undergoes trafficking through the endosomes and all that, and how it actually plays a pathway in thyroid hormone synthesis is something you can go back and look into. But just to tell you that this is very complex and it can be affected by multiple signaling pathways like the MAP kinase, PIK3CA, Notch, Wnt, TGF-beta, etc. Even epigenetic modifications, methylation histones can affect this, can interfere anywhere in this whole complex situation of the sodium iodide transporter, lead to iodine refractoriness. And they can be reversed to some extent by BRAF or MEK inhibitors, PPAR agonists, and retinoic acids, all of which are used as differentiation therapies. So I come back to my initial question. So can we predict behavior of differentiated thyroid cancer from its genetic and molecular features? What would be your answer? Have I convinced you yes or a no? Or maybe? Only Dr. Nusrat is answering. Okay. Those who say yes, raise your hands then. At least assure me that I may have... okay, the backbenchers don't seem to agree. I think they haven't raised their hands. I think they are very wise. The people sitting at the back, I have to say they're silent. They don't want to raise their hand. I think I would not even say yes or no, but I think it's a combination of the clinical features. I forgot to throw in imaging features, which again is so important. Histopathology, yes, and molecular markers. I think if you take molecular markers out of context and start to interpret it or give it more importance than it actually should have, you're going to land in trouble. So integrated, it has to be integrated to the clinical, the imaging, histopathology, and then you will be able to predict the behavior of differentiated thyroid cancer. Of course, the villain of the piece is BRAF, and we learned a lot that it is actually more than BRAF, not BRAF, it is actually the third promoter. And I think the future is really a black box with a lot more to come to predict the behavior of differentiated thyroid cancer. So thank you very much for your attention.
Thank you, ma'am. That was a wonderful lecture, and I think with absolute justification is the topic that will be allotted to you. And it speaks of the volume of experience that you have and the humility. I always admire the humility that you show, the amount of experience that you have. Thank you so much, Dr. Madam.
Thank you.
I just had a small query. There are a lot of markers that are coming. What do you think of these are the markers which need to be done pre-operatively, and then we will have to do them in the FNAC, that is the cytology in a cell block or something, which can be done after you have the surgical specimens on the list. So what is your say on that?
No, by markers again for diagnosis or
not for diagnosis, as a prognostic and predictive.
Right. I think at the moment, like I said, there are only two things that you can do for prognostication. One is BRAF, and one is, of course, the third promoter mutation. So my feeling is that the digital PCR is a technology that's coming in a big way. And it's excellent for picking up point mutations. So, it's very cumbersome for anybody to extract DNA from the tissue, go and actually do a Sanger sequencing on it, and not only time, the human effort and labor. So if you have a simpler test coming in for both BRAF and TERT mutations, like I said, but the frequency of TERT mutations is very low. So it's just about, I think I was looking at the poster, some 3 or 4% is what you would be looking at. But those are the patients who would benefit from this test. So it is third promoter alone, like I showed you in that last paper, that is only a mild effect on prognosis, but a combination of BRAF, V600D, and third promoter would be the best at this point of time, best available prognostic marker if you have on your table a well-differentiated thyroid cancer. And I think the only way to do it is by molecular analysis. I don't think you have surrogate good IHC markers. Dr. Nusrat can add her experience on IHC for BRAF, but again, BRAF alone is not going to tell you anything about the prognosis. Okay, so if you want to do, you have to do a combination. For the combination, I feel that we should look at digital PCR, which will save time and energy. It's widely used for point mutations in so many hematological patients. Should be we could have Indian data coming in. Maybe somebody should take the lead, and others have a multi-centric project on this, so that multiple institutions can send in their samples, and then you have a big study, some 500 patients or more. Then you have adequate statistical power, and then India can make a name for itself. It's all nice to have G20 and all these things, but if you really want to be quoted in the world arena, you have to have multicentric studies. You have to have large numbers of samples which run into hundreds. It cannot be one institution. Thank you.
I completely totally agree with you on that. And I think also that the extended panels for, like as you said, the BRAF alone doesn't matter. It is not enough. So you actually have to look for the RAS and
no, RAS third promoter.
The RAS third promoter as well as the RET PTC.
RET PTC, I think frequency is no effect on prognosis. Only two things: third promoter and BRAF.
From the diagnostic and prognostic.
It's nice to know RET promoter if it's there or not, but won't make a difference in management. Yeah.
So usually these comprehensive thyroid panels which have come up for testing give you at least like 5, 7, or 9 genes which are tested together, and they give you a combination. The other thing is also when you look at the combinations, the interpretation varies when you're looking at a well-differentiated versus a poorly differentiated. Like we say for well-differentiated, the BRAF mutation is giving you a worse prognosis. On the other hand, in the poorly differentiated ones, if you are getting a BRAF mutation without the TERT, you are actually giving the best prognosis because you are linking it to a PTC, which is then treatable by the tyrosine kinase inhibitors. So the incidence of the TERT along with the BRAF then puts it into a very bad group there.
Yeah.
So as you rightly pointed out that the morphology and the whole context of the spread of the tumor should be interpreted along with the genetics in terms of prognostication. Thank you very much. Do you have any messages from the audience? Yes, Dr.
I have one remark that 90% of PTCs are cured.
Correct.
So the marker has to be one which is found in only a very small proportion of cases that would work. BRAF, 40-45% of cases, it can't really explain why only 5 to 10% of cases are lost and 90% do well. And another, as an aside, in fact, it just crossed my mind, is the presence of lymph node metastasis in a case of papillary carcinoma. Is it a marker of bad prognosis or is it of no consequence or little consequence?
I think I've shown in some of the meta-analysis the relative risk of BRAF for lymph nodal metastasis per se. Yes, it makes it a higher stage disease. Obviously, it would have an effect on prognosis versus if you compare two groups of patients, one without lymph nodes, one with lymph nodes. Obviously, the one with lymph nodes would require more extensive surgery. But if a surgery is done well in that patients, then it's still the prognosis is fine in such patients. I think I would, if you pay attention to the last slide by the JAMA 2017 analysis, I think he's taken it out of here. That is what gives you the answer that doing BRAF alone is of no use. That's what I told you. 10 years ago, they made it that it was very important prognostic feature. It didn't stand at 10 years down the line in 2022 meta-analysis, Asia versus other countries, it did not stand. It's not of any value in prognosis per se, just BRAF. You have to combine BRAF with TERT. I think can we have that presentation? So the last, yeah, that is the take home. I think if you remember just that, ekdam end ka last slide. So the last part, the JAMA, yeah. So that slide told you everything. That even if it was TERT promoter alone, it only made a small effect. Yeah, 1 minute. This is what it is. Just see this. Okay, no mutation right on top. Only BRAF, a little effect only. Only TERT, a little more effect. But here, if you took conventional PDCs, even TERT alone or BRAF alone didn't make much difference. But look at the combination. The curve goes here. So if you're looking at a prognostic marker, prognosis, then you have to look for the combination. If both are present, then only it's a poor prognostic marker. If either one is present, still it need not tell you. So this is what it is. So if you have BRAF only, it's only 3.05 deaths per 100,000 person years. If it's TERT only, it's 2.40, but the combination is 30. Nearly tenfold. So this is the message I want to give. Poor prognostic factor is a combination of BRAF plus TERT. Thank you. Thanks for asking that question, so it can be reiterated.
The thing about lymph node metastasis I asked was definitely because there was a very old study in which they showed that patients, they had the figures to show that patients have lymph node metastasis in papillary thyroid carcinoma very frequently, and many of them are not clinically manifest. And you do not remove the lymph nodes, you remove the thyroid, but most of the patients, probably the lymph node metastasis, they take care of themselves once you do the thyroidectomy, and hence they do not require neck dissection subsequently. So in this context, I was just asking that, is it a marker of lymph node mets are a marker of very bad prognosis or even a significant effect on outcome?
No, see, to answer that question, you would have to have a cohort of patients for which they did not do surgery in spite of lymph node metastasis and followed them up, which would not be possible. So I think this must be coming from very maybe 3 decades earlier data. I don't know the answer to that, but I think at the current way the patients are managed. Dr. Mishra, guys, a surgeon would be better suited to answer your question than I am. I don't think they would not do even a limited lymph node dissection if there was documented. Yeah. I mean, maybe micrometastasis, I don't think it would matter. Thank you. Thank you.
Thank you, Councillor Linda, for this interesting session.
Thank you, ma'am, for this captivating talk. It was a delight listening to you. I now request our respective chairpersons to please present a memento to ma'am.
Last night when I came to Lucknow, I saw thousands of butterflies lit up on the street lights. All have the symbol, so I don't know if there's something Lucknow
Highlight the butterfly of it.
publicity for the Thank you.
Thank you, ma'am. I would also like to request Professor Munazar Hussain, ma'am, to please felicitate Professor Vinita Agarwal, ma'am.
She's my student.
We are extremely honored to have with us Professor Vineet Sharma sir, Pro BC KGMU, and on behalf of the entire Department of Pathology and Endocrine Surgery, I would like to thank sir for his impeccable support, encouragement, and constant motivation that we could delve into such a venture of organizing this CME. Thank you so much, sir. We are extremely grateful to you. Sir, I welcome you on stage to officially inaugurate the ceremony. I would also like to request Professor Radhika Srinivasan ma'am, Professor Madhumati Goyal ma'am, Professor U.S. Singh sir, and Professor Anand Mishra sir to join us for the inauguration ceremony. I request Professor Rakesh Pandey sir to please join us for the inauguration ceremony. And also Professor Arun Chaturvedi sir. I welcome all the dignitaries on the dais with a ekal push. Professor Vineet Sharma sir, Pro BC KGMU. Professor Madhumati Goyal ma'am, Lab Director Medanta Lucknow. Professor Radhika Srinivasan ma'am, Head Cytology and Gynecology Pathology, PGI Chandigarh. Professor Arun Chaturvedi sir, Head Surgical Oncology, KGMU Lucknow. Professor Anand Mishra Sir, Head Endocrine Surgery, KGMU Lucknow, and Professor U.S. Singh Sir, Head Department of Pathology, KGMU Lucknow. I now request our respected Pro Vice Chancellor Sir, Professor Vineet Sharma Sir, to kindly share his valuable thoughts and inputs about the CME.
Thank you. My seniors sitting on the dais, heads of the departments, Professor P.K. Agarwal, Dr. Nuzhat Hussain, my colleagues, residents, ladies and gentlemen. It's a pleasure to inaugurate this conference which has been organized with the collaboration of two departments, that is endocrine surgery and pathology. Such conferences which involves the surgeons who have to operate and the pathologists who have to make a diagnosis really makes a difference. And I'm sure this update today on thyroid, with the presence of luminaries from PGI Chandigarh, from Vedanta, from other delegates who have come far and wide, will definitely enrich the knowledge of our students here. And I am sure with the deliberations that we come across, at the end of the day, it is the patients who benefit. I congratulate both the departments, Dr. Anand Mishra and Dr. U.S. Singh, for organizing this conference, and I wish you all the best. Thanks a lot.
I now request all the dignitaries on the dais to please join us for the traditional lamp lighting ceremony. No auspicious event can be started without remembrance of God, and on this occasion, we seek the blessings of Ma Saraswati, who is the goddess of knowledge and an embodiment of wisdom and learning. I thank all the dignitaries. I now request Professor Madhumati Goel ma'am to please say a few words.
Again on the dais. And this was a surprise for me that I have to say a few words. It is always coming back KGMC because I was born here in 1972 and the institution gave me so much. So it's always a pleasure to come back to the institution. And today, Chanchal, you have really brought people together and it was a delightful treat to have. And I think all of you will enjoy the deliberations. Thank you.
Thank you, ma'am. I now request Professor Radhika Srinivasan ma'am to please say a few words.
Thank you, Chanchal, and dignitaries on the dais, Professor Sharma, Professor Singh, Professor Mishra, Madam Goel, dignitaries of the dais, Madam Padam Agarwal, ma'am, Dr. Nuzhat, and everyone else who is here, delegates. So I think I'm very happy to be here. First of all, a big thank you, and most importantly, I want to congratulate and compliment Chanchal Rana, Dr. Mishra, and the entire team, Dr. Singh, and all the entire team which has actually put up this program, Endocrine Path, Thyroid, focusing on the thyroid. Exciting about this program is not the lectures that we're giving in the CME, it's just the starting, it's just a starter, but the real stuff is actually what's coming after the CME, and that's the workshops which Chanchal is having. Yesterday I was asking her about the details, and she has planned it so that people get to see nearly the entire spectrum of thyroid pathology here, and I mean that is remarkable. And really, I am also going to be one of the participants in that workshop. So I've come here more to learn, and it's only teaching and learning are actually interchangeable, I would say. So it's great that you have started this exercise, and I hope that you will continue to have more such CMEs and more glass slide based workshops that residents and young faculty and also everybody benefits from. Case-based workshops, and I think they have to be encouraged. And once again, my best wishes for this success of this CME and also the workshops. And thank you very much, sir, for this kind invitation. Thank you.
Thank you, ma'am. I now invite Professor Arun Chaturvedi, sir, to please share his thoughts with us.
Professor Vineet Sharma, Madam Madhumati, my senior, and Professor P.K. Agarwal, my teacher, Nuzhat, and not many friends, colleagues. It is indeed a pleasure to be here in this conference. And so as part of surgical oncology, we also do thyroid cancer. But this has been a tremendous learning experience, at least whatever I heard today. And I think this constant learning experience is what shapes us in any kind of teaching institution. And I'm so happy that the Department of Endocrine Surgery and Department of Pathology have got together to organize this conference and workshop. I'm seeing it's going great, and I wish it all success. Thank you so much for inviting me. Thank you once again.
Thank you, sir. I now request Professor Yves Singh, sir, to please share his words with us.
On behalf of Department of Pathology and all the faculty of Department of Pathology, I welcome you, sir, Professor Vineet Sharma, sir, who has been my teacher and also is the head of the Department of Orthopedics and Provost Chancellor in KGMU. I welcome my teacher, Professor Dr. Madhumati Goel. I welcome Dr. Radhika Srinivasan, who is head of Department of Gynecology and at PGI Chandigarh. And my teacher, Professor Dr. Arun Chaturvedi, sir, and my colleague, Dr. Mishra. It is a great day for me because we have among us teachers of teachers, and we are really very much thankful to you, Madam Professor P.K. Agarwal, Madam, who has come at this age, and yesterday also, in the previous conference also she was there, and today she has come. It is a great blessing for all of us, Madam. We welcome you very much. Now we are enlightened to have our own department colleague, Professor Dr. Nuzhat Hussain, who is Dean and Dean at RML Institute of Medical Sciences and also head of the Department of Pathology. And we are very much thankful that Dr. Seema Sharma, the HOD of Department of Pathology, has come from PGI, SGPGI, and all the, Again, I am thankful to my teacher, Professor Rakesh Pandey sir, who has come and delivered here. We welcome each one present here, all the faculty, all my seniors, my honorable senior, Dr. Sudhir Srivastava, and everyone present here. Now, what I'm going to say is just the repetition of the things. And already you have heard that what Professor Nuzhat Hussain has said, rightly said, and I do agree that the classification whatsoever currently has come is saying that it is of low potential, or we don't know that what is the outcome, uncertain outcome and all that. So this type of the terminology is really, worrisome for us. Then we heard about the Professor Rakesh Pandey sir, and he elaborately said that don't go at how do they look, but how the tumor behaves, that's important. Or in other words, he has said that the best test is the time testing. So let the patient come in the follow-up, see the progression of the disease, and then only you can predict that what is going to happen. It was really enlightening to listen to the different type of the changes, cytogenetic and molecular changes by Professor Srinivasan, and she has rightly said that there is a related changes, cytogenetic changes, molecular changes. That's well taken, but our concern is slightly different, and that is that in this part of the India, the thyroid disorder is found. It is found as a common disorder, and the main problem with the thyroid disorder is, other than the tumor, is about the hormone. There is a hypothyroidism, there is a hyperthyroidism, maybe primary, maybe secondary, and the problem with this is that our masses are not aware of this disorder. So, and that is the one problem. The second is, I don't think that it is a topic in our primary or the school level. So even the educated children also probably are not so conversant with this disorder. And the third is at a hospital level, even in the best of the institution, they are doing outstanding work. But the thing is, a patient coming to the outdoor, a patient coming to the IPD, they are not segregated for that which department you should go and should get the specialist treatment. Or in other words, we can say that at the patient locations, the specialists are not coming. So that way, suppose someone is having hypothyroidism, so they have to roam around. And what is hypothyroidism? Means there is a mother hormone. If it is defective, all the metabolism, carbohydrate, fat, protein, everything will be defective and its consequences. So we have seen the hypothyroidism, its effect in the cardiovascular system. We have seen in the malformation in the women's, likewise in tuberogenesis and all that. Then second concern is that although WHO is very well taken, that they are doing the this morphological classification, which we do, and the cytogenetics or the molecular markers. It is well taken, but after all, who is going to pay? And where are the facilities? And if you make an evidence-based or mandatory, how it inhibits legally from doing the services to the masses. So in Indian scenario, we need to be guided by WHO, but should derive certain mechanism so that we can make an early diagnosis. We can make almost 100% diagnosis on phenotype, because phenotype and the genotype are the same thing. What you see in the morphology, you see in the genotype as well. Now, what about the mutations? We are talking about mutations so much. Mutation is not bad. We are here, all the species are here because of the mutation. So there are good mutations, neutral, and the bad mutations. So just making this thing that these are the mutations, we don't know whether it is bad, good, or neutral, and things likewise. So I think that pathology people should do the morphology part, genetics people should do their genetics classification and all that. And the thing which we are saying that it is a targeted therapy. Now it is again a misnomer. Why misnomer? Because although the disease is same, genetically the same, but when the treatment is given, it is in the many different persons who are genetically and they have many alterations. Multivariant from each other. So how can you say that this is I will say कि भाई आपको ये targeted therapy दिया गया है? Because suppose someone is suffering from thyroid disorder and he has got some compromised renal and all that, the outcome is going to be different. As far as the prognosis is said, as Madam has said, although the mutation is there, but we are not able to comment for how long it was there or how long it will take to express. So if you are saying prognostically a year, it is too much of the statement. So this we must understand. We must understand that we are in India. Our protocol is so it should be derived at university level and should be in practice. Thank you very much. Thank you.
Thank you so much, sir. I now request Professor Anand Mishra, sir, to please share a few words.
Respected VC sir, Minister Sir, Madhumati ma'am, Radhika ma'am, dignitaries on the dais, Chaturvedi sir, teachers, delegates, I welcome you in this campus of KGMU. Delegates who are coming from outside, on behalf of my department. Thyroid, if you see, it's the most fascinating organ in the history. And if you see all countries, all continents, they have, that's a single organ, they have association. American Thyroid Association, European Thyroid Association, Oceania Thyroid Association, even Japanese Thyroid Association. So it's a single organ. And the second organ, if I say, is in last 2 decades, it's the breast only, on which there are a number of publications, the associations, only based on this single organ. If you see the thyroid surgery in 1850s, it was said to be a horrid butchery. And in fact, I don't know you pathologists know these postgraduates know or not, French Academy banned this surgery in 1850s. It was criminal to do thyroid surgery. But in next 50 years, thyroid Kocher, he got a Nobel Prize on the physiology of thyroid surgery, thyroid physiology, and he was a surgeon. And from there, it has progressed a lot. As a surgeon involved in this conference, we these thyroid pathology in 3 groups: good, bad, and ugly. And there are many classification and detailed classification. There were many types of surgery, in fact, number of controversies, subtotal, lobectomy, nodulectomy, partial thyroidectomy. But as a surgeon, if you say, we have a consensus now that for unilateral, it has to be hemithyroidectomy or lobectomy. For bilateral disease, it has to be near total thyroidectomy or total thyroidectomy. And I think this targeted conference on this pathology, endocrine pathology, will give us some help in getting this consensus, because your pathology helps us in deciding the type of surgery, whether we are going to do a unilateral surgery or going to do a bilateral surgery, and associated with talking of prognostication, whether we are going to do extensive lymph node dissection or less lymph node dissection. I congratulate Dr. Chanchal. He has done tremendous hard work to organize this conference, and I'm very happy that he has so many delegates. I mean, she has worked so hard. So, Chanchal, our expectations are, already Dr. Radhika has said, our expectations are high for the next time and for a greater conference. Congratulations to you, and once again, I welcome you all to our campus. Thank you.
Thank you so much, sir. I would again like to thank all the dignitaries on the dais for joining us today. We shall stop here for a short tea break. I request everyone to please join us for high tea. We will resume with our next set of sessions at 12:40, and I request everyone to be seated by then. Thank you.
Yes,
आइए आइए आप भी आ जाओ। आप एक सेकंड खड़े हो जाओ। अच्छा तो आप ये खड़े दो बार छोटी दिक्कत नहीं है सर, हमें एबीसीडी नहीं पता पहली बार है। अरे दो चार फोटो में आ जाएंगे आप। अरे आओ देखो
I welcome you all back. Professor Manoj Jain, sir, Professor SGPGI Lucknow, wants to say a few words. I would like to invite sir on stage.
Thank you. So first of all, I congratulate Dr. U.S. Singh, the whole Department of Pathology, KGMU, Dr. Chanchal for organizing this focused CME on thyroid pathology. Now this is the high time that we should focus on subspecialty pathology. As you know, last year we had our this is of Indian Academy of Psychology, Indian Academy of International Academy Pathology Indian Division. We had a conference last year, Diagnostic Update and Molecular Advances in Endocrine Organ Lesions. So when we built this topic, among 6-7 topics, this was selected. And last year on 16-17 September, we had meeting at SGPGI, this CME. And that was a huge success. And such a short span, we are having another endocrine pathology focused CME in Lucknow. So this shows how much this area is picking up. So as ever expanding knowledge in pathology, we are seeing that molecular and recent classifications are taking up. So this is the high time we should have some national body for endocrine organ pathology, endocrine organ pathology society. In 2005, we had an CME, International CME of Renal and Transplant Pathology at KGMC, at SGPGI in 2005. And then we formed a society, Indian Society of Renal and Transplant Pathology. And that was a huge success. We are running it till now. So this is the high time because endocrine pathology is picking up very fast, and all this molecular biologists, they should also collaborate with this. So what I will suggest that Dr. Chanchal Rana, she should take lead and form a national body, Endocrine Pathology Society of India, something like that, and form a core group. And she should. I'll Dr. Radhika Srivansan ma'am to say a few words and what is her opinion regarding this. So I'll invite ma'am.
I think you rightly said one thing that we are now moving into subspecialization in pathology in most departments. And worldwide, of course, this has happened some 20 years ago. So you have a lot of international societies in subspecialty pathologists. For example, you have International Society of Gynecologists, similarly you have pediatric pathology, even endocrine pathology, there is an international society and so on. And like Dr. Manoj already said, one of the first subspecialty societies in India was the Indian Society for Renal and Transplantation Pathology, which had its janam in Lucknow, city of Lucknow. Of course, there were stalwarts of renal pathology from SGPGI who have started it, and it is going strong. It did take some time for other specialties to develop, and as of now, I know we have the Dermatology Society of India. I think we had a second conference or so. We have the Neuropathology Society of India, maybe in its third or fourth, fifth year, something like that. And there's one more.
Uropathology. Uropathology. Uropathology is also there.
Genitourinary Pathology Society, which Santosh Menon and the team is working there to bring up that specialty. See, the advantage of having these societies is that it helps, promotes the development of specialty, helps in collaborations. Like I said, we are not collaborating enough, and maybe at least through societies we can have multiple institutions which can collaborate with each other and it will foster collaboration, having CMEs in multiple institutions, so it can be done under the umbrella of these subspecialty societies. So in fact, in February this year, we have just also launched the Gynecology Society of India called GIPSY, and we just made an announcement, but a lot of homework after that has to be done. And what I would propose, sir, is to have a core working group at the moment. You can make a soft launch or a soft announcement, and then the working group can create the bylaws and so on and so forth. But for that, you need to have some sort of a memorandum. So if you could have stalwarts who are there in the audience to kind of sign a memorandum that you would like to launch the Endocrine Pathology Society of India, or what you want to call it, even Society of Endocrine Pathology, I said, or either way. You want to go the way the other societies are, it's always some Society Pathology of India. So it could be Endocrine Society Pathology of India. Once you have the memorandum of understanding, then the core working group can formulate the standard bylaws, rules and regulations, etc. And then you can take it forward from that point of time. So I feel the time has come, this is the right time for us to start it. And then of course liaise with all the other societies, particularly the International Society. This will help us to bring in quality speakers for the Indian audience and help the development of this specialty. At the end of the day, we are all interested in giving good reports and betterment of patient management. So for a very long way, I think this is the right time to start off having this kind of a society, and with the blessings of all the great pathologists in the audience and the youngsters. So it is a big stimulus for the younger generation, and I think at some time the older generation has to take the mantle and start it. So that this is my suggestion on the way to go forward.
As well is rightly saying, our problem is different. Just like genetic mutations are different in India. So at least that will be collaborating and will making our own and it will be better collaborated with endocrine surgeons and whatever stakeholders with endocrine pathology. So it will be better to collaborate international as many see. So I think Dr. Chanchal can take lead and she can form the group, and interested persons can join in that group. And similar like other societies, we can have bylaws just like collaboration with other societies. Professor Chanchal and
everybody else interested in taking up this, it's a huge responsibility, and it will take a lot of time for any society to actually. It's easy to start, but to bring it forward and to develop it, it requires a lot of effort. So people who are kind of committed in different institutions, particularly the seniors as well as the mid-level faculty who are committed to endocrine pathology should have been come under this umbrella of this society.
And Dr. Chanchal can take the lead here. Dr. Shukla is another person who I think is kind of very connected to endocrine pathology. I'm sure there are others, and suggestions can be given to Dr. Mahesh to kind of, I think, first this will form a core working group, then we take it forward.
So what I suggest that it should be represented all major issues of India who are doing endocrine work. They should be represented, their faculty should be represented. So that rate will get good.
Yeah, so I think we should have people from South, which never have that impression. I know, yes, that impression has got created, at least in psychology, dominated by the Nordic peers of what they have the impression. So that impression should not be there. So I think they should be equally wanted from all parts of the country, get them from everywhere, and have the core working group cannot be too big, but once you have got an intent, keep the executive committee wide enough so that people feel that there is a national idea.
So we are always to guide and help everyone.
So I think that right, and this place has done so much for endocrine pathology, and you have dedicated endocrine surgery surgeons here. So I think it's the right place for it to.
It's kind of 9 months we are having another endocrine dedicated CME one NCBI not here.
So you have the conception, now you have the gestation period.
Thank you so much, sir and ma'am, for your valuable suggestions. Now we shall move on to our next set of sessions. Our next oration would be taken by Professor Neeraj Kumari ma'am, Head Pathology, AIIMS Raebareli. Ma'am will be discussing with us the low-risk neoplasms of thyroid and the differentials. I request our chairpersons, Professor Arun Chaturvedi sir and Professor Suresh Babu sir, to please come on stage and introduce our speaker.
So I'll give a brief introduction to Professor Neeraj Kumari. I think a lot is already projected here, but Professor Neeraj Kumari is Head of Pathology at All India Institute of Medical Sciences, Raebareli, and she has specialized in histopathology and cytopathology and molecular pathology, oncopathology. She has received fellowships at Oregon Health and Science University, Portland, and has had training in molecular pathology from Boston and from Netherlands. She has more than 105 publications, and her field of interests are gastrointestinal, hepatic, endocrine, pulmonary, molecular pathology. I invite you, Madam, to make your presentation.
Thank you, sir, and good afternoon, everyone. I thank the whole organizing committee of this CME, both the pathology department and the endocrine surgery department of KGMU, and especially Dr. Chanchal for inviting me here. I was asked to discuss the differential diagnosis of low-risk neoplasms of the thyroid. And as we have already gone through the morning sessions, and most of the things has already been discussed, so this must be a revision for some of you people. We know that the 2022 classification, WHO classification, broadly divides thyroid neoplasms into benign, low risk and malignant ones, and the low risk falls intermediate between the benign and the malignant in terms of morphological features, molecular profile, as well as clinical behavior. Although it cannot be categorized definitely as benign, but it has an excellent prognosis. Now, the WHO 2022 group divides neoplasms in 8 groups, of one of which is the low-risk neoplasms of the thyroid. And it consists of 3 main entities, which we have already seen in the morning. One is the very popular entity, which is non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which is commonly known as NIFT-P. Then the second is the thyroid tumors of uncertain malignant potential, which is again divided into two subtypes: follicular tumor of undifferentiated malignant potential and well-differentiated thyroid tumors of uncertain malignant potential based on the nuclear features of papillary carcinoma. And the third entity is the rare one, the hyalinizing trabecular tumor. Now, in 2017, the entity of hyalinizing trabecular tumor was a separate entity, but in 2022, it has been clubbed with the low-risk thyroid neoplasms. The incidence of this category is, the incidence of metastasis in this category is very, very rare. And most of these tumors are RAS-driven tumors. They show mutation for RAS, except for the hyalinizing trabecular tumor, which has a different molecular profile. So if we detect a non-RAS-like mutations in any of these encapsulated tumors having a papillary nuclear feature of papillary carcinoma, such as especially V600E, not the other BRAF mutations, it's V600E and the TERT promoter mutations already discussed in the morning, then it should alert that if they are present, it should alert that we are dealing with some other entity. So coming to the non-invasive follicular thyroid neoplasm with the papillary-like nuclear features, the term was proposed in 2016 and it continued to remain in the picture in 2017 as well as 2022 classifications. To diagnose a tumor as NIFT-P, it requires extensive sampling of the gross specimen and also very meticulous microscopic examination to find out any focus of invasion, because the presence of a single invasion would change the diagnosis. Prevalence is very low in the Asian countries as compared to the Western population. The histological features already discussed. It requires that the lesion is well encapsulated and circumscribed. It has a follicular pattern of growth with less than 1% papillae. Although the percentage of the papillae was debated, as it has to be 0% or 1%, but again in the WHO 2022, they have agreed to the criterion of less than 1%. The pattern of solid trabecular or insular growth pattern should be less than 30%, and it should have a nuclear feature of PTC with the score of 2 and 3. Absence of any invasion, vascular or capsular invasion, no necrosis and no samoma bodies, and the mitotic counts should also be very low. Although it can be there, it cannot be entirely absent. Now, just for the sake of the residents or the junior residents, the nuclear scoring of the PTC is based on 3 categories. The first is the nuclear size and shape, and each of these categories has given a score of 1. So the total score is 3, and if it is absent, it's 0, so 0 to 3. The first is the change in the nuclear size and shape. If the nucleus is enlarged, it's oval and oblong or elongated, there is presence of nuclear overlapping and crowding, it gives a score of 1. The second category is the change in the nuclear membrane. So if there is irregularity in the nuclear membrane with folding and presence of nuclear grooves, pseudo-inclusions, it gives another score of 1. The third criteria is that of the changes in the nuclear chromatin, where there is peripheral margination or clearing and the presence of ground glass-like nuclei, then it gives a score of 1. So if all these features are present, it's a score of 3. So in NIFT-P, feature of papillary carcinoma, but the mitosis is increased, then we have to think of some alternative diagnosis. So till 1 or 2 mitosis, that is less than 3 per 2 millimeter square area, is acceptable in NIFT-P. If the mitosis increases from 3 to 4, the entity is upgraded, or the lesion is upgraded into an encapsulated PTC with predominant follicular pattern. And if the number of mitosis increases of 5 or more, then it goes to the high-grade tumor, that is non-invasive high-grade follicular variant of PTC, which is again a newer term proposed in 2022, that is differentiated high-grade thyroid carcinomas. Now this picture is just to show a follicular pattern lesion, which has the nuclear features of papillary carcinoma with ground glass nuclei, nuclear grooving, overlapping, presence of these pseudo-inclusions, which is the prototype of a NIFT-P. Now this image shows a papillary pattern where there is a central fibrovascular core, and again the nuclear features are the same with presence of these pseudo-inclusions and ground glass nuclei. So this kind of area has to be either absent or less than 1% in a NIFT-P lesion. Now many times when we routinely deal with these lesions, there is a difficulty to identify true and pseudopapillae sometimes. So true papillae will always have a central core with nucleus arranged perpendicular to the papillae. Whereas in the pseudopapillae, you don't see a nuclear core, but there is a stroma of some stromal cells here, but no vessels. And these are actually the hyperplastic lining epithelium of the thyroid follicles, which are seen in many benign lesions as well. For example, in follicular hyperplasias or multinodular goiters. So we have to be very careful when we say it's the presence of papillae in an FP, whether it's a true papillae or a pseudopapillae. Now, these two new entities have become independent in NIFP. Earlier, they were not given much importance, but now the two subtypes of NIFP have been described in the WHO 2022 classification, where if a tumor is less than 1 centimeter, with all the features of NIFP, it is categorized as subcentimetric NIFP. While in very small tumors, if the tumors are less than 2 millimeters, it's very difficult to categorize them as subcentimetric because it is very difficult to exclude the presence of invasion or a percentage of the papillae in those very tiny lesions. Then, already discussed in the morning, the oncocytic NIFP needs at least 75% of cells to be oncocytic, having a bright eosinophilic granular cytoplasm. Now, molecular tests in NIFP are put under the desirable diagnostic criteria. They are not essential for the diagnosis, but their molecular profile is almost similar to those of the follicular neoplasms, and most of them harbor RAS mutations. As I said, presence of V600E mutation. So please remember V600E because we can get other BRAF mutations sometimes, rarely in NIFP lesions. So V600E BRAF mutations and TERT promoter mutations, if present, then we should think of some alternative diagnosis. In some subset of these lesions, gene fusions like PAX8 PPR gamma and the thyroid adenoma associated gene fusions have been documented. Coming to the second entity, that is the thyroid neoplasms of uncertain malignant potential. Uncertain means we are not sure whether there is invasion or no invasion. So it's about the uncertainty of the tumor, but not about us, because we are not able to document in the tumor whether there is invasion. Presence of any single focus of invasion will change the tumor to another category. Incidence is again very low, 0.5 to 3%, and it requires a very close follow-up because we don't know whether it has been fully sampled or not, because it's not difficult to sample a 4 centimeters or 5 centimeters lesion with almost 50 odd sections. The lesion is again, it has a follicular architecture, encapsulated and well circumscribed. As I said, based on the presence or absence of the nuclear features of papillary thyroid carcinoma, this is divided into two subtypes. That is follicular tumor of uncertain malignant potential, which lacks the PTC-like nuclear features, so it can have a nuclear score of 0 to 1. Whereas the well-differentiated tumor of uncertain malignant potential will have a nuclear score of 2 to 3. Sometimes oncocytic cells, clear cells, or a glomerulite pattern and mucinous stromal features may be seen in these tumors. Now again, it is differentiated from the benign counterpart, the follicular adenoma, and the other encapsulated lesion NIFP by the presence or absence of capsular invasion. The high prevalence of RAS alterations and lack of V600E is similar to that of NIFP. And because of this, on cytology, because the morphological features and the molecular profile is similar, it's very difficult to differentiate on cytology specimens, whether it's uncertain malignant potential or a NIFP lesion. Because the thing is that we have to document invasion, which will be possible only on histology. Now, this is a picture from the Fletcher textbook, just to show that how a questionable invasion will look like. So, if you see these lesions, we know that for capsule invasion, the tumor has to go outside, traverse through the capsule and sit beyond the capsule here outside. But if there are tumor islands within the capsule or they're just mushrooming, this will not qualify for capsular invasion. Similarly, for vascular invasion, the vessels in the capsule or outside should show presence of tumor thrombus, and it should be attached to the wall, not just floating into the lumen of the vessels. Now, this is one of our case. It's a case of follicular nodular disease, which was a multinodular and a hyperplastic nodules were there. I am using this case just to demonstrate a feature, how a questionable or a doubtful capsular invasion may look like. So you can see here that there is a thick capsule here and a thick capsule here, And you can see this thin capsule where it seems that the tumor is pushing, but even on serious sections, we could not demonstrate capsule invasion here. So sometimes it can look like this. This is another focus again. You can see very broad, thick capsule here, and here it is becoming a thin. Again here, it seems that there is a capsular breach, but this is the normal compressed follicles outside this tumor, and the tumor is very well delineated here. So again, this is not a capsular invasion. So we think that it may or maybe it's questionable. So these kind of tumors, they come into the category of thyroid tumors of uncertain malignant potential. Although this is a case of follicular nodular disease, I am just using these pictures to demonstrate the finding. Now, in the other areas of the same tumor, and why saying this? Because in the same, in the other areas of the same tumor, we had these areas where it is more closely packed follicles, more solid follicles, broad trabecular kind of arrangement. So it was a suspicion that can it be a follicular carcinoma. But despite that, we couldn't find, and then there were other multiple nodules in the same specimen. At All India Institute of Medical Sciences, Raebareli, we don't have a dedicated department of endocrine surgery. However, our ENT colleagues, they do the thyroidectomy surgeries. And in the last 1 year, since we are a very budding institute, we are almost in infancy, we got 183 specimens with only 17 corresponding surgical resections. And we had none of these cases was diagnosed as a low-risk neoplasm. The third entity is that of an hyalinizing trabecular tumor, which again is a well-defined lesion, follicular pattern lesion with nuclear features of papillary carcinoma. Incidence is again lower than those the NIFT-P and the UMP tumors. So its prevalence is less than 1%, and lobectomy itself is curative. In some cases, earlier few cases, lymph node and distant metastases have been documented, but it is exceptionally rare, very, very rare. And therefore, radiotherapy is not advised after surgery. Regarding the histological criteria of this tumor, they have a long, wavy, coiled trabecular pattern of growth. The cells are elongated, polygonal to oblong, and they're aligned perpendicular to the trabeculae. I'll just show you a few pictures in the next slide. With very lightly eosinophilic cytoplasm, and again, the nuclear features are similar to PTC. In the cytoplasm, they can have yellow cytoplasmic bodies, which are just hyaline globules present near the nucleus, and they have a small clear halo around them, which represent giant lysosomes. They can have some microcysts or some larger cysts, and they can also have some extracellular hyaline kind of material resembling an amyloid, but it is negative for congruent. One peculiar finding of this entity is that it shows staining with MIB1 in a membranous pattern, and only of the Ki67, which has a clone of MIB1, not with other clones. So this is the histological picture of this tumor, where it has coiled trabecular kind of pattern, and you can see these cytoplasmic bodies which are present near the nucleus and have a clear zone around that globules, which are the giant lysosomes. And this is the staining with Ki67, which is present, which is giving a membranous kind of appearance. We are used to see a Ki67 staining as a nuclear pattern, but here you can see that they are present on the periphery of the cytoplasm, and this is possible. This is seen only with the MIB1 clone. And it is also different from its other counterparts in the same category because it harbors GLIS gene rearrangements, and it is the defining criteria for hyalinizing trabecular tumor. So there is a fusion with PAX8 GLIS3 commonly, or PAX8 GLIS1 gene, and it lacks RAS and BRAF mutations. Although the commercial antibody is not available, but some people have used in-house development of the antibody of GLIS3 and used for immunohistochemistry, which shows strong nuclear and cytoplasmic staining, which can be if there is availability of immunohistochemical markers, or even on cytology specimens, this GLIS3 rearrangement can be used to define this entity confidently. Because of its organoid features and the nuclear features, the differential diagnoses come into picture are paraganglioma, a papillary thyroid carcinoma, or a medullary thyroid carcinoma. And however, we can see that the HT tumors have a wavy trabeculae. They have other peculiar features like presence of those cytoplasmic globules, and sometimes hyalinization can be seen. A medullary thyroid carcinoma will have, again, it can have amyloid-like material, but then it will be positive for congruent, whereas it will be negative in the HTTs. They have more granular cytoplasm. In some of the earlier reports, there was an evidence of presence of RET-PTC1 gene rearrangement in HTT. And so earlier it was thought that there is some relation between HTT and PTC, but after that, no other studies have been shown. And even the GLIS3 rearrangement has not been shown in other tumors, and these tumors have not been found to recur or to metastasis yet. So in my last slide, this is just a summary to show the differential diagnosis of the capsulated, benign, the malignant, and the intermediate categories. At one end, we have the follicular adenoma here, and at the other end, we have the invasive encapsulated follicular variant of PTC. You can see that the category here is benign, low risk, growth-scan, and malignant. The PTC nuclear features is absent in this one, especially the follicular tumor. And then here, all these three entities show very pronounced nuclear features of papillary carcinoma. Invasion is present only in the malignant counterpart, whereas it is absent or questionable in these entities. Morphologically, the high-grade morphology is absent in all these lesions. RAS mutation may be present in all these lesions because they are follicular patterned and encapsulated with invasion or without invasion, but it varies ranging from 20 to 70%. The PAX8 and PPR gamma fusion also may be present, but even in a low percentage, that is less than 10 to almost 40%. BRAF V600E is almost absent in all these tumors, all these follicular pattern tumors. Therefore, it is said that the RAS mutation is one of the prototype of the molecular profile of these follicular patterned thyroid lesions. And sometimes these THADA fusions may be detected in like less than 10% up to 30% in some of these lesions. Thank you very much.
Any questions from audience?
Thank you, Dr. Iman. These are nice presentations.
What is the frequency of the in the large series?
Ma'am, it has been addressed point. Yeah.
I'm sure you may not. And is there reasons against you? You did say we of course there's a difference in Asia and the West. But the other
The uncertain malignant potential is 0.5 to 3%, but the difference between the Asians and the other population or the Western populations has not been given. The literature is just very low, 0.3 to 3%. Maybe once it has come into the WHO and people will start recognizing more and more or reporting more and more, then we can get it.
Dept also started coming there. Once the diagnosis came, I personally feel that there's been an overdiagnosis without appropriately applying all the criteria that are required for Dept. There have been some publications also in the Indian journals. So sometimes it's very hard to believe that kind of data, which show in Indian data also something like 10% of listing. So I don't know, now I think they are proposing certain quality control criteria. So what should be the proportion of Dept versus your total PTCs in the department and things like that?
Yeah.
Maybe it's all emerging, right?
Yeah.
Ma'am, can I ask? Actually, for NIFT-P, sometimes like we recently had a case of NIFT-P where the nodule was on the surface. So the surgeon said that at the moment I opened this, the nodule was out. Now the nodule had such a thin capsule. So does that really go into an IFTP? Because it says you should have an intact capsule. So in these kind of lesions, it becomes a little difficult to be sure whether what exactly the lesion is. And we put it into an IFTP.
I think we will need to gross the specimen more and examine more the main specimen and to exclude that if there are any other nodules in the main thyroid.
I would like to add a few notes regarding this entity. Actually, we did a study in which we compared the Dept incidence in Asia and the Western countries. And it was seen that this entity actually come into play after 2018. So before 2018, almost all the studies so far are retrospective studies. Prospective studies are not there. And it was seen that the studies which were done before 2018, they overestimated the percentage of Dept.
So it was ranging from 5% till 20-25% in some studies among the PPCs. And after 2018, with time, when the people got well versed with the diagnostic criteria, because the identifying the PPC features, the threshold for this also varies from person to person. So when the guideline got revised and less than 1% papilla was replaced with no papillae, the incidence came down. And in Asia, we have found that there is a marked difference in the incidence. Asia is somewhere around, when combined among all the study, only 2.5%. While in West it is ranging, in American and European countries, it is ranging from 10 to 15%.
One question which I had was regarding this 1% papillae business. How do you quantify, number one? And number two, in what percentage of cases of NIFT approximately do you encounter papillae at all? I asked this question also because there was one group which showed that if the tumor is BRAF B600D negative, then up to 10% of papilla do not impair the prognosis. So, what proportion of cases approximately you encounter papillae, NIFT cases?
Sir, the criteria given by WHO is very, very strict. It has to be either 0 to 1%. So that 10%, I don't know how it has come, but I can't give you data where it's almost absent or it's 0%. But many times it's very hard to find papillae in these depletions.
How frequently do you encounter papillae in NIFT? If anyone has sufficient experience?
It's very difficult. No, it's again in 2022, the less than 1% criterion has come back and it is there. Yes.
Calculate ka hai, or for a general pathologist like me, I think I would take this solution.
If you see even one small papilla of a size of a one follicle or two follicles, I think that is enough in a big tumor.
And when we are reporting thyroid, we see that there is a follicular architecture neoplasm and there is a compressed normal thyroid outside. And when we are following the capsule, we are following the capsule nicely and suddenly it disappears. And there is no invasion, we are seeing the neoplasm, we are seeing the compressed normal thyroid outside, and the capsule suddenly disappears. So, should we call it invasion? Should we call it questionable? Or what should we call it?
I think it's better you go and look back to your sample and gross more to find out if it is a multinodular or you can document invasion. So it's better to sample more.
Ma'am, but this question arises very frequently in our setting. We gross it again and again. But this question,
I think you can put it in UMP then, because that's why this criteria has come. If you can't put it in any other definitive category, you can put it in UMP and then just follow up the case.
Okay, thank you, Dr. Reshma. Nice presentation.
Thank you so much, ma'am, for such an informative talk. I now request our respective chairpersons to kindly present a memento to Neeraj, ma'am. Thank you, ma'am. I now request our chairpersons to please stay on stage while I call on request on stage to join Professor P.K. Agarwal, ma'am, Professor Pradyuman Singh, sir, and Professor U.S. Singh, sir, to kindly felicitate our chairpersons for this session.
ये बुढ़ापा है।
नीचे भी जा सकते हैं, हम लोग नीचे भी आ सकते हैं।
I request Professor P.K. Agarwal ma'am to please felicitate Arun Chaturvedi sir and Suresh Babu sir. Thank you, sir. I now request Professor P.K. Agarwal ma'am, Professor Pradyuman Singh sir, and Professor U.S. Singh sir to please take their seats and chair the next session. Our next talk is an online lecture by Dr. Andrei Baikov, Director Digital Pathology, Kamita Medical Center, Japan. He shall be talking to us about the reporting of thyroid cancer for clinical risk stratification. I request our chairperson to introduce our speaker.
Good afternoon, everyone. Thanks, organizers, for inviting us to chair this session. It's my pleasure to introduce Dr. Andrei Beshkov, who is an MD, PhD, and FRC PAT, and Director of Digital Pathology at Kamita Medical Center, Kamogawa, Japan. And he's a visiting associate professor at Nagasaki University. Dr. Andrei graduated from Russia, where he did his MD, has completed residency training and also practiced anatomic pathology. Later, he moved on to Japan and there he did PhD in molecular medicine in Nagasaki, Japan. And he has also supervised research projects in Thailand. His subspecialty is thyroid pathology, and he has major contributions and significant contributions to the WHO 2022 classification also of the endocrine and hematological lymphoid tumors. Dr. Beshkov is actively engaged in the projects of the Asian Working Group of Thyroid Pathology, which addresses differences between Asian and Western approaches to thyroid SMA and thyroid nodules immunity. Dr. Beshkov has completed Digital Pathology Certificate Program by the NSH EPA, and currently he is deeply involved in the development of Kamita Digital Pathology Network, which is one of the few Asian facilities successfully adopted digital pathology for and AI for the primary diagnosis of these patients. Dr. Andrei is a Deputy Director for Pathology Outlines, a very popular platform that you all use, Associate Director for JPPM and Front Med, and Academic Editor for several international journals like PLOS ONE, etc. He has published extensively and authored about 100 journal articles and book chapters. And he regularly presents at various international conferences and pathology meetings, including top-ranked events like USCAP, IAP, and IC, etc. And may I now invite Dr. Andrei for his presentation.
This presentation will be an online presentation. We could not have him this time physically with us. Possibly next time when we plan, he would be here to give a live lecture. So I'll be playing the lecture, and after we have we are having a recorded lecture so that there is no connectivity issue during the lecture. However, he is there online and present, and after the lecture he will be live for any discussion.
to so as a big hotel always there. Hello, thank you for having me today. It's been almost 40 years when I visited the last time, so I feel quite excited being with you. Congratulations. And of course, delighted to serve as a big hotel this event along with the well-recognized national level speakers. With some of whom we communicated in the Asia Ontario working group and even more successful research collaboration. The topic I decided to present today is the histopathological reporting of thyroid cancer for clinical risk stratification. Speaking about adverse outcomes of thyroid cancer, we usually keep in mind mortality, which is an opposite side of survival, but frequently overlook another clinical endpoint, which is a recurrence, particularly structural recurrence. Let us compare these two outcomes. Mortality is pretty rare event in differentiated thyroid cancer, while recurrence is much more frequent, approaching in some cohorts up to 40%. It may take decades from surgery to the end point to track that of disease. That's why mortality is a long-term outcome, which is good for patients, but sorry to say, bad for researchers. And all of us know that if we want to produce a good quality study on prognostic biomarkers of thyroid cancer, our cohort should have follow-up of 10 to 15 years, otherwise your viewers won't be happy. Mortality is a rather static variable, arguably, which is mainly assigned once at time of surgery, while prediction of structural recurrence is known at dynamic risk stratification and can be adjusted over the post-treatment course several times. Prediction of mortality is based on the well-known short-lived parameters, which are tumor size, presence of null and distant metastasis, and also age. On structural recurrence predicted by a long list of clinical and histopathology features. And as you have realized already, the key system or formula for predicting that of disease is AGCCTN staging system. While the main reference for predicting structural recurrence is the ATA, American Thyroid Association Risk of Structural Recurrence System, dated back in 2015, and soon to be updated. TNM definitions are well described in the AGCC cancer staging manual and also summarized in easy one. I wish to emphasize again that thyroid cancer is a unique malignancy, including age as part of TNM classification. You can clearly see that even patients with distant metastasis, but age less than 55 years, excellent 10-year disease-specific survival, 85 to 95%, therefore being assigned just stage 2. Structural recurrence or persistence is not a fun. It is frequently associated with radio-iodine refractoriness, a local spread, which may further lead to dissemination and even death of disease. Here is an example of one more patient from my cohort of radio-iodine refractory thyroid cancer collected in Bangkok, Thailand. She was operated with total thyroidectomy at age of 39, and over the next 15 years, she suffered from multiple neck recurrences. ADA 2015 risk of structural disease recurrence system was evolved from the 3Q 2009 edition, which included low, intermediate, and high-risk categories based on the combination of several tumor characteristics. 2015 editions provided more detailed breakup by multiple variables and associated risks estimated in %. These risk stratification systems appear
follow-up and post-operative treatment of the patients, including radioiodine inhalation and expanded surgery. If you take a closer look at the original risk chart, you may easily figure out that most of the variables essential for risk stratification, plus pathologies, have been calculated from our diagnosis and report. These include pathologies at the central stage as a contributor to decision making, and underscores the value of the detailed pathology report. For example, these are so-called iris features, which considered as an indication for completion thyroidectomy. They are not part of the TNM classification, but identified by a pathologist during histological examination of the first thyroid surgical specimen. The drive surgeon to make a completion thyroidectomy, and it could include clinicals, margin, and so on. There are multiple protocols for reporting of thyroid cancer, including national and international, and some are shown here, for example, American, British, Japanese, Japan. I won't be surprised if you have your own protocol in England. The payment protocol for thyroid surgical specimens is prepared by CAP, Collection American Pathologists, and I consider CAP protocol the best one, because it is synoptic, comprehensive, and regularly updated almost on an annual basis, I would say. Here is a list of mandatory items included in the CAP thyroid protocol. And next, I would like to briefly go with you through the key list and pathological parameters, one by one. Here is a list of procedures which produce surgical specimens for you. This includes lobectomy, hemipthyroidectomy, long-risk isthmus. Subtotal thyroidectomy is when just a small portion of uninvolved thyroid gland is left to preserve endocrine function. And total thyroidectomy, when entire gland is submitted including prosteral capsule. Another example is a conventional thyroidectomy. Thyroidectomy could be accompanied by neck dissection. Ultimately, the choice of procedure and how it is made is left to your surgeon. The same I would say about tumor sites on the thyroid, which could be right lobe, left lobe, isthmus, parietal lobe. Also, there are here is good to regular impacts indicated by a surgeon. Tumor fecality. Tumors could be unifocal and multifocal. We should remember that in multifocal cancers, the protocol is applicable to the dominant excised tumor, which is defined as the most aggressive tumor, not necessarily the largest tumor. Also, if the second tumor is clinically relevant, for example, pre-existing medullary carcinoma with failure, second report should be taken. Multiple foci, whether minute or large, EC or contralateral, can be either independent tumors or may result from intrathyroid spread of the index tumor, which is difficult to distinguish. Here is an example of the obvious intrathyroid spread, which I call C. And there is a less obvious case where contralateral tumor can be independent, which is difficult to prove without molecular instincts. Regarding tumor size, it's recommended to be reported on the greatest dimension and millimeters, also advocated by the WHO classification groups, while additional dimensions are optional. Graphic charts provided by clinicians or available in informing medical records are of great help sometimes. This is an example of such labeling approach routinely used in one-driven thyroid clinic. It's very helpful, especially in multilobular regions. Tumor and ATM risk stratification system has an important prognostic significance. For instance, papillary cancers less than 1 centimeter and more than 4 centimeters are associated with excellent and worse prognosis respectively. For follicular cancer, it's believed that size more than 3.5 centimeter has a worse prognosis. Average tumor size in Western practice is 10 centimeter. The number of sub-centimeter cancers is growing from 27% in the USA to 80% in Korea most recently because of the widespread ultrasound screening of thyroid. Next parameter is the histology type, and our main reference here is blue. I copied this table from our recent review paper in Endocrinology and Pathology. There was an excellent overview lecture today. If you want to venture into more details, but without being overwhelmed, I would definitely recommend our open access publication with tables, flow charts, and figures for easier understanding and guiding you. This diagram reminds you about the of surgical thyroid carcinoma specimens in July, with vast majority in PTC, papillary thyroid carcinoma, basically dominated by classic PTC and also sub-centimeter tumors. It is important to remember what subtypes of PTC are considered aggressive, and according to the WHO classification, the current edition, these are 4 variants which are dorsal, colonal cell, hotbed, and solid chemical. In the previous edition, we also had a diffuse sclerosing as an aggressive subtype. It was removed from the list of unaggressive subtypes in the current edition. And here I show the histological appearance of some representative aggressive PTC variants, such as dorsal variant with tram-track appearance, columnar PTC with stratification, multi-layer, and also epithelial, and whole-nailing in whole-layer type of PTC. Papillary microcarcinomas as in 1 centimeter, whether incidental, occult, or non-incidental, should be reported and requires the standalone protocol to be issued. A minor component with high grade, which should be insular, anaplastic, and aggressive histology, for example, minor toe cell component or whole component can be of significance and is not reported as an additional feature. Regarding thyroid tumors with undifferentiated component or anaplastic component, I use the following terminology. So, if the whole body of the tumor, there are less than 10% of anaplastic component, I call it as a main tumor, whether FTC or PTC, with anaplastic foci. If there is more than 10%, I would call it either pure ATC, if there is no coexisting differentiated thyroid carcinoma, or ATC, ex-BTC, is pre-existing BTC, differentiated thyroid carcinoma. Why I use this terminology? Because of publications reporting different survival in those groups in patients. Let's move on to margins, which could be labeled as positive, negative, or cannot be assessed. We also can optionally indicate site of invasion and distance from the closest margin in millimeters. Once again, just an option. You know very well, and definitely I have no doubt that you use ink to mark margins. This is not the case of my laboratory. Frankly speaking, I don't like inking because it's always going deep in tissues and creates some confusion. So what I do is just simply compare very well labeled grosses specimen and capture here with pathological specimen. One benefit I have here is that I'm using digital pathology system, and that's why I can review the histopathological specimens with very low power magnification, which is probably not available in your routine settings of your laboratory. And I can do a perfect matching between gross images of my specimen and histological specimen. And if here I have a positive margin, it can be easily recognized as posterior and reported to the surgeon just after the matching histology and gross images. Sometimes I use immunostaining to highlight those cells because, for example, here it's difficult to recognize what are those crush cells. Are these, red cell, or is probably some crush benign thyroid follicles? For those cases, I employ so-called thyroid cancer markers, such as CK19 or HbA1 or galectin-3. So, for example, is an immunostaining with CK19, which was helpful. And when I see with clinician who is asking me, I couldn't make this margin positive, just leave them approve and show up the slide with a positive stain at the margin. Tangent invasion or vascular invasion is also labeled as either present or absent, sometimes cannot be determined. Extent of invasion is considered to be just optionally reported as focal or extensive. Focal is less than 4 vessels, and extensive is 4 and more vessels. And you can find the scheme with what is positive vascular invasion or no vascular invasion in the CAT protocol, or actually original source, which is a flat lecture book on diagnostic histopathology of tumors. We should remember that only extensive vascular invasion, that means 4 and more foci, predict adverse outcome. And major invasion is quite relevant, which is found in less than 10% of encapsulated well-differentiated cancers. Once again, the clinical significance is association with distal metastasis, usually to bone, spine, and lungs. Angio invasion is mainly seen in encapsulated or previously encapsulated thyroid cancer, such as follicular carcinoma here, or encapsulated variant of biliary thyroid carcinoma. Also in previously encapsulated fully differentiated carcinoma. In PDC, we can see angio invasion of skeletal vessels in cases with extensive extrathyroidal extension, especially in parathyroidal soft tissue. I would not recommend, and I don't use additional stains like CD31, CD34, or mastone, or other elastic staining to detect angio invasion in typical or classic PDC silent tumor. It produces a lot of confusing results. It could detect some invasion or so-called invasion in small-sized vessels, which has no any clinical significance, and just create confusion when you produce the risk stratification report for clinician. It's also important to remember that areas of angio invasion that are closely adjacent to one another are counted as separate foci. Lymphatic invasion is also labeled as present or absent or cannot be determined. It is extremely common in BDC and can be identified by peritoneal foci seeds, small bodies, or indirectly by presence of low metastasis. By definition, clinical significance is an association with low metastasis and multi-locality. I put this set of questions here why. As for lymphatic invasion, I will express my opinion that searching for it in PDC is a tedious and unnecessary task, or in simple words, is a waste of time. I believe that lymphatic invasion is an essential feature of any unencapsulated PDC.
which is translated in a high rate of normal metastasis. Even after a careful search for lymphatic invasion, we always have a discordance between the rate of lymphatic invasion and lymph metastasis, such as frequently the rate of lymph metastasis is more than we could detect lymphatic invasion in the tumor. Also, there are many subjective issues related to the recognition of this parameter, such as the place to search, should be tumor model or inside the tumor, encapsulated, non-encapsulated, what criteria to use, as I mentioned, how to deal with the, shedded edit, So, to illustrate the lymphatic invasion, we always put a picture of diffuse sclerotic variant of the thyroid carcinoma or subtype. Now, of the subtype, lymphatic invasion is also a matter of subjectivity without significant clinical consequences. That's the matter. Extrathyroidal expansion is also labeled as presentation or cannot be determined. It's quite frequently then detected in one sort of thyroid cancer, and its clinical significance show an association with recurrence. Here is an example. If present, we should specify extent of EPE antigrowth, which means involving strap muscles and deeper into larynx via large vessel growth, or only microscopic or minimal extrathyroidal expansion inside the parathyroid fat. Gross extrathyroidal expansion, by definition, is identified by clinician, surgeon, on imaging, or during the surgery, or by pathologists or gross visualized controls. Minimal EP requires tumor to extend beyond the contour of the gland with a plasmaplastic response and region of parathyroidal adipose tissue. Alright, and here we move on lymph nodes, reporting lymph nodes. We need to provide the number of lymph nodes examined and involved, and nodal levels should be specified. Here we basically rely on the labeling provided by the surgeon. And number of nodes depends on type of neck dissection, which is originally performed at your institution. You know that lymph node metastases are extremely common in PTC, up to 58% cases, depending on the extent of the dissection and segment. According to the JCCPNM, identification of a submodule here in the cervical lymph node, even in the absence of associated malignant cells, meets the definition of pathology and malignancies. Adverse prognostic influence of lymph node metastasis in patients with differentiated carcinomas is observed mainly in the old age, and less prognostic significance in medullary than in medullary thyroid cancer. We also need to provide a size of the large metastatic deposit. Should keep in mind that if we have micrometastasis less than 2 millimeters, less than 5 in both nodes, they likely do not increase risk of recurrence. There is certainly confusion about how to measure the size of the metastatic deposit. Example is here. We have a lymph node with 1, 2, 3, 4, 5 foci, including one submodule. So some people measure just the largest. Some are everything together. The right answer is actually here. We need to measure the greatest dimension end to end from a single side, including these continuous tumor deposits. And this is the example. The last feature protein to reclose is the clinical report external extension. The most consistent diagnostic criteria is the involvement of perinodal adipose tissue. External extension is reported in up to 12% of PTC overall and 63% of nodal metastatic PTC, and definitely increases the risk of recurrence. Ultimately, after all these features scored, we need to provide the TPNM, pathology TNM, based on the TNM charts. And now I'm ready to issue my pathology report, which is looking quite comprehensive. And as you see, it includes AGCC staging and also APA risk stratification, each of my thyroid cancer diagnosis.
diagnosis. Which one will be more details? This case after lobectomy HACC staging with all the parameters of TNF, also supplied by the risk stratification. This case is a high risk recurrence. I provided percent as per the ADA table, and I also explained why is behind this high risk of recurrence. In this particular case, it's contributed by the right laryngeal nerve involvement and extraneural expansion. And this is another case with multifocal pituitary microcarcinoma, with intermediate risk of recurrence, provided based on all those stratification is the pathological parameters, and also supplied by percent, which inform decision for my education. So one thing I will be going to tell you is a recent ICCR project, International Collaboration in Cancer Body, they have a thyroid cancer checkup, which is also similarly reported similar to CAP protocol. I mean, the CAP protocol was used in the campaign. And there are two additional features which were not mentioned recently in the CAP protocol, but added in the last year, which is metabolic activity and tumor necrosis. As you could guess, they are relevant to the ossifying tumor as a high-grade carcinoma, which was covered in one of the talks today. My take-home messages for you. Risk stratification of thyroid cancer predicts recurrence and drives follow-up and treatment. Detailed pathological reporting is essential for the initial risk stratification of thyroid cancer. Reporting should be synoptic and standardized. The last one, very important thing, communication and mutual understanding between clinicians and pathologists is a key of success. If you want to refresh quickly on my talk, I will redirect you to the page of Pathology Alzheimer's website with all the information I provided today, supplied by the editors. Thank you for your attention, and I hope to meet with you during the Q&A session. Hello, thank you for having me.
Now we can take questions for sir. Please bring him online. Good afternoon, sir.
Hello.
I hope we are audible to you.
Yeah, I hope me too.
Yes, sir. Yes, sir. Thank you so much, sir, for being able to join us today. We were expecting you to be here offline, so if maybe in future we can have you live with us presenting. So there are certain questions. I'll pass on those questions to you.
Thank you.
Sure.
Nice presentation, nice material, very good.
Good afternoon, Dr. Andrew. It was very nice and like we all are enlightened. Next time we will invite you and hope that you will come to our center, KGMU Medical University, and we will welcome you. Today's lecture has been excellent. Thank you.
Is anyone one from the audience would like to ask any questions?
Thank you for your wonderful lecture. It was quite informative. I would like to ask one question. Since you are actively involved in AI and digital pathology, so you can throw some enlighten us about using this AI information or digital pathology medium to look for vascular invasion and or to predict vascular invasion in cases which are gray zones, and if there is a gray zone, that's a gray zone for most of us. So how does AI fit in there? And maybe if you can share something about your experiences with that.
Thank you. That's very interesting question. All right. So what can I tell you here? Yes, I'm involved in digital pathology and AI projects, but surprisingly, those are not related to the thyroid. And I can give you a brief overview of what is going on with AI in thyroid field. Basically, applications are much limited so far. And I think what we probably use most commonly is just a quantification of immunostains, such as Ki67, or sometimes we can use for membranous markers. Regarding the topic which you particularly highlighted, can we employ AI or whatever computational pathology algorithm to detect questionable features of the tumor? The answer is, if you want to create AI, robust AI, you need to define to do training on a well-defined set with a ground truth. And, you know, in the field of the questionable nuclear features or questionable capsular invasion, questionable vascular invasion, those cases cannot serve as a ground truth. And we still have a lot of observer variability in those gray zone areas. So far, I would say we have no any solution. I doubt that in near future we will have solution to render those issues. But whenever we come in with something, I would definitely share this with audience. So far, to sum up, applications of AI and computational pathology in thyroid pathology area is limited, and it's much more used in fields of imaging, such as radiology and ultrasound.
Thank you so much, sir. So there is one more question for you. Yes.
Yep.
She is Dr. Neeraj. She is head of the department of AIIMS, All India Institute of Medical Science, Rai Bareilly. So she wants to ask a question.
Good afternoon. I just want to know whether you avoid using ink only for thyroid or for other specimens as well.
Sorry, can you repeat again?
You said you avoid using ink. You don't use ink.
Oh, okay. Yeah, so let me be clear. This is just my approach. I found it, well, quite workable for my own laboratory. I would not say that I would recommend everyone, guys, please stop using ink. Because in our experience, yeah, it works, as with all other tumors, but it frequently leak inside the tissue, and sometimes different colors, they are mixed up together. So I figure out with approach which I'm using, and I just repeat again, what is my approach is to make the clear labeling of your gross specimen to identify where is the posterior, where is anterior, where is superior, and so on. And then I have an opportunity to match those gross image with my histological specimen on the low power using digital pathology. This is where digital pathology helps me. In your case, you can simply match, like, you know, you can bring the slide with a specimen in your hand and to match those. And I figure out, yeah, so it works for me. I no need to make inking. It's looking like 3D reconstruction, but I would definitely not consider this as a major recommendation for everyone. This is just an approach.
No, I agree with you that the ink penetrates sometimes in the tissues and may cause problem. But for me, my personal experience is that if we have an ink there, if you don't put an ink, actually sometimes very small, minute foci of tumors, which are at the edge of the section, they actually fall down while taking very thin sections. And then when the section breaks, it's very difficult to say whether it's positive or negative. So even if it penetrates, we have some amount of ink at the periphery. So that helps to say whether the margin is positive or negative.
I agree with you. Yeah, this definitely should be considered as a pitfall. And ultimately, it depends on the way how your laboratory meticulous in making grossing and how, let's say, process is standardized, and all people, they follow the same, the same approach. For example, in my lab, I have quite a limited load of thyroid surgical specimens, actually more than what you reported in your lecture. Maybe I have like 3-4 times more, but it still can be better just one by pathology expert, thyroid pathology expert. But if you have a load of specimens, in some thyroid clinics here in Japan, we have like up to 2,000 thyroid surgeries per year. And there are several doctors, of course, working on grossing of those specimens. And it's difficult to, to homogenize and to standardize everything. That's why, I agree with you. There could be pitfalls with this approach. Don't take it as my main take-home message for you. This is just to show different, variability in personal approach to the grossing.
Thank you so much, sir. Thank you so much for sharing all these important aspects with us. Thank you so much. Sir, Radhika Srinivasan ma'am from Chandigarh PGI. She also wants to ask a question.
Thank you so much, Dr. Enrique, and I think we learned a lot from your talk, and particularly how the final report that you showed, a lengthy synoptic report, that was, I think, really the take-home message for all of us who report on thyroid histopathology. My question to you is, are there any specific situations where you would wait to look at a molecular report, or would you wait for that to integrate that into your scientific reporting? Particularly when you're talking of risk stratification, there may be some situations where you would want to know whether it is, BRAF mutated, for example. You at least integrate it into your report, or you just sign off your histopath and then the molecular report is an independent report, or is it integrated? How are things done there? Over to you.
Thank you, Dr. Radhika. Well, what can I say here? I think that the utility of molecular testing is more applicable to cytology field, which means preoperative sampling, because figuring out whether cytologically indeterminate specimen is malignant based on molecular data, this makes more sense for the clinical decision making. But when the surgery is done, I don't think that molecular plays actually some major role in the follow-up of the patient. Sometimes it does, but we cannot compare to the importance of molecular testing in cytologic specimens. Well, frankly speaking, I'm still doing BRAF immunostaining for my surgical specimens, but this is probably because of my research bias. I want to use this for research projects. And I report those results to surgeon, to clinician as well. I don't think they are of much sense for them because the specimen is already removed, surgery is already done. If some, high-risk mutation is coming up in rather benign or low-grade looking tumor, that's probably make your sitting together with a clinician and discussing the case. And in that sense, I would probably highlight again my last takeaway point of my talk for everyone here. And I'm also glad to see that there are clinicians and surgeons in the audience. I believe that, all these complicated way of reporting thyroid specimens, using synoptic reporting and also referring to the risk stratification schemes. This actually makes sense only when clinicians understand what you are doing. I can give you one example. When I came to work in my current hospital and I started to report first couple of cases with the risk stratification, they came back to me, I'm a surgeon, and asked, "What is that? I never heard about that. I don't know how to use that." And here is our mission coming. We need to communicate together with all the multidisciplinary thyroid team and to find our way of how we make a report. Is it actually necessary for them to make this comprehensive synoptic reporting? Do we understand each other? even if clinicians say, I don't need this report because it's too complicated, I don't know what to do with them, then we just need to give a feedback, maybe give them some short talk, what is the importance of this risk stratification. They may not be aware of existing this risk stratification scheme, but now after 2-3 years working with my surgeons and clinicians, they are happy. And when another doctor, for example, part-time working with us, reporting thyroid specimen, without providing much detailed report, without providing a risk stratification assessment, like is it high-risk tumor or low-risk tumor. So they are asking, well, this is what we already missing. This is what we need to make in a strategy for the follow-up our patient. So that's why I believe that the last point of my takeaway messages was very important, and I would like to to convey this again to the whole audience here. Please communicate as a team with your clinicians. And surgeons and clinicians here in the audience, please keep in touch with your pathologists. Please keep talking the same language and keeping your updated the same, like what is going on this amazing course right now.
Thank you so much, sir. Thank you so much, sir. Thank you for joining us today. Thank you.
Thank you.
The next session we have is based on the unusual and interesting cases. I would request, since we are running a little late for the time, so I'll request the presenters to please come and to describe their cases a little bit briefly, I suppose.
I request Professor Ram Naval sir and Dr. Vandana Mishra ma'am to please come on stage and felicitate our chairpersons, Professor P.K. Agarwal ma'am, Professor Prajaman sir and Professor U.S. Singh sir.
पूरा मेरा ही है थायराइड से ये टॉनिक सेट करते हैं ये वाली है ना हां ये चीज भी लगी है इसमें बाकी कोई यूज भी नहीं मतलब फिर ना हो गया ये है ना ना ये नहीं है इसमें यूएसबी है आपकी ये यूएसबी लगी है मैं दूसरी लाऊं मैं आपको दी थी मैम यही तो नहीं मैंने आपको दे दी इसमें आपने कहा ये
I request Professor Ram Naval Rao sir and Dr. Vandana Mishra ma'am to please stay back on stage and share the next session. Interesting and unusual cases of thyroid pathology, and I'm grateful to our speakers for sharing with us these fascinating cases. I request speaker, Professor Deepa Rani ma'am, Professor at SN Medical College, Agra, to present her case.
Respected Chairperson, and good afternoon, everyone. First of all, I would like to thank Dr. Chanchal and team KGMU for providing me an opportunity to present this case. 22-year-old female presented with a diffuse thyroid swelling from last 3 years. It was firm in consistency, and there was only one complaint, that is heaviness in the neck region. Her serum thyroid profile was normal. This is the clinical pic of the patient. We can see there is diffuse thyroid swelling. And clinically, we thought it as Hashimoto's thyroiditis and secondly, hyperthyroidism. Contrast CT scan of the neck reveals diffusely enlarged heterogeneous thyroid parenchyma showing multiple small hyperdense calcific foci seen throughout the parenchyma. No definite adenopathy was noted. This is the axial view and this is the coronal view of the neck region. This is the trachea. And we can see there is diffuse enlargement of the thyroid. This is right lobe, this is left lobe, this is the isthmus. And we can see multiple calcific foci distributed throughout the thyroid parenchyma. Fine needle aspiration cytology was advised, and on aspiration, we found these small cellular aggregates as well as dispersed cells in a hemorrhagic and a small lymphocytic background. On high power view, we found that these cells have abundant basophilic cytoplasm in a background of lymphocytes. This is another view. We can see the similar cells having abundant basophilic cytoplasm and lymphocytic thyroiditis. So we thought it is Hashimoto's thyroiditis, but then we found these papillary aggregates as well as abundant of samoma bodies. This is another view. We can see papillary aggregate, abundant of samoma bodies and colloid. Thick colloid, which is referred to as chewing gum colloid, in a close vicinity to the papilla. These are the samoma bodies showing fine concentric lamellations in a close vicinity to this papilla. This is a high power view showing end on papilla and these cells having finely granular chromatin and intranuclear inclusion. So we thought it is papillary thyroid carcinoma. But then we thought which papillary thyroid carcinoma is diffuse. This is another view. We can see there's beautiful intranuclear inclusions. And these cells were catching eyes that these cells have abundant basophilic cytoplasm. Then we observed these cells carefully. Then we realized, oh, these are squamous metaplastic cells. These are not those oncocytic cells. And squamous metaplasia can be seen in papillary thyroid carcinoma. Now looking back to the previous pictures which we have seen, these are actually squamous metaplastic cells, no, not the oncocytic cells. Actually, oncocytic cells have basophilic granular cytoplasm, and we found these lymphocytes also. So the story does not end. We thought actually squamous metaplasia were seen throughout the slide. See, we can see so many pictures of squamous metaplastic cells in a dense lymphocytic background. Again, so beautiful squamous metaplastic cells in a dense lymphocytic background. So can any inferences from this? Anyone? So to summarize, we have young female patient, diffuse enlargement of the thyroid gland, marked lymphocytic infiltrate, tumor cells having papillary thyroid carcinoma-like features, innumerable samoma bodies, metaplastic squamous cells. So we thought it as diffuse sclerosing variant of papillary thyroid carcinoma. However, we did not found any evidence of sclerosis on FNAC. Clubbing all these features and looking at the clinical picture, radiological findings and FNAC findings, we have given the diagnosis as suggestion of diffuse sclerosing variant of papillary thyroid carcinoma. Histology was advised and gross specimen reveals this is the right lobe of the thyroid. This is the left lobe. Cut surface is grayish white. It was hard and gritty to cut, and even we can see knife lacerations on the cut surface. On histopathological examination, we can see there is diffuse sclerosis of the parenchyma, dividing these thyroid tumor nodules, and we can see these numerous samoma bodies on histology. This is another view. We can see normal thyroid tissue, tumor nodules, and dense lymphocytic infiltrate. This is the high power view. We can see lymphocytic infiltrate showing germinal. This is another view. We can see numerous papillary structures, samoma bodies. This is the low power view of the same. This is the high power view. We can see this nuclear crowding, overlapping, classical nuclear features of papillary thyroid carcinoma showing this ground glass chromatin grooving. In this pic, we can see squamous metaplasia and this classical nuclear clearing. This is another view to show squamous metaplasia and this nuclear grooving. In this pic, we can see there is normal thyroid tissue as well as this tumor nodules attached to the wall of the blood vessels. Actually, this tumor has a great tendency to spread within the thyroid. That's why it is diffuse. And normal thyroid tissue is also visible in the sections. This is another view. We can see tumor nodules attached to the wall of the blood vessels covered by endothelial cells. So on histopathology, our diagnosis was diffuse sclerosing variant of thyroid carcinoma, and immunohistochemistry is not required for the diagnosis of this, but as a protocol, we have applied immunohistochemistry also. Multiple lymph nodes were also received, and these lymph nodes shows metastasis of papillary thyroid carcinoma. This is the high-power view showing metastasis of papillary thyroid carcinoma with nuclear grooving and these abundant samoma bodies. So our diagnosis was diffuse sclerosing variant of papillary thyroid carcinoma. Papillary thyroid carcinoma has a number of well-recognized histological variants. Diffuse sclerosing variant comprises 0.1 to 4% of papillary thyroid carcinoma. Patients are relatively young, even when compared to the mean age for papillary thyroid carcinoma in general. Vast majority of patients are female, although conventional papillary carcinoma is also more common in female patients. Tumor is characterized by diffuse involvement of one or both lobes of the thyroid lobes, often accompanied by palpable lymphadenopathy of the cervical lymph nodes. Tumors are large and compression-related symptoms are common. Involvement of the entire gland is due to the striking proclivity for lymphovascular invasion. Gland is hard, cut surface is grayish-white, with whitish streak of fine reticulated gritty calcium material. Borders are irregular with extensive infiltration of the thyroid parenchyma. Extension into perithyroidal adipose connective tissue and skeletal muscle is common. Characteristic architecture seen in diffuse sclerosing variant can be solid, papillary or follicular. Massive number and diffuse distribution of samoma bodies is unique to this variant of papillary thyroid carcinoma. Squamous metaplasia can be seen in papillary carcinoma, but not to the extent that is identified in diffuse sclerosing variant. In fact, metastatic foci in lymph nodes often contain areas of squamous metaplasia. Lymph node metastases are seen in more than 80% of the patients. This is the IHC of the patient, which I received yesterday only. TTF1 was positive and CK19 was positive. Actually, it reflects the squamous metaplastic foci. CD31 was positive. We can see the tumor. These are the endothelial cells. Tumor attached to the wall of the blood vessel, and they are covered by endothelial cells. We did not perform RET or PTC rearrangement or BRAF mutation in our case. Differential diagnosis, most common differential diagnosis is Hashimoto's thyroiditis because there is diffuse involvement of the thyroid in both the lesions. Anti-thyroglobulin and antimicrosomal antibodies are present in Hashimoto's thyroiditis. They are also seen in 30% of cases of diffuse sclerosing variant of papillary thyroid carcinoma. But the difference is oncocytic cells are present in Hashimoto's thyroiditis while they are not seen in diffuse sclerosing variant of papillary thyroid carcinoma. This tumor has a pronounced vascular dissemination of neoplastic cell, so it raises the differential diagnosis of metastatic carcinoma to the thyroid gland. Metastasis of pulmonary adenocarcinoma, it can metastasize to the thyroid with papillary architecture. But here samoma bodies can be seen, but in diffuse sclerosing variant, there are innumerable samoma bodies. TTF1 is positive in both the lesions, while a heavy inflammatory response, dense fibrosis, and areas of squamous metaplasia are not seen in metastasis of pulmonary adenocarcinoma, while these features are seen in diffuse sclerosing variant, along with characteristic nuclear features of papillary thyroid carcinoma. Another differential diagnosis is mucoepidermoid carcinoma of the thyroid gland. In mucoepidermoid carcinoma, compact clusters of epidermoid cells and mucocytes are encircled by fibrous stroma. But in mucoepidermoid carcinoma, extensive intravascular invasion, samoma bodies, and lymph node metastases are lacking, while these are present in diffuse sclerosing variant. TTF1 is positive. Total thyroidectomy with bilateral lymph node dissection is advocated with or without radioactive iodine therapy. Although the tumor is biologically aggressive with extensive lymph node metastasis, the patient outcome is excellent. This is the report of our patient, which we followed after 2 years of her surgery. Her PT scan revealed there is increased radiotracer uptake in the thyroid gland. No other area of abnormal radiotracer uptake in the rest of the body noted. Actually, when this thyroid surgery is done, the remnants of thyroid are left there. Those uptake those radioactive iodine. So to conclude, final aspiration cytology findings helps in the correct preoperative diagnosis of diffuse sclerosing variant, leading to optimal preoperative management. requiring total thyroidectomy with lymph node dissection to achieve best long-term patient outcome. Take-home messages: it is neoplasm presenting in young female patient with signs and symptoms most suggestive of thyroiditis. Tumor involves both lobes in nearly all the cases and very extensive intravascular permeation by neoplastic cells. Combination of papillary architecture, squamous metaplasia, extensive seminoma bodies, and lymphocytic thyroiditis and diffuse sclerosis are the characteristic features of diffuse sclerosing variant of papillary thyroid carcinoma. However, after when the histology came, then we looked back previously our slides, we found few fibroblasts, scattered few fibroblasts in the cytology slides also. But before diagnosis, we could not find these fibroblasts. Nearly all patients have lymph node metastasis at presentation, requiring aggressive surgical management. So it is a more biologically aggressive than conventional papillary thyroid carcinoma. Although patient survival is not significantly different, patient experience an excellent long-term clinical outcome.
Thank you, ma'am. Thank you for this interesting presentation. We are running late, so we will be taking one question related to the case.
I'll quickly ask one question. Right, I sort of differ from the diagnosis in the sense that there are certain odds to it. First of all, the imaging is very classical of you leave aside the PTC area. It's very typical presentation of a thyroiditis, diffuse thyroiditis, maybe an autoimmune type. So then there are certain odds to the histology like absence of sclerosis.
So there was diffuse sclerosis throughout the thyroid. No, there was diffuse sclerosis. I said on cytology we could not found any evidence of sclerosis, but when we looked at the cytology slides again after histology, then we found few fibroblasts. Sir, there was diffuse sclerosis. I've shown the histology picture also.
So one difference that could be like a more common one. Why not think of multifocal?
Sir, yes. Okay, sir, in multifocal.
Low-grade presentation, low-grade disease, and this is a much more aggressive one, which requires much more aggressive treatment. And if you when you have followed up this patient for 2 years, it is still like a more limited,
yes, sir.
less aggressive treatment.
Sir, actually, the points against diffuse that multiple that you asked told key PTC. With squamous metaplasia was so diffuse, but it was present throughout the slide that we don't found in their PTC. And also the dense lymphocytic infiltrate, even germinal centers were forming in the slides. So these 2 points were against these multiple PTC, multinodular PTC.
Thank you, sir. Thank you. Please, I would invite the next speaker to present the case and request them to please be a little bit faster. You may present the entire case scenario and skip the discussion part. Okay. So possibly somebody have a question, then you can have it.
Good afternoon, everyone. Myself, Dr. Shaila Fias. I'll be discussing an interesting case of 49-year-old male who presented with anterior neck swelling for 2 years, which was painless and gradually increasing in size. It was associated with compressive symptoms like change in his voice since 3 months. On physical examination, a large irregular swelling which moved with deglutition was noted. It was not associated with cervical lymphadenopathy. On biochemical evaluation, thyroid function tests were normal. On radiological evaluation, CECT revealed heterogeneously massively enlarged bilateral lobes of thyroid, largest dimension measuring 11.5 centimeter with solid cystic changes. On PET-CT, heterogeneously enhancing soft tissue lesion, largest dimension measuring 14.2 centimeter, involving the anterior thyroid gland, encasing bilateral carotids, trachea, and esophagus without significant narrowing was noted. On final aspiration cytology, this is the Dimser stain, atypical cells along with presence of multinucleated cells with foamy cytoplasm. This is the ethnic stain. In this, we can appreciate nuclear features much better. It shows atypical cells with convoluted nuclear membrane and multinucleation along with inflammatory cells in the background. So based on cytomorphology, we made a probable diagnosis of granulomatous thyroiditis, and possible could be the differentials. Tuberculosis in this caseous caseating granule present along with AFP positivity. In sarcoidosis, there should be non-caseating granuloma, which are usually present in the interstitium. Thyroid primary. Sometimes thyroid tumor imitate the symptoms of subacute thyroiditis, so it can be taken as a differentials. Anaplastic lymphoma and poorly differentiated carcinomas. On conidal biopsy, sheets of atypical histiocytic cells with abundant pale eosinophilic cytoplasm, irregular elongated nuclei with prominent nuclear grouping, often known as coffin bean nuclei, fine chromatin, and indistinct nuclei were noted. On immunohistochemical analysis, it was CD1A positive, S100 positive, and CD68 positive, while it was negative for CK, PAX5, and CD21 to rule out our certain differentials. So based on histomorphology and immunohistochemical analysis, we made a diagnosis of Langerhans histiocytosis. On further evaluation, our patient developed skin lesions with due course of time, which on biopsy showed similar morphology. So earlier we were thinking about solitary Langerhans histiocytosis of thyroid, but with the development of this skin lesion, we concluded our diagnosis as Langerhans histiocytosis of thyroid with multi-system involvement. Our patient was treated with cytarabine-based chemotherapy and showed a significant response and is now being planned for a thyroidectomy. Thank you.
Any question from audience?
We can proceed with the next case.
I request Dr. Ruchita Sachan from RNL to please present a case with us.
Good afternoon. I am Dr. Ruchita Sachan, currently doing PDCC in oncopathology from Dr. Ram Manohar Lohia Institute of Medical Science. I am presenting a case of primary hyperthyroidism in an elderly female under the guidance of Dr. Nidhi Anand, additional professor. So, a 40-year-old female presented with chief complaint of body ache, pain in knee joint and fatigue since 2 years. Also, she was on medical treatment for chronic kidney disease for 2 years. Her blood investigation shows elevated level of serum calcium, parathyroid hormone, creatinine and urea, and serum level of sodium, potassium, vitamin D and thyroid profile were within normal range. Ultrasonography of neck showed a large hyperechoic lesion arising from the left parathyroid gland with size of 4.7 in maximum dimension with an internal echogenic strand and cystic area noted in posterior to the left lobe of thyroid. An MRI scan of the lumbosacral spine showed a hyperintense signal in bilateral iliac blade and head of the femur. So, on the basis of the clinical findings, diagnosis of primary parathyroidism with left inferior parathyroid adenoma was made. After this, inferior parathyroidectomy was performed, and intraoperatively the nodules was resected with difficulty. So, in our department, the specimen of parathyroid tissue was received with size of 4.5 into 2.5 into 2 centimeter in size with total weight of 11.9 grams. Cut surface was solid grayish white and outer surface was painted and entirely sectioned the tissue. So this is the microscopy of the case. Here we can see the sheets of the chief cell disposed in the lobule and separated by the thick fibrous septae. And the further high power view, we can see the tumor cells are disposed in the nests. Here we can see the capsular involvement by the tumor. Here this is the capsule and the tumor present outside the capsule. On further high power view, we can see the tumor cells are round to oval with abundant cytoplasm and frequent atypical mitosis were also seen. On next view, we can see the prominent macronucleoli. On further high power view, we can see the macronucleoli. Here we can see the vascular invasion. This is here is the capillary blood vessels, which is invaded by the tumor cells, and also tumor cells invading the adjacent adipose tissue and with positive resection margins. And these tumor cells were positive for chromogranin, GATA, and the CD34 highlight the vascular invasion. So on the basis of the histomorphology like capsular invasion, vascular invasion, macronucleoli, mitosis, and atypical bizarre cell, we made the diagnosis of the parathyroid carcinoma. So on follow-up and outcome, the serum PTH level was significantly reduced from 1574 to 876 picogram per ml immediately after the surgery, and next day its level was 290.5 picogram per ml, and about 1 week ago this serum PTH, her serum PTH level was 393 picogram per ml, and serum creatinine was 3.9 milligram per deciliter. So this signifies either patient have some residual disease or a recurrence of the disease. Thank you.
Finally, we have Dr. Jitendra Kumar from SGPGI presenting his case with us.
Good afternoon, respected teachers, seniors, and my colleagues. Myself, Dr. Jitendra PGI, presenting a case of 46-year-old female presented to SGPGI on 13th January 2023, referred to a nuclear medicine department from elsewhere. Diagnosis at presentation to PGI is follicular thyroid carcinoma with skeletal metastasis. Referred to endocrine surgery department. With chief complaint of patient was apparently asymptomatic till June 22. Then she developed low back pain radiating bilateral lower limb for 6 months, which was continuous in nature, increasing intensity since 2 months. Inability to walk 2 months. Chest pain for 1 month. Consulted at local physician and was found to have fracture right neck of femur. MRI reveals a diffuse hypointense lesion in multiple vertebral bodies and pelvic bone, likely metastasis. USG of neck reveals well-defined heterogeneous hypoic lesion, solid lesion, taller than wider in right lobe of thyroid, reported thyroid 4. Outside right thyroid nodule guided biopsy was performed, which was reported as follicular neoplasm. Bone scan saw the osteoclastic skeletal metastasis at bilateral shoulder joint, bilateral ribs, dorsolumbar vertebra, bilateral pelvic bone, and femurs. CCT neck and thorax reveals anterior mediastinal soft tissue enhancing mass, size about 6 into 4 centimeter. Diagnosed with follicular thyroid carcinoma with extensive skeletal metastasis. Presented to nuclear medicine department and referred to endosurgery for total thyroidectomy. Then we received one outside block for review. Outside reported as follicular neoplasm. This section shows from right lobe of thyroid. This tumor disposed in sheets, lobules, and adjacent area show the sclerosis along with the foci of the colloid filled thyroid follicles along with areas of hemorrhage. This is another high power view of for the same. Tumor cells are minimally anisomorphic, round to oval, central to eccentric nuclei, fine chromatin, and inconspicuous nucleoli, moderate amount of eosinophilic granular cytoplasm. This is another high power view showing the eccentric nuclei and fine chromatin, inconspicuous nuclei, and moderate amount of eosinophilic granular cytoplasm. On the basis of histomorphology, we kept the diagnosis of medullary carcinoma. To confirming it, we applied the calcitonin and synaptophysin. Calcitonin show the positivity in tumor cells, while synaptophysin has negative in tumors. so reported as the medullary carcinoma. Then in SGPGI, neck examination is done, where is a well-defined solitary firm nodule, right of midline measuring 2 into 1 centimeter moves with degglutination. There is no lymphadenopathy, and biopsy scar is present in mid-line of the thyroid, which was performed outside. Investigation at SGPGI, USG neck, right lobe saw 2 into 1.4 centimeter large hypoechoic lesion remaining at the right lobe with smooth margin and no calcification found around the lesion. Left lobe showed 1.6 into 1.3 centimeter spongiform nodule, reported at thyroid 1. There is no evidence of enlarged parathyroid glands. CECT of thorax reveals heterogeneous enhancing lesion in right lobe measuring 2 into 1.5 centimeter. And there is a heterogeneously enhancing anterior and mediastinal mass also noted, which was 5 into 7 into 9 centimeter. Then mediastinal mass biopsy was performed in SGPGI, and sections in the form of multiple core showing mediastinal mass with dense collagen tissue infiltrated by tumor cells disposed in nest interconnecting cord trabeculae and tubules. This is another high power view showing the tumor disposed in nests intersecting cords, trabeculae, tubules, and areas of myxoid degeneration. This is high power view showing the occasional mitotic figure and hemosiderin macrophages. We applied chromogranin and synaptophysin. Chromogranin came out positive, while synaptophysin is non-specific. CD56 and calcitonin are positive. Thyroglobin negative. Ki60 is approximate less than 1%, and TTF1 is also negative. So we reported as metastatic medullary thyroid carcinoma. In view of possibility of medullary thyroid carcinoma, patient was evaluated for multiple endocrine neoplasia 2. There is calcitonin and CEA level was normal, whereas PTH level is increased. On evaluation, calcitonin and CA level are elevated, PTH are increased. Then whole body DOTA neck PET is done. There is a non-tracer heterogeneous soft tissue lesion mass identified in interior mediastinal measuring 4.5 into 5.9 into 8 centimeter. Then technetium 99 MIBI image was performed, which is the uptake on the thyroid lesion. This is a parathyroid gland, and this is a thyroid gland showing the right lobe gland. Then non-tracerable anterior mediastinal mass. On evaluation of multiple endocrine neoplasia, 1, the pituitary, there is no biochemical or clinical feature suggesting the galactorrhea, headache, or double vision. Pancreas, there is no lesion are seen in pancreas. Then received 3 level container for frozen section. First is right level 3 cervical, and second is third level left cervical level, and third is a parathyroid adenoma. Right and left cervical lymph node are showing the reactive population. There is no evidence of malignancy, so reported as negative for malignancy. This is a parathyroid thyroid tissue showing the normal thyroid parenchyma along with the follicular thyroid adenoma, which is the composed of predominantly nest and acinar arrangement, interspersed with thin capillary adjacent areas show the unremarkable thyroid parenchyma. This is the high power view showing the monomorphic round to nuclei, evenly distributed chromatin, indistinct nucleoli, and scant amount of eosinophilic cytoplasm. There is no evidence of atypia or capsular invasion. To rule out the origin of the tumor, we apply the GATA3 and TTF1. GATA3 came out positive in parathyroid tissue, while TTF1 came out the thyroid tissue. So it is reported at the calcitonin and CA also are negative. So it is reported as intrathyroid. We received 3 specimens. First is labeled mediastinal mass, second is labeled as supraclavicular mass, and third is superior parathyroid. This is a anterior mediastinal mass showing the irregular flattened fatty tissue measuring 9 into 8 into 2 centimeters. Cut surface show the solid area with areas of hemorrhage. This is a scanner power view of anterior mediastinal mass showing the tumor cells infiltrated in the seeds and nest along with the areas of the myxoid degeneration. This is the high power view showing the stomach along with the congested blood vessels and myxoid degeneration. With areas of a few foci show the hemocyanin macrophages. This is a lymph node, supraclavicular lymph node showing the tumor cells which are similar morphology. This is a parathyroids showing the unremarkable histology. We applied chromogrammy and synaptophysin, which came out positive. Ki67 is proliferative index is about 30 to 35%. Secant TTF1 was negative. So we are reporting in the anterior mediastinal mass reported as neuroendocrine tumor grade 3. Left supraclavicular mass reported as metastatic neuroendocrine tumor. Left superior parathyroid unremarkable. On the basis of the histomorphology, the final diagnosis came on the view of the increased PTH level, parathyroid adenoma, and neuroendocrine tumor. The multiple endocrine neoplasia 2 is considered.
So, what do you take home message in this case?
Take home message this case, sir. Synaptophysin chromogram can be positive in thyroid origin cells and also in media few chromocytomas or carcinoid tumors. So can be misinterpreted that they positive in thyroid medullary carcinoma.
So the nasal parathyroid gland diagnosed as a medullary thyroid carcinoma. So sometimes misdiagnosed
yes
parathyroid gland as medullary tumors or medullary thyroid carcinoma.
Yes. Yes. Thank you.
Thank you, Dr. Jitendra. I now invite on stage Professor Manoj Jain sir to felicitate our chairpersons. I now invite you all to join us for lunch. And everybody is requested to please be back here by 3:15 since we are already running a little behind schedule. Thank you.
लंच टाइम 3:15 मतलब 3:15 2:25 बोला 3:50 बोला 3:50 बोला
ma'am, Professor, Department of Pathology, AIMS, New Delhi. She'll be talking about the grading system in thyroid neoplasm, significance of high-grade follicular cell-derived thyroid carcinoma. For this, I request Dr. Pooja Agarwal ma'am, Professor, Department of Pathology, SNMC Agra, and Dr. Kiranpreet Mehrotra, Professor, Department of Pathology, RML Lucknow, to please join us on the stage and chair the next session. I request Dr. Pooja Agarwal ma'am to introduce our speaker. Hello, Dr. Shikra. Are we audible to you?
Hi, Chantal. Nice to meet everybody.
We are not able to hear you.
You're not able to hear me? Just a minute. Can you hear me now?
Just a second.
Otherwise, I'll rejoin.
This is a recorded session. Are you able to hear us?
Yeah, very clearly. Can you
We're
hear
not
me?
able to hear your voice, Dr. Shukla. If you agree, can we play the recorded session and later we'll join with you?
Yeah, that's also fine with me.
Good afternoon, everybody. I am Dr. Shikha Agarwal from the Department of Pathology, AIMS New Delhi. And today I will be talking about grading system in thyroid neoplasms with the focus of the top high-grade follicular cell-derived thyroid carcinoma. At the outset, I'd like to thank the organizing committee, especially Dr. Chantal Ma'am, for the kind invitation. This is my disclaimer, and the data in this presentation has been compiled from my own experience and available literature, the authors of which have been duly acknowledged, and I do not have any discussions. In today's oncology research and therapy, precision medicine is the forerunner. So what does precision medicine mean? Well, it means each individual's cancer, even of the same histological type, is different from the other person's, thus needing individualized treatment. But precision medicine is nothing new. Its history dates back to 1914 when doctors from the Mayo Clinic demonstrated that life behaved differently when they had different needs. In case of thyroid, follicular cell-derived thyroid neoplasms have been very strong, and these have been broken into benign, low-risk neoplasms and malignant neoplasms. Each has been given a different behavior code of 0, 1, and 3, meaning WHO. In today's talk,
we will be focusing on the malignancies, or the primary malignancies of the thyroid gland, which have been listed here. When it comes to grading of cancers, it's based on three histological parameters, which include the cellular differentiation, nuclear polymorphism, the proliferative activity of the tumor, and the presence or absence of necrosis. Grading helps us in gauging the aggressiveness of a tumor. In thyroid, we look at the following parameters: cellular differentiation, proliferative activity, and necrosis. We'll come to the details soon. So, again, these are the various thyroid malignancies. Let's try grading them. So, the first four have been called the differentiated thyroid carcinomas. So, these are of the low grade. The high grade ones, that is, those which are follicular derived, these include polydifferentiated thyroid carcinoma and differentiated high grade thyroid carcinoma. In this, PDTC has been recognized for quite some time now, but DHGTC, or differentiated high grade thyroid carcinoma, has been recently included in WHO, and these two have been clubbed together to call FDCHG, so follicular derived carcinoma high grade. Anaplastic thyroid carcinoma is the highest grade and has a very poor outcome. Why do we need to group the thyroid carcinomas like this? So their 10-year disease-specific survival is highly different. So it's more than 90% for the differentiated thyroid carcinomas, 45 to 60% for the high-grade carcinomas, and less than 5% for anaplastic thyroid carcinomas. Coming to the focus of our talk today, follicular derived carcinomas, high grade. So these, as I told you, include the differentiated hybrid thyroid carcinoma and the polydifferentiated thyroid carcinoma. Well, why was the differentiated hybrid thyroid carcinoma included with PDTC? So let's see. This is a publication from 2021 in which clinical pathological and molecular features of papillary thyroid carcinoma with hybrid features were compared with differentiated thyroid carcinoma. Polydifferentiated thyroid carcinoma. And they found that PTC with hybrid features were more likely to have T4 disease, that is, involvement of essential leg structures, to show positive surgical margins, develop lymph node metastasis, as well as a poor disease-free survival at 2 and 5 years. In addition, they were more likely to harbor BRAF mutation than the PDTCs. Hence, the authors concluded that it is very essential to recognize PTCs having high-grade features, and these should be considered a distinct group from PDTCs. Another recent study in 2022 studied 364 cases of primary high-grade non-anaplastic thyroid carcinomas. So in this, they included PDTCs plus they included those cases of thyroid carcinomas which had high-grade features but did not meet the Turing criteria for diagnosing a case as PDTC. They come to the criteria later. What did they? They found that the disease-specific survival was similar. The PDTCs had a higher rate of radioactive iodine avidity and a higher frequency of RAS mutations. So, in their study, the survival was a bit similar. So, what they concluded is that the high-grade thyroid carcinoma should be kept as a single group, having distinct subtypes based on the tumor differentiation, and these should include PDTC and non-PDTC. So let's see a few cases as examples, so that you can understand the concept better. So this is a case of papillary thyroid carcinoma without any increased mitosis or necrosis and easily identifiable nuclear features. This is a case on the right side of a follicular thyroid carcinoma with evidence of capsular and vascular invasion, but again lacking a frequent mitosis, a high rate of mitosis or necrosis. Another case, a columnar subtype of PTC showing necrosis and a high mitotic rate. So, such cases, what do you call them? Well, you call them differentiated hybrid thyroid carcinomas. We come again, we talk about the criteria later, but it has been seen that these hybrid features are more common with certain subtypes of PTC, that is columnar, tall cell, and oblong cell PTCs. Another case, a case of follicular thyroid carcinoma, which showed extensive angio invasion, a high mitotic rate, and a high Ki-67 labeling index. Again, this is a case of differentiated hybrid thyroid carcinoma. So what is differentiated hybrid thyroid carcinoma? These are differentiated thyroid carcinomas which show invasive features, which show either a high mitosis amounting to more than or equal to 5 per 2 millimeter square, or tumor necrosis, or both these criteria. In addition, since they are called differentiated thyroid carcinoma, so they have to show a morphology or architecture similar to PTC, FTC, or thrombocytic carcinoma. What about this case? This is totally different from the previous ones. It doesn't show papillae, it doesn't show microfollicles, instead it shows a solid or an insular or a nested pattern with foci of central necrosis. Necrosis present in the center of the nests. There is a high mitotic rate and a high Ki-67 index. So unlike the previous cases, this is a case of poorly differentiated thyroid carcinoma, having an architecture which can be solid, trabecular, insular, having invasive features, nuclear features of PTC were absent, and one of the following criteria have to be present. So mitosis, minimum of 3 per 2 millimeter square, necrosis, or convoluted nuclear. So this is a table which shows differences and similarities between PTTC and differentiated hybrid thyroid carcinoma. So in both pattern in PTTC can be solid, trabecular, insular. In differentiated hybrid thyroid carcinoma, it can be papillary when it arises from PTC, follicular when from FTC, and solid when from oncocytic thyroid carcinoma. PTC-like mutant features are absent in PTTC, but are present when differentiated hybrid thyroid carcinomas arise from PTCs. The mitotic count cutoff is 3 per millimeter square in PTTC, it's 5 in case of differentiated hybrid thyroid carcinoma. PTTC, which is most of the code is intermediate between GTC and ATC. This is a panoramic view of the beautiful beach from the Andaman and Nicobar Islands. And look at this image, I wonder where should I look at the blue sky, or the plants, or the green trees, or the white sand, or these mountains at the back, or the sea, or the horizon. So even the microscope, we wonder where should we start the counting of mitosis from in case of thyroid carcinoma. Then the rule is hotspot counting. So you have to start counting in areas of highest proliferation. Many times students want to remain asking as to how to calculate the number of fields per millimeter square. Well, it's very simple. For this, you need to know the field number of the eyepiece and the magnification of the objective at which you are counting. So once you know these two, you can calculate the diameter of the field of vision, which is field number of the eyepiece divided by the magnification of the objective. Thus, the radius will be FOV divided by 2. The area can be calculated by the formula pi r square, and number of fields in 2 millimeter square will thus be 2 divided by the area. So let's take the example of my microscope. This is the field number, which is 26.5. So when I count at 40x objective, the diameter of my field of vision will be 26.5 divided by 40, which is 0.66. Radius will be 0.33. Area of the field will be 0.34 if we use the formula pi r square. Thus the number of fields will be 6 high-power fields. This table is based on the field diameter. So we can see when the field diameter is 0.66, that is the same as that of my microscope. The number of fields per millimeter square is 3. So 2 millimeter square, 6 high-power fields. Let's see the other parameter which we have to assess by grading. So necrosis. Remember, tumor necrosis can be global. Hence, adequate sampling of tumors is essential. Avoid grading on biopsy sample unless they show overt features of high-grade tumors. It's essential to differentiate tumor necrosis from infarction, which is especially common in oncocytic tumors. It cannot complete the lecture on grading of thyroid carcinoma if we are talking about anaplastic thyroid carcinoma. So this is the dedifferentiated thyroid carcinoma. As a result, there is a coexistent ETC or FTC or oncocytic carcinoma. You cannot diagnose it just from morphology.
It even lacks TTF1 expression. Taxate can be positive in a proportion. Yes, some labeling index is very high. It is usually more than 30% and can be as high as 50% and above. We talk about related thyroid carcinomas also. They constitute a small proportion of thyroid carcinomas, and again, they also need to be treated. So, low-grade NTC, when you use this term, when the mitosis is less than 5 millimeter scale, there is no necrosis, and the Ki-67 confidence index is less than 5%. A case is called as a high-grade NTC when any one of the following criteria are present. That is, a mitosis of more than or equal to 5 millimeter scale, necrosis is present, or a Ki-67 labeling index is 5% or above. So, any of these three criteria, we call it high-grade. So these high-grade NTCs are again associated with lower disease-specific survival and pregnancy survival. While counting the Ki-67 confidence index, again you have to be careful that you count it in areas of hotspots, and 500 to 2000 nuclei should be ideally counted. So this is a case from our archives. In the lower right edge of the HA section, you can see NTC, which was easily identifiable on morphology, while the upper left side, the tumor cells had very prominent nuclei and a very high index. So another case which looks like small cell carcinoma, which again had both high necrosis and high Ki-67 labeling index. Thus summarizing, grading of thyroid carcinomas was incorporated in the recent 2022 classification of thyroid tumors. It provides a prognostically relevant classification of thyroid carcinomas. It helps us in early identification of patients likely to have an aggressive clinical outcome, enabling closer follow-up and stricter treatment regimes. The grading is based on cellular differentiation, proliferative index, that is mitotic rate and Ki-67 labeling index, and necrosis. The salient points that need to be taken care of include adequate tumor sampling, calculation of the number of beads per millimeter square, per 2 millimeter square, with the area being calculated for your own microscope based on the field number of your eyepiece and the power of the object used. Look for hotspot areas with the started counting, and essentially, it's essential to differentiate tumor necrosis from infunctional and indirect necrosis. These are my various references. And I'm extremely grateful to my evaluator in this for providing us with a platform which helps us in doing each and every day value of the and thanks for the beautiful audience for being so patient with all the patients. Thank you very much. Have a very good day.
Can we have her on live, please?
Good afternoon, everyone.
Can you hear me now? Am I audible?
Yes, Dr.
Okay.
Yes.
Great.
Thank you for such a lovely talk.
Thank you for inviting me. Yeah. I'm sorry I could not join. Some professional commitments developed at the end moment, so I had to cancel. So
no problem.
I'm missing everything. I'm missing all the lunch and the tea and the snacks.
We would have loved to have you. She was initially planning to come here live only, but some exam and
duty came up. Yeah.
Yes, exam came up. So the house is now open for any questions.
Any questions from the audience? Dr. Shikha, this 2022 WHO classification, what is the exact recommendation? Does it recommend for mitosis to be counted per 2 millimeter square, or does it recommend per 10 hypertrophy?
Ma'am, it is 2 millimeter square, so that the change was brought about because
get our own objectives assessed and then see how many hypertrophies.
Yeah, so that's what we do it. Like on my microscope, it's 6 high power fields, and now in a routine, we are doing it in 2 millimeter square.
Hello. For the poorly differentiated ones, why is the cutoff different? And everywhere else, it is less than or more than 5 mitosis, and then it suddenly comes to less than 3. So any correlation, why is it kept different for poorly differentiated?
I think this is based mainly on the studies. So whatever studies have been there. So Turin proposal has been there for quite some time. It was there in the old. It was accepted by the previous WHO also. So in that the PDTC criteria was 3 per 2 millimeter square. That has been continued. But there were some studies, the ones which I quoted and previous ones, which showed that with a cutoff of 5 per 2 millimeter square, we are able to better characterize differentiated thyroid carcinomas. So I feel it's an evolving field. It may change, but as of now, this is what I have. And even WHO is a textbook. So it's based on the studies that we perform. And as Dr. Radhika very well said, that there's nothing from India. We all need to collaborate, bring out these cases and bring out what's there here. So we should have a large cohort of patients with available follow-up and see what cutoff do we get instead of following what's being prescribed by the Western data. But as of now, it's 5 per 2 millimeter square for the high-grade differentiated thyroid carcinoma, and we have to abide by it. So these are guidelines are inculcated following some research, some studies which have taken place. So that's what it is. In fact, WHO also says that we can use immunohistochemistry for phosphohistone protein 3, PHH3. But if you actually search the literature, PHH3 has been mainly evaluated in meningiomas and breast carcinomas. There is just one study on thyroid. And I attempted using PHH3 in our setup. So it is not very easy to standardize. And you have to keep on doing, even if it gets standardized once, you have to redo it for maybe after 1 month or 2 months. Again, it starts showing diffuse background. So I don't know how robust it is for long-term use. So I think these are initial guidelines, and they may evolve. Maybe mitosis won't get changed, but whether to use PHH3 as a marker of mitosis or not, that may change.
What is your experience with molecular markers in differentiating these entities? Are you routinely doing graphing C100D or not?
I didn't get the second question regarding molecular markers. Dr. Radhika very well covered it. And there is no one marker. So the problem is in thyroid. As even in the morning session, sir also said that thyroid is the most difficult to classify. And I totally agree, Dr. Rakesh Pandey, in that. So multiple markers are there, but nothing is absolute. And I think I'm very happy. I'm sorry. And I think I'm very happy that WHO has given histological criteria which are easily applicable in setup in resource poor settings also. So I think that's the good point about it. But yes, if you want to do molecular, as ma'am said, third promoter, then there is P53, then there is PIK3CA. So there are lots of molecular alterations, chromosome 1q loss. So there are lots of alterations which can be done. But if you ask me just one marker, there is none.
Are you reporting on BRAF and polydifferentiated polyclonals?
So we do BRAF. So PDTC usually do not show BRAF. High-grade differentiated thyroid carcinomas, if they have a PTC morphology, they show. So we do BRAF, yes, but not for all patients because it's not going to help the patient. First, the patient will have to undergo the patient will have to undergo a radioactive iodine therapy. If they are recalcitrant to radioactive iodine and the patient is sent back by the oncologist to us, asking for a BRAF mutation status, we do it. So we do it on demand because a BRAF doing on every patient on histopath is not required. We do it in situ if there's a diagnostic dilemma or if the patient is not amenable to thyroidectomy.
Thank you, Dr. Shikar. Any questions from the audience? I think then we'll put an end to this session. Thank you so much, Dr. Shikar.
Thank you, ma'am.
I now invite Dr. Radhika Srinivasan ma'am and Dr. Naren Krishnani sir to please felicitate our chairpersons, Dr. Pooja Agarwal ma'am and Dr. Kiran Preet ma'am.
I take this opportunity to announce that SNMC Agra is hosting UP chapter Pathcon this year. So I would request all of you to please register for the conference.
Now I request Dr. Radhika ma'am and Dr. Naren Krishnani sir to chair the next talk. For this session, we have with us Dr. Archana Gupta, Professor and Head, Department of Radiodiagnosis, SGPGI. She'll be speaking us about the importance of radiological findings in reporting a case of thyroid. I request Dr. Radhika ma'am to please introduce the speaker.
It's my honor to invite Dr. Archana Gupta. She is professor in radiodiagnosis at SGPGI. And she is well experienced in the field of radiodiagnosis, and presently she is president of TSI in UP, as well as she has a lot of publication on book on hepatobiliary and gastrointestinal imaging, and 12 book chapters and more than 100 publications. She has done a lot of courses, and she is training many of the DM and such students, and she is looking after the diploma students of the School of Internal Medicine and Biomedical Informatics. So I request Dr. Archana, please start.
Thank you, Dr. Krishnani, for such nice introduction. And firstly, I would like to thank the organizing team, especially Dr. Chanchal Rana, for inviting me here. She has given me the task of going for approach to the diagnosis of thyroid lesion, and basically on thyroids, and to define the thyroid nodule on its benignity and the malignancy. As the term thyroid nodule, it refers to the distinct lesion So the term thyroid nodule has been referred to a distinct lesion within the thyroid gland that is palpably or radiologically distinct from the surrounding thyroid parenchyma. On a population-based studies have demonstrated that prevalence of this clinically palpable thyroid nodule is 5 to 7% in the general population. However, when we do USG guided diagnosis, it increases up to 20 to 76%. A word about ultrasound evaluation of thyroid. The ultrasonography is a very safe, fast, cost-effective, easily available, and comfortable mode of imaging. A high-resolution probe is required that measures around 10 to 15 megahertz, which is used for the examination of thyroid. The patient should be lying supine, and the neck is slightly hyperextended. As such, the part of the thyroid which is extending into the anterior mediastinum should come out. A semi-erect position is also acceptable. The normal sonographic appearance of thyroid is homogeneous, and it's mildly hyperechoic as compared to the surrounding overlapping muscles. Each lobe of thyroid has a globular shape and smooth outlines. The individual lobes and their suspicious structures must be examined in both transverse and the longitudinal views. Isthmus is located at the anterior aspect between the two lobes, and it is anterior to the trachea. Two important features make it readily identifiable on the USG, that it is filled with air and the cartilaginous ring at the anterior aspect of the trachea, which produces curvilinear hyperechoic signals. So either side, the carotid arteries, which are located posterolaterally, and the internal jugular vein, which often collapses with the pressure of the probe. The muscular structures, that is the strap muscles and the sternocleidomastoid muscles, which overlaps the anterior aspect of the thyroid gland and have lower echo signal as related to the thyroid gland. The diagram shows the cross-sectional anatomy of the thyroid and the adjacent soft tissue structures, and that you can easily correlate it with the ultrasound image. This is ultrasound image of the neck at the region of the isthmus with right lobe and the left lobe. This is the trachea, which is filled with the air, and posterior laterally slightly towards left side is the esophagus, and these are the vessels, artery and vein. The overlapping strap muscles, they are slightly hypoechoic as compared to the thyroid gland itself. Thyroid gland is, this hole is thyroid gland. So you can clearly see this is more, in grayscale imaging, this is more whiter than the muscles surrounding, overlapping the thyroid gland itself. This is the transfer view of the right thyroid lobe. This is the trachea, and right side of the trachea is the right thyroid lobe. This is longitudinal view of the right thyroid lobe. So this is superior part and this is inferior part. About normal dimension, everybody knows the thyroid lobes are normally 4 to 6 centimeter in craniocaudal length and 1.3 to 1.8 centimeter in AP dimensions and transverse dimensions. Now, the most important is thyroid classifications. Thyroid's classification is used for classification or to show the benignity versus malignancy in the thyroid nodules. The high prevalence of thyroid nodules combined with the generally indolent growth of thyroid cancer present a challenge for optimal patient care. So the thyroid imaging reporting and data system, that is THYRAID, of the American College of Radiology was designed in 2017 with the intent to decrease the number of biopsies for the benign nodules and to improve overall diagnostic accuracy. Thyroid categories. The 5 ultrasound features has been taken for the thyroid classification or thyroid categories. That is composition of the nodule, the echogenicity of the nodule, shape, margins, and punctate echogenic foci within the nodules. And each item has been given points. The points are added for all categories and the thyroid level has been decided. The nodules which are smaller than 5 millimeter do not need any follow-up. This is because it is very unlikely that nodules smaller than 5 millimeter will be. The cutoff point of 2.5 centimeter for FNA is mildly suspicious. The thyroid 3 lesion is based on a study showed that thyroid carcinoma does not have a decreased survival until they reach the threshold level. The ACR thyroid categories has been shown to have good correlations with the malignancy risk in the large studies. This is how we take the thyroid classifications based on different categories and how the points has been given. I will go for this slide again once I will discuss individual point. However, there is few exceptions for the thyroids. There are several where this system cannot be used for. These are exceptions have a greater risk of thyroid cancers with otherwise normal adult populations. These are in case of children, FTG, PET, avid thyroid nodules, lymphadenopathy, and with known risk of thyroid malignancy like MEN type 2. So we will not go for thyroid in all these. So first, about composition of the nodules. For the composition, the nodule can be cystic, spongiform, mixed cystic solid, and solid. Here is an example of totally cystic nodule. This is the nodule which has been measured. Trachea, the left lobe, and this lesion is seen in the left lobe, which is totally anechoic or totally cystic with well-defined. There is no echoes are seen within the nodule. So it is a cyst, and it gives the point has been given in this 0. Second is spongiform. This lesion is spongiform lesions where nodulation, because it is sponge-like, very tiny cystic lesions are there. They cannot be differentiated on ultrasound. So the stratification appears to be seen here, and no clear-cut cyst like cyst seen in the first case. And in this case also, no further characterization is needed. Third is mixed solid and cystic. So this is totally different from the first and second case. Here, the cystic area is relatively large. They can be seen properly within the lesions. And the amount in solid and cystic part is not important. The lesion is given 1 point for the mixed solid cystic composition. A word about solid lesions. These are the two examples of two solid lesions. These solid nodules, at least 95% of the nodules should be solids, and the percentage should be an estimation. It is not needed to calculate in the 95% in this case. It's clearly visible. It's basically solid. The second category is echogenicity. So again, in echogenicity, we have anechoic, hyper to isoechoic, hypoechoic, or very hypoechoic. As I shown you in first few slides, the echogenicity of normal thyroid versus the anteriorly overlapping muscles. The muscles are more hypoechoic as compared to the thyroid gland itself. So you can compare isoechoic, the lesion, when the lesion is within the thyroid, and its echogenicity is quite similar to the thyroid itself. Hyperechoic when it is more echogenic, more vital than the thyroid gland, and hypoechoic when it is similar to the muscles overlying the thyroid gland, and very hypoechoic when they are less hypoechoic than the muscles itself. So this lesion is hyperechoic because this is the normal thyroid, and this is a lesion which is hyperechoic than the normal thyroid parenchyma. It is isoechoic as echogenicity is equal to the echogenicity of the normal thyroid gland. This is hypoechoic because this is the normal thyroid and the lesion is lesser echogenic than the thyroid gland itself. And here, because there is calcification in the anterior part of the lesion, so the lesion is not at all seen because of the calcification, the posterior acoustic shadowing is coming and the lesion is not adequately visualized in this particular plane. This is hypoechoic. This is very hypoechoic type of lesions, and tumor is more hypoechoic in comparison to the step muscles here. The step muscle is seen here. Here it is compressed, and normal thyroid parenchyma is here. So you can very well compare. This lesion is very hypoechoic. So this very hypoechoic lesion is given 0.3. Third category is shape. So all the lesions which are wider than taller, they are given 0 point, and taller than wide is given 3 points. A taller than wider shape is a strong predictor of malignancy, and therefore it gets 3 points. You have to keep in mind when you are just going to demonstrate taller than wider lesion or wider than taller lesion, the imaging should be, the probe should be in the transverse orientation. You should not keep it in a longitudinal position. So it should be assessed in the axial plane. The fourth category is margin. Margin is often assessed on the anterior side. Margin can be smooth or with extrathyroid extension. So smooth margin is, here the margin is smooth all around. So this here the point is given 0. Here the margins are imperceptible with the normal parenchyma. This is ill-defined nodule. Margin is here angulated. Angulation can be very well visualized. Here the margin is lobulated. In previous slide, this is also appears to be lobulated, but here the is imperceptible and lobulated margins. Here the thyroid points are 2. So the fifth category is echogenic foci. Echogenic foci, if there is non-echogenic foci or large common tail artifacts, they suggest benignity of the lesion and point is given 0. Macrocalcification has been given 1 point. The peripheral limb calcification 2 points and punctate echogenic foci given 3 points. So this is more suggestive of malignancy in the nodule. This is macrocalcification, chunk of calcification which has been given thyroid 0.1. This is an example of rim type of calcification, and that is because ring is broken at places, so that suggests there's incomplete ring and suggests more towards the malignancy of the lesion. Here, the microcalcifications are seen within the nodule. These punctate echogenic foci are also known as microcalcification, and they are a strong predictor of malignancy and therefore get 3 points. The ACI lexicon further defines this category because in the normal thyroid, there also may be echogenic foci visible, and they should be called in situation where they are obvious and only visible within the nodule. Small comet tail artifact with a length less than 1 millimeter are also included in this category, and this has been given 0.3. A word about growth of the lesion within time. More than 20% increase, equal or more than 20% increase in at least 2 nodule dimensions with a minimal increase of 2 millimeter or more than 50% increase or greater increase in volume is suggestive of going and growth of the lesion. If there are multiple nodules in thyroids, there should be no more than 4 nodules should be classified, and FLAC is not recommended for more than 2 nodules. In cases of multiple nodules, the nodule filling the thyroid FLAC criteria should be sampled. In this case, we should not go for the larger lesion, but where it is fitting in the thyroid classification to with the higher malignancy rate should be sampled. So here, in thyroid levels, with 0 point, no FNAC or follow-up is required. With 2 points, no FNAC or follow-up. With 3 points, thyroid 3 FNAC if the lesion is more than 2.5 centimeter. Follow-up if it is equal to 1.5 centimeter. No FNAC or follow-up if lesion is less than 1.5 centimeter. In 4 to 6 points, FNAC if it is 1.5 centimeter. Follow-up if less than 1 centimeter, no FNAC or follow-up if lesion is less than 1 centimeter. If it is equal to 1 centimeter, follow-up is required. In thyroid, if it is more than 6 point, FNAC routinely should be done. A word about benign and malignant thyroid nodule, just to revise the benignity versus malignancy. The features suggesting malignancy, the benignity is uniform halo around the nodule. Predominantly, lesion should be cystic or anechoic. There should be no vascularity around the lesion. The enlarged thyroid with multiple nodules should be taken as benign. However, a word about the vascularity or avascularity. The Doppler feature has not been counted in all these categories because the increased flow or increased Doppler flow arteries supplying the thyroid gland may be increased in cases of thyroiditis. So it has not been taken granted for this thyroid classification. The features suspicious of malignancies are microcalcification, extension beyond thyroid margin, cervical lymph node metastasis, taller than wider. This taller than wider lesion is most important. The less specific features are no halo around nodule, ill-defined or irregular margins, solid lesions with increased central vascularity. What about colloid nodules? It is hypo to isoechoic, may have internal cystic or heterogeneous changes because of the cystic degenerations and all, may have calcifications and may have inspissated colloid with large comet tail artifacts. Large comet tail artifacts are suggest benignity. What about follicular thyroid carcinoma? Adenoma versus carcinoma. The follicular thyroid adenoma is a commonly found benign neoplasm of the thyroid consisting of differentiated follicular cells. It cannot be differentiated from follicular carcinoma on cytologic sonographic or clinical features alone. So ultrasound features of follicular adenoma share many features with follicular carcinomas. They have thin peripheral halo, predominantly cystic or mixed cystic or solid. Isoechoic or predominantly anechoic, may be homogeneous or heterogeneous, and absence of internal flow or predominantly peripheral flow indicates reduced probability of thyroid follicular malignancy. I've been asked to specially include this slide for sonographic characteristic of follicular pattern tumor with papillary-like nuclear features. So if you go on all 3 different types of tumors. The grayscale ultrasound is not very much of differentiate. Just one or two things can be more in one or two tumors, but 100% you cannot differentiate histological tumors of these varieties with the sonographic appearance. A word about role of elastography, because everybody is now going for elastography in cases of breast and this liver and thyroid lesions. So, elastography just shows the resistance or the loss of elasticity or loss of fragility of the lesions within the gland. There are two types of elastography. That one is strain elastography and other is real-time shear wave elastography. So this we take a region of interest, and there is a specific application in the ultrasound. When you put this specification on thyroid lesions, then we can count the strain ratio cutoff. And when this is 2.32 or high, this is highly indicative, predictive of malignancy. And if Emax is more than or equal to 42.6 kPa, and the lesion depth should be more than the width of the lesion, then it's more suggestive of malignancy of the nodule. This is how the elastography looks like on the ultrasound. This is the thyroid gland, and when we put this applications, this looks like different colors comes green to blue, and if it lesion is more blue, then we take box here, ROI here, and that shows the strain. Role of computer tomography is basically just to show the extensions, lymph node involvements, invasion in the surrounding structures, and the absence of these features the absence of these features does not exclude any malignant tumors. So basically, the role of computer tomography or CT is just to see the locoregional spread and distant metastasis. It cannot tell you about the histopathological type of the lesions. Same with the MRI. Few people have showed the DWI, importance of DWI when the ADC value is low or high, indicative of infective pathologies versus. This is a sampled USG report. So we have to tell about the thyroid gland size of both the lobes, different their appearance. Then a large right thyroid lobe with like in this report, the right thyroid lobe is large with a lesion within insides. So we have to characterize this lesion based on the thyroids, and score should be given accordingly. Then you have to show the retrosternal extension. So we cannot go too much low in the anterior medial sternum. For that, we have to go for CT scan. Normal movement with swallowing should be shown, and the gland measurement should be given with the surrounding structures, whether they are intact or not, and efficient. So take-home messages: nodule is smaller than 5 mm, does not need any follow-up, and we should always go for ultrasound-guided FADC because in that case the yield is more. And the combination of grayscale imaging with sonoelastography can increase the prediction of malignancy and increases the yield during guided FADC. Thank you.
Thank you very much, Dr. Archana, for a very illuminating lecture. And I think something which is very much required for all pathology reporting on thyroid FADC, we have to be aware of it. I just thought I'd recollect my own, experience over the years. So of course there was a time when there was no hardly ultrasounds to be done. Everybody who walked in with a thyroid enlargement would be the first effort. FADC, many times used to be the initial investigation for a patient with a thyroid nodule. But then we slowly started getting reports, and sometimes we would advise please correlate to imaging. So the ultrasound would be done after the FADC. But now I think almost every patient who walks into the clinic where we do calibration-guided FADCs invariably has an ultrasound report with them. True. So it is so widespread the use of ultrasound, and next comes the proportion of our ultrasound-guided FADCs thyroid. So somewhere from starting way back, maybe even 10 years ago, it was somewhere around 10 to 20%. Because I remember
when I gave a talk, I compared the different TBS categories in the ones that we had done simply in the clinic, the palpation guided versus the ultrasound guided. And of course, the numbers of the malignant lesions were higher in the where we had done an ultrasound guided FNC. So at that time, this was, I'm telling you, in 2016 or something, 2015, 2016, the ratio was 80% for palpation guided, 20-25% for ultrasound guided. Today, almost I have seen a reversal of the issue. Almost everything is going to the extent that patient has a large nodule and then they still want an ultrasound guided FNC, which is, to us, the old timers, we get very irritated by that. To suppose people who got excellent material, and we feel that increases the yield. I would say not necessarily, because we were getting excellent material with palpation guided FNCs. But yes, I still remember that I had put up a slide way back some 6-7 years ago. Sorry, my comment is long. That what would be the indications for ultrasound guided, but I think at the moment maybe that slide itself is redundant. There would be many people who would say that if it's a thyroid FNC, let it be an ultrasound guided FNC. So I don't know whether in your institution everything 100% is ultrasound guided FNC. That's not quite the question, number one. Number two, even when you do an image guided FNC, there can be small differences in technique institution wise. Are there any recommendations for exactly what technique to follow? Because in the clinic, very important is to keep the neck in an extended position by holding the pillow. We always teach our residents and then do it quickly, because if you 1, 2, 3, 4, 5, you should be out. The longer the needle is sitting in the thyroid, it gets diluted by blood. But when we can't tell that to the radiologist, they won't listen to us. If there is a senior resident radiologist, tell him jaldi karo. He will take his own time to put the needle into the lesion. I mean, I know there are experts, consultants will do a great job.
Yeah, everything depends on the expertise of the person.
Yeah, and so you get all clotted smears, you get some 10 or 12 smears, you have to keep searching for material. Even in my institution, of course, that's because it's a training institute and people with different levels of competencies are giving guidance at the other end. And we, scold our resident, kya material laya, and they'll say, it's not my fault. The radiology SR kept on taking too much time. So should they do with the needle, with the stilette, should they do with an LP needle, should they do with a, just a 1.5 inch, should it be just sampling? Are there any guidelines for the technique? And I think that is a pressing issue. So something that together we need to work on that, and if there are, I'd like you to tell me about it. My third question is, sometimes we have the term hypodense. What is hypodense?
Ultrasound doesn't tell hypodense, it is hypoechoic or hyper. Yeah.
And I've seen on reports people writing this hypodense. And lastly, sorry, I just wanted to tell you even about this thyroids. 2015, 2016, I don't think even people in India were using any thyroids. You can tell us your experience. And when I did a talk, I remember it was the Koreans which actually came up with this kind of a reporting system.
Classification.
Okay, the Korean Thyroid Association, whatever they have. This was kind of developed further, maybe even made better. And the Americans are so good in globalizing any kind of recommendations that we caught up. And of course, in India, we always love what the Americans tell us and we pick it up. And I would tell my radiologist colleagues, please ये thyroids को बता दो. This was in 2015, 2016. And they say, नहीं, कुछ कभी देते हैं, कभी नहीं देते. It used to be like that. Now, even a peripheral center who does thyroid, they are putting thyroid 1, 2, 3, 4. Whether it is correct or wrong, I don't know. What is the accuracy of whether that has even been evaluated by radiologists. So these are some of my comments, and you can respond. And happy, of course, the audience also can ask questions.
Actually, the last question one, we are doing thyroids in all the thyroid lesions. With most of our colleagues, senior person are sitting here, the surgeons, the physicians, and the pathologists.
Now people are doing.
Yeah, because it came only in 2017 onwards, so we are using it. We are doing.
There was a time when nobody did.
Definitely, initially the ultrasound was not there, so people were using the manual palpation, they were doing FNAC. So now we are doing most of the cases ultrasound guided. 80% we are doing ultrasound guided where the small lesions are incidentaloma. Larger lesion you can do on palpation. Where the lesion is not adequately palpable, you cannot characterize, you should not do the FNAC without guidance. So we are doing smaller lesion, definitely we are doing, and as in this TARET classification also, when the lesions are multiple, we are not doing biopsies in more than 2, and where the TARET is definitely going towards malignant lesion. In that case, we are doing the lesions. Regarding the material can come in benign lesions also. It comes in both the lesion, even on palpation, on FNAC done on palpation. But whether it has been taken from right place or not, that I think here the role of ultrasound comes. So when we have available criteria and available recommendations, so why not to go for guided with TARETs and do the FNAC from the correct area, so we can have proper yield, and we can at the 1 or 2 needling, we can decide if we can differentiate the benign versus malignant lesions.
Secondly, I'll ask you about the technique.
We are using LP needles.
LP needles,
Yeah.
isn't it?
Yeah.
So that's what majority of the people
Yeah.
actually use. And you tell each residents you have to be very quick in the therapy.
Yeah, definitely. Anywhere also, either in liver and breast, everywhere we try to be quick. And FNAC is just
particularly thyroid, I'm telling you.
definitely.
And we get all diluted as
Definitely.
And actually the intracranial rate, the AUS rate, is higher not because it's not the question of interpretation. Many times it's all because it's trapped in a clot.
Definitely.
And it's so difficult to interpret those. So our rate, AUC rates, AUS rates have actually gone up. From what used to be 2% or so, we are moving around 6-7%. And that has paralleled the increasing use of ultrasound-guided FNAC because of these.
Just to increase the FNAC in benign lesions, just to decrease number of passes and total number of biopsies patients or FNACs patients, just to decrease the doing FNAC in benign lesions. TARET is very helpful.
But I would say in practice, even PR3 lesions, they're not following that rule.
That is in between, so most of the time,
PR3 comes and, it's. So if there are questions from the audience, sir.
How much time does it add to your reporting? Just that you have to do a TARET's report, then does it add significant amount of time to your report?
Definitely, sir. If you go maybe with expert hands and the senior resident working, junior resident will take sometimes 10-15 minutes, but the senior resident finish it off within 8 to 10 minutes.
I was just thinking about the private labs.
Definitely.
Because the results are often at variance with what we see on cytology.
Okay.
And second, is taller than wider business, it is percolating everywhere.
Definitely, sir. It is in breast also, it is in breast also, and this is very significant point.
And just wondering if the lesion is taller, it is more likely to be malignant rather than if it is broader, it seems a bit incomplex.
Taller than wider is malignant.
Yeah, either way, but just the access of the lesion itself is a predictor of malignancy versus benignincy. It seems a bit.
So this is very important feature.
It could be gravity-dependent extension of the lesion.
No, it is not like that.
What's the biological reason for this? That's what they want to know.
I think pathologists can better do.
And the other thing that bothers me.
Gravity dependent hota, so it should be anterior posterior view. We are taking it in a transverse orientation.
Last question by Indian everyone. Very quick one. Oh, you're asking, it's not a radiology related, so I'll answer you later in oral. Thank you.
The final recommendations are that we should do FNAC in all cases of therapy.
Not all cases. Not all cases. If it is 3 or more than 3, depending on the size of the lesion, if it is less than, preferably should be done guided.
But even then, we were doing a great job, sir, until a few years ago.
Ma'am. Not exactly, sir. If you are doing guided, you need not to do 4 or 5 aspirations.
But visual palpable are always better to do. So my question is whether we should go for all cases or not all cases for the FNC thyroid or not. When superficial palpable lesion is there, distinct lesion, then one should do because we get much better.
Doctor,
They would prefer that you do ultrasound guided FNC in all cases, but I think it's very different, slightly different in different institutions, different in the private setup also. I think, but the ratios are skewing towards guided FNCs.
And when he's saying whatever malignant lesion, you put the needle. If you're not taken out immediately, you'll get always clotted.
That is always everywhere, and especially in thyroid, that is true.
And keep on
My question is from the radiology. What is the type of the samples you are collecting for in FMSC, like this smear or cytogen takes of the body?
Actually, nowadays the practice is the pathologists are coming daily for the FNACs. We take the sample, they make the smears, whatever they want. That I can say. I think Dr. Gaurav is also here. You can make whatever you, how many slides you want to make, you can make.
I think that has been the practice in PGI Chandigarh for ever since inception. Our team is always there, and the radiologist gives the guidance. Once the needle is in, then it's over to the pathologist, and this works very well. Plus, madam, we also have a weekly radio cycle round, where practically every case, most of the cases that have undergone FNAC, or I would say, wherever there's a problem or interesting case, are all discussed. So, if there is a discrepancy between the thyroid score and our report, immediately it gets discussed, and then, of course, the next appropriate action is taken. So, it helps us where required. We can take for molecular, number one, in a second, molecular wire. And it is also possible, sir, if you're doing DNA-based assays, to do it on cytoscrapes. You can scrape the smear which has the maximum material. In indeterminate nodules, that paper which I showed you by Rojas, Gupta, and all of us today, we have used scrapes. So you can easily scrape the smear, you can get adequate DNA, so you know it is representative, you know it is cellular, and that can be subjected to these assays, VRAS, and all these assays we can do with heat-based, real-time PCR-based assays are there. So that is easy. We find that better than taking a direct sample, because we are not sure whether the data which is actually showing the atypical cells or not. No, sir.
Not required.
We don't use saccharinides at all. It's an NP needle with the stilette, but as soon as the stilette is taken, whoever is doing the performing the FNA has to be really quick to get good material. So it's again operator dependent. Thank you, sir.
Thank you. Thank you.
Thank you, ma'am. I now request our chairpersons to please felicitate Dr. Ashwini Gupta, ma'am.
Images were great, very nice. Enjoyed.
I just wanted to come in. As Dr. Andrew says, the clinician and pathologist should go together.
Yes,
so I
yes.
think we should keep one radiologist also.
Yeah, I agree.
In association also.
Yes, I agree.
Yeah.
You're absolutely right.
We should have the tumor boards and all.
Exactly. I think that point is very, very valid. Thank you, ma'am.
Now I humbly request Dr. Radhika ma'am to please felicitate Dr. Naren Krishnani, sir.
Yeah, thank you.
Now I would like to call Dr. Pooja Ramakant ma'am to please moderate the next session.
Good evening, everybody. So now, as the theme of the concept and the name suggests, endocrine pathology updates, so we have now surgeons and pathologists together for the next two sessions. So I invite Professor Anand Mishra sir, who is head of endocrine surgery department at KGMU, to chair the session, along with Madhumati Goel ma'am, who has been our ex-HOD pathology department, and at present she is director of pathology services at Medanta Hospitals, Lucknow.
So, a very good evening. It's my proud privilege to introduce the next speaker, and he is my mentor, teacher. I invite Professor Dr. Amit Agrawal, ex-HOD, Endocrine Surgery Department at Sanjay Gandhi PGI, and at present he is Director Endocrine Services, Medanta Hospital, Lucknow. Dr. Amit Agrawal.
A very good evening to all of you. I'm very happy to be here amongst the galaxy of pathologists. And for that, I'm particularly thankful to the departments of endocrine surgery and Department of Pathology at KGMU, particularly the head of the Department of Pathology, head of the Department of Endocrine Surgery, Dr. Chanchal, Dr. Bhalla. So the cytology is a very important investigation for thyroid surgeons because it impacts the extent of surgery and it helps to decide the surgeon whether the patient requires surgery at all or not. So I bring you greetings from my institution. I have no disclosures. We are all aware that thyroid nodules are quite common and most of them are benign, and only 5% of excised nodules are actually malignant. So it's a very small, minuscule percentage. The final aspiration, we all know, is a very reliable, very efficient means, and is considered the gold standard. And I think I should stop my talk here because we all know that FNAC is the gold standard. But having said that, there are certain limitations. What are the goals of FNAC? We need to identify those nodules which require surgery. We need to identify the nodules that are malignant so that we can decide the extent of surgery. And just to recapitulate, if it's a benign nodule, most would require a hemithyroidectomy. And if it's a malignant nodule, it requires a total thyroidectomy. And for papillary and medullary, we also do a central compartment dissection. So this is the kind of extent of surgery which the surgeon decides based on the cytology. It also helps to decide the high-risk variants. So there are certain variants of PTC which require an extended thyroidectomy, and you will help us to know preoperatively what is the variant that is present in a particular patient. And of course, if there are lateral lymph nodes, you would help us to decide whether the patient needs a lateral neck dissection or not. This is the common, the diagram which you are all aware of as surgeons. It tells you the percentage of malignancy in different categories of Bethesda and what are the recommendations. But I must tell you that these recommendations are not sacrosanct. These are just guidelines, and most surgeons do not follow these recommendations. And why, I will let you know in my subsequent talk. Now, coming to the benign category, although the series have reported malignancy from 0 to 3%, but if you look at the surgical series, the rates are almost from 6 to 14%. And the reason is that even if the nodule is benign, there are associated features which force the surgeon or which helps the surgeon to decide that the patient needs surgery despite the nodule being benign. There may be compressive features, the nodule may be too large, or there may be retrosternal extension. So these are the kind, or there may be, as Dr. Archana shared with you, there may be certain suspicious features on radiology which prompt the surgeon to decide that the patient needs surgery, even though that the nodule is benign. So that is why the percentage in surgical series would be higher. Just to take you through one of the cases, this was a 33-year-old female. She had a right solitary thyroid nodule, approximately 5 centimeters. Guided FNA was follicular neoplasm. TARADS 4 on ultrasound. Patient opted for total thyroidectomy. See, when we consult the patient, we tell there are 3 options. Either do a hemithyroidectomy, wait for the final histopathology, and depending on she may require a redo surgery. The second is an upfront total thyroidectomy. And the third option is to do a hemi, do a frozen, and then decide based on the frozen section whether to go in for an opposite side thyroidectomy or not. Anyway, the patient opted for a total thyroidectomy, and we did an open total thyroidectomy with frozen section. The histopathology, and this was the ultrasound of the patient, TARADS 4. And as we have been listening, even now the peripheral radiologists would report mostly in a TARADS format. And the final histopathology was a follicular adenoma, but there was some lymphocytic thyroiditis also. So this is how, the surgeon took a decision based on the size, based on the ultrasound features, and patient wishes are also very important. When we do consult, we take the patient wishes also in account. When we have Bethesda category 5 and 6, there's always some confusion, and most of the pathology literature will tell you that if you take both category 5 and 6 as cytologically positive, then this is the difference sensitivity and specificity. The specificity is very low, 30.9. But only if you take the category 6 as positive, then the specificity is 84%. So the bottom line is that the DC5 category is not highly reliable for diagnosis of malignancy. And when you exclude this category, then the diagnostic accuracy and the specificity increase. Different institutions follow different policy. Some consider 5 and 6 together, and some would consider separately. And so this is how it impacts the surgeon's decision for the extent of surgery. So this was a case where the cytopathologist really guided well. 20-year-old doctor presented with the left anterior neck swelling. It was small, 2 into 2 centimeters. I had operated on his father maybe 15 years back, but that was a benign histopathology. Ultrasound showed TARADS 5 in the left lobe, and there was another nodule in the right lobe, which is TARADS 4. And he also had approximately 2 centimeter level 2 lymph nodes, though the fatty hilum was preserved. The guided FNAC was suggestive of a papillary thyroid cancer, and therefore we decided to plan a total thyroidectomy along with the central compartment dissection under an intraoperative neuromonitoring. And we did a frozen section for the lateral lymph node as well, which was actually positive. And therefore we did a bilateral neck dissection, a central dissection, and a total thyroidectomy. We autotransplanted the inferior parathyroid gland after confirming the frozen section. The superior parathyroids were preserved. The histopathology was a multifocal PTC. So in this case, the pathologist really guided us well. They told it was a PTC. We took the help of frozen section for the lateral nodes. So we did a proper operation, which is a total thyroidectomy, a central dissection. The central dissection is important because that is the first basin where the PTC will go from thyroid to the central node. So we are very happy. The cytologist guided us very correctly. Now, there are certain limitations. We do have false negative cases. We do have false positive as well. So let us take false negative cases. Now, forget about the figures on the right side. I just took this table from one of the papers. So the false negative could be due to 2 broad factors, the specimen problem or due to interpretation error. So the specimen problem, the commonest cause of false negative is a microcarcinoma. And I'll come and illustrate this with another case. And the second important is presence of fibrosis. And thirdly, if you have a nodule in a patient who has a multinodular goiter. So papillary microcarcinoma and a multinodular goiter are really the 2 important factors which result in a false negative case. So this I told, a microcarcinoma is an important cause. And the other factor is these are details, I think I'll not bore you with the details. An interpretation error, the most common cause is the follicular variant or the follicular patterned lesions, as you like to call it, are an important cause of false negative. So I'll just illustrate a case of false negative, a case of multinodular goiter. He had a large STN, but on an ultrasound showed a dominant nodule. He had nodules in the opposite lobe as well. The FNAC was a colloid goiter, and we did a hemithyroidectomy. And this was the specimen, hemithyroidectomy specimen, which told us BRAF positive papillary thyroid cancer. And since the cytology was benign, we did just a hemithyroidectomy. But since it came as papillary thyroid cancer, and we like to do a total thyroidectomy because it facilitates a radioiodine treatment and follow up with thyroglobulin. So we counseled the patient regarding a completion thyroidectomy, and the patient underwent a completion thyroidectomy, though the left lobe was negative for malignancy. But as I mentioned, total thyroidectomy helps to follow up these patients with serum thyroglobulin, and it facilitates giving radioiodine to these patients. So though ATA recommends at less than 4 centimeters, you can go for hemi, but I prefer anything above 1 centimeter to go for a total thyroidectomy, but it facilitates a lot of things for our patients in this part of the world. Another case of false negative, there was a patient with solitary thyroid nodule, a large one, 10 into 8 centimeters. The guided FNA was Bethesda 3 category, and we did a hemithyroidectomy under neuromonitoring guidance, and the histopathology came as papillary thyroid cancer with evidence of lymphocytic thyroiditis, and therefore the patient underwent a completion thyroidectomy, and it was a multifocal. The opposite lobe also had it. So this case, we were misguided by the cytology, and we did a hemithyroidectomy, but we always counsel the patient that the final histopathology can be different from the cytology, so we need to be prepared for a completion thyroidectomy. There's another case of a papillary microcarcinoma, a 31-year-old radiologist who was initially diagnosed with Graves' disease, but there was a small nodule on ultrasound, and this nodule was, I think, TIRADS 4 on the imaging, and the guided FNAC was Bethesda 3. So in fact, her husband was also a radiologist. Both of them were really confused what we should do. And in presence of a TIRADS 4 small nodule, I suggested surgery for this patient. And the plan was a total thyroidectomy, and she had a small lateral lymph node. We did a frozen section, which was negative. And we did a total thyroidectomy, and the histopathology showed grooves, and it was a papillary thyroid cancer, but a very small focus of papillary thyroid cancer. I think the size was less than 1 centimeter, though she was BRAF positive. So the final stage was PT1A, multifocal, and N0. So papillary microcarcinoma can be missed on a cytology, but imaging can really help to guide the surgeon to take an appropriate decision. So even though she was negative, but because of TIRADS 4C, we opted for a thyroidectomy, and that was a total thyroidectomy in this case. As I mentioned, one of the important causes of false negative is a follicular variant of papillary thyroid cancer. This was a gentleman who had an MNG for 1 year with recent change in voice. The FNA was reported as Bethesda 4, and underwent total thyroidectomy with level 3 and level 6 lymph node negative and frozen section. And the final histopathology was a follicular variant of PTC. So I think it's very difficult to really diagnose a lot of follicular variants of PTCs on cytology, and this could be one important cause of false negative cases in these patients on cytology. Now, coming to false positive cases, again, you may have a specimen problem, and most important problem is thyroiditis, or again a papillary macrocarcinoma, and interpretation error could be there in cystic lesions and in presence of adenomatous hyperplasia and thyroiditis. So thyroiditis is really something which can confuse the cytologist in giving a proper preoperative cytological diagnosis. So hyperplastic, and I'm not going into details, but this is an important cause. Cystic nodules are also a cause of false positive, and interpretation error could be in presence of thyroiditis, especially post-COVID, as surgeons and as endocrinologists would agree with me. They've seen a lot of cases of thyroiditis, especially this post-COVID era. So this is a case, a 59-year-old lady who had a solitary thyroid nodule. On ultrasound, it was actually a MNG, so it was an impalpable nodule on the left side. And the ultrasound thyroid showed features of multinodular goiter. I don't remember her TIRADS. Yes, she was TIRADS 4 here. Both the lobes, she was TIRADS 4. She had her cytology done outside and we got it reviewed in our institution, and it was suggestive of papillary thyroid cancer. So we took up a patient for total thyroidectomy and a central compartment dissection, as would be classically done in a case of PTC. But unfortunately, so the final impression in the thyroidectomy was actually a follicular thyroid nodular disease. It was not papillary thyroid cancer, but there was a lot of lymphocytic thyroiditis. So I think the thyroiditis misled the cytopathologist in giving us the correct diagnosis. So it was kind of false positive. But patient had nodules in both lobes, so we did nothing wrong in offering a total thyroidectomy for this patient. Another case, this was a young person, I think he was from Bombay. He had a right solitary thyroid nodule. The left lobe was not he had multiple nodules in right lobe, which was thyroids 4. But interestingly, our radiologist picked up a very small hypoechoic nodule in the left lobe, 5 millimeters, which was actually thyroids 5. Now the patient had come for a surgery for a benign goiter, benign right-sided thyroid nodule. Now, in view of this, we counseled the patient and we told the possibility of harboring a malignancy in the opposite lobe, not in the large 3 centimeter nodule. So we did a guided FNA as well from the right-sided thyroid nodule, which was Bethesda 3. Of course, that small 5 millimeter nodule could not be aspirated. And so we did a total thyroidectomy and a central dissection. And the final histopathology was actually multifocal papillary thyroid cancer, BRAF positive, PT1A multifocal and 0. So in this patient, again, it was a kind of a false negative for this patient, but based on the thyroids, we took a decision for a total thyroidectomy and it turned out to be a papillary thyroid cancer. Now, 2 more important areas which I think the cytologist can impact the surgeon's decision for the extent of surgery is the variant of PTC. And I'd like to particularly talk about these 3 variants. These are the aggressive variants of the thyroid, the diffuse sclerosing variant, the tall cell variant, and the insular variant. And I'm sure you all agree with me, it's very challenging to get a preoperative cytological diagnosis in all these 3 situations. Now, that is important for surgeons because all these are aggressive malignancies and the surgeons would like to do a one-time full job like a total thyroidectomy or a central dissection or an extended thyroidectomy because the surgical cure is the only cure which we can offer to these patients. But unfortunately, the preoperative rate of positivity on cytology is very low in all these 3 situations. But I'm sure this is an area where cytopathologists would work and to get a better reporting on these 3 variants of thyroid cancer. The other area which is very important for the surgeon is the poorly differentiated thyroid cancer. Now, why it is important for the surgeons to know? Because these are very aggressive tumors, unlike the well-differentiated. These are large in size, they have more extrathyroidal extension, they have more lymph node metastasis, and they have more distant metastasis. Unlike a DTC, they would have almost 25 to 30% cases of metastasis. But more importantly, they are very locally invasive disease. For a surgeon, it's very difficult to decide whether a particular thyroid could be operable or inoperable. As you said, somebody is talking about a high-grade, well-differentiated thyroid cancer or a poor. It's very difficult to, but it's very important because if you have a preoperative diagnosis, then you can go for a different approach, And just to reiterate, more frequent extrathyroidal extension. And thyroidectomy is not easy in these cases and be very difficult to achieve an R0 resection because it will be invaded to the nerve, the larynx, the esophagus, the trachea. And sometimes they would require reoperative surgeries in 1 or 2 sittings. So for a surgeon, it's very important to know preoperatively whether they are dealing with PTC or they are dealing with a poorly differentiated thyroid cancer. And this is one of the projects which I did. We had 39 cases of poorly differentiated thyroid cancer, and you can see only 8 cases we had a preoperative diagnosis of PDTC, and the others we have a host of diagnoses ranging from PTC, the follicular neoplasm, even benign, the medullary as well. 1 case with the lymphocytic thyroiditis, 1 case with the inconclusive, and 3 cases were actually reoperative with a histopathological diagnosis of PDTC, FTC, and PTC. So the preoperative identification could facilitate the better initial patient management in many cases, namely more extensive surgery and early surgery rather than causing any delay. Those specific features of PTTC on cytology have not been defined, and but insular or solid architecture, hypercellularity, high NC ratio, and mitotic activity may suggest a diagnosis of PTTC in a thyroid. So, as surgeons, we would want better, sensitivity and specificity for high-grade thyroid cancers, whether they are actually PTC. Because if they are PTC, we would all like to go in and do a good job and remove the maybe a portion of larynx or esophagus or other structures. But if it is poorly differentiated, we would not venture in, because poorly differentiated, the results are not very good, and we might think of a neoadjuvant tyrosine kinase drugs to downstage the tumor and then operate on these patients to have a better R0 resection rather than just R1 or R2 resections. So we really need preoperative identification, whether it's PTTC or whether it's a high-grade PTC, to decide whether we need to go in and operate on these very aggressive thyroid cancers or not. So the take-home message is that the specimen problems are the main causes of false negative diagnosis, whereas interpretation error can lead to most of the false positive diagnosis. I should not be really, I took up this from a cytology paper, so it's pathologists telling the pathologist, not the surgeons telling the pathologist. The cytopathology should strengthen the criteria for identification of these situations, adenomatous hyperplasia, thyroiditis, and cystic lesions, to avoid a false positive diagnosis due to interpretation errors. And again, this is from a cytology paper. Somebody has emphasized 3 A's. This could prevent misinterpretations and enable better clinical management, aware of the limits of cytomorphology, awake to the presence of sheets and macrofollicles. I don't know what are these, and avoid downgrading nuclear atypia. So I think 3 A's would probably have a better sensitivity on your preoperative diagnosis. But as thyroid surgeons, I would recommend that we take the results of cytology and imaging, including elastography, before we take a decision on to operate on this patient and the extent of surgery. So I think a holistic view would help much better than just the cytology. Well, that's my last slide. Thank you very much for your kind attention. Happy to take any questions.
Yes, Dr. Neeti. Please give a mic. Since we are getting not many guided FNACs for thyroid, which we prefer, but we don't get the kind of information, the radiology information, which is also required to report cytology. So there have been instances where the radiologist has done the job, but we still don't know what the thyroid was.
Yeah.
And especially in the cases which are done outside, and there's a lot of pressure. And moreover, since in our institution we are not going to the radiology department to see, so the sensitivity of the FNACs is much more, it's more of comfort. So when you see that the needle has reached the lesion, which otherwise we are blind.
Of course.
We don't know where it's from thyroid, and that's all we can make out. And the other thing is that because of the issues in the sampling, the sample management, because of the things getting caught up in plots, and around 20 to 25 smears for each case. So perhaps that can also be a reason that there could be false negatives.
Yeah, we are talking only about 2%. 98% time you are right. We are just talking about those 2%.
2%.
Yes.
So even for the 98% also, at least 2 people see. But for that also, we make a lot many effort to get the radiology and also.
Yeah, so I think it's incumbent upon the clinicians to send you the full report of the radiology, yes. Of course. And now I think most of the. Yes, of course.
In these situations, we need the radiology, and then only we are comfortable to report the cytology.
Definitely, agreed, totally.
Still sample dilution will continue. So thank you for that very excellent coverage and a lot of learning from your own experience of false negative process, which is kind of similar to what we also see. We we don't claim that FNAC is 100% accurate, never, yes, we always have, and we try to keep it at a certain level. We are more scared about false positives than false negatives, actually. And at least there are instances sometimes in our institute, for example, if it is in category 5, then for a repeat FNAC. Unless you say it's category 6, I'm not going to operate. I mean, this is some of the surgeons, not all. But there are other surgeons who would go ahead and operate like that. I always feel in what Dr. Archana said is we really should start discussing these in tumor boards, where even in radiology there can be some degree of observer interpretational issues. So a specialist who does thyroid, if the surgeon, the cytopathologist and the radiologist sit together for a tumor board, do you think that would improve our approach, and improve our management?
Definitely, yeah.
At least a proportion of the false negatives we would avoid by simply doing the repeat FNAC. I'm really surprised about your experience of poorly differentiated thyroid cancer. So it has prompted me to go back and look into our own data. I'm really worried why so many of them were missed, because I somehow always had it in my mind that was something very easy to diagnose. But I think I take your point that there can be discrepancies, difficulties, and we must be assigning a lot to category 4. The only thing is about this FVPTC, you put it into false negative, what we call it as category 4, and it turned out FVPTC. So at least in my reports, in a lot of them, if it is category 4, I add a line that the differential diagnosis includes follicular neoplasm, in bracket follicular adenoma/carcinoma, because cytology cannot demonstrate invasion, and also FVPTC. But this is a big concern. Our false negative rates will depend on, particularly this category is a very important.
Very important.
We cannot do better than calling it a code. So sometimes we upgrade it. So this FVPTC can be either category 4, category 5, or sometimes when everything is very well developed, then it can also go into category 6. So that will remain a problem area. And I think it's important for surgeons to understand that when we call it a category 4, it could also include an FVPTC.
Yeah, definitely. I think that is the area where molecular markers really can help. The RAS mutation is more likely to be a follicular lesion. But if you get a BRAF, no, RAS means goes on follicular, yeah. But if you get BRAF, it helps you to decide it could be, yeah. And the category 5, I think most people don't use and condemn frozen section, but I think frozen section is a very good investigation. Category 5 lesion. There you can actually get to know, yes, it's PTC. Because somehow the cytology has not really said it is 6, but it has given 5. But frozen will really help you a lot in these situations.
Microcarcinomas, less than a centimeter, and according to what madam's thing was, they should not have been subjected to it. But they're still subjected. So we might have missed some, but we have got some as well.
Definitely.
And frozen will not help in microcarcinoma.
No, it will not. Yeah, it will not.
My question is that when to go for biopsy? Needle biopsy.
You mean incisional biopsy?
No,
True cut.
Because we are getting a lot of needle biopsy.
True cut, you mean? Yes. Yeah, so there are only few situations. One is anaplastic carcinoma. The other is lymphoma. You have a patient who has a rapidly enlarging goiter or a recent increase in size. Those are the indicators towards the patient having developed a malignant change. No, 5, I said you 5, you take in a 5 helps you to decide patient needs surgery. You do a frozen section, it helps you to decide whether you need to do a total or a hemi. So biopsy, I don't think there's any role in category 5. In PTC, there's no role except poorly differentiated where the biopsy can really help. Because cytological diagnosis of PTTC is still very challenging. And most institutions will not report a very high rate of PTTC. Their high-grade PTC, PTTC, and anaplastic sometimes very difficult to differentiate. So a biopsy helps in that.
I'd like to add that if you have just one FNAC anaplastic cancer or anaplastic lenses, now there is a differential diagnosis of lymphoma. Lymphoma is totally treatable disease, while anaplastic is not a treatable disease. And for lymphoma, you need a biopsy. So in that situation, when FNAC or clinical scenario or FNAC suggests an anaplastic line,
then biopsy is must in that situation.
But we have give a diagnosis of thyroid lymphoma cases.
Yes.
Particularly if you combine it with low cytopenia.
Yes.
I agree, and nowadays, sir, in such cases, we always have a cell block to our rescue. So the days are gone when FNAC was just 2 years. So we definitely
Give cell blocks.
Yeah, we can on record many cases of thyroid lymphoma. So sometimes we go back and take a special second pass for both cell block and whenever we suspect, we have the slightest suspicion for a lymphoma. So high-grade lymphomas we do prefer cell blocks, and if it is low-grade, of course, which borders on hydroxyperonetis, then flow cytometry can help. Where it doesn't help, definitely we have morning and for biopsy.
And usually anaplastic carcinomas are not confused with lymphomas in cytology, mostly.
Mostly, yeah.
With this, thank you, sir.
Thank you. Thank you very much.
I request the chairpersons to kindly felicitate Amit Agarwal, sir. So this is a very interesting memento you see.
Really?
It's very unique and very peculiar of Lucknow. They have drawn a thyroid on a chicken piece of paper. Chicken work has made thyroid image. Thank you, Amit sir. Thank you, Madhumati Goel ma'am and Anand sir. So now next we have the most exciting session, which is for the residents have been waiting a lot since morning, and that is a very competitive session. I invite the chairpersons, Professor Gaurav Agarwal sir, who is head of Endocrine Surgery Department at SDPGI, ex-CMS, and he has been ex-president of Breast Surgical International Society, and our teacher, obviously. So, sir, we are very honored to have you. Please come on the stage. Along with Professor Naren Krishnani, sir, Professor in Pathology Department at SDPGI, and Manoj Jain, sir. And sir, please. He's also Professor in Pathology Department. So the rules are there are 4 teams, 2 from SDPGI and 2 from KGMU. And they have, each team has 15 minutes. And there are 2 judges who are unbiased from institutions apart from KGMU and SDPGI. So chairpersons will be initiating the discussion. 5 minutes, the endocrine surgery resident presents, 5-minute pathology resident present, and 5 minutes discussion, which is led by the chairpersons. Audience may be listening it, and then 15 minutes they have to finish on time. In the validatory function at the end of the session, we shall be announcing the winners. So I request the chairpersons to begin with first 2 teams from SDPGI. So please call your resident.
I think that the first case will be presented from SDPGI. The team from Endocrine Surgery from Dr. William and from Pathology from Dr. William. Those will be presenting 2 cases of thyroid. So, over to you.
Thank you, sir. Good afternoon, everyone. For our first case, we will be presenting a case of a 53-year lady who presented with the chief complaints of tremors, weight loss, despite good appetite for 3 months. There was no history of diarrhea, heat intolerance, increased sweating, palpitations, or anxiety. No history of any anterior neck swelling. She was diagnosed to have hyperthyroidism by her local doctor and started appropriately on tablet propranolol and carbimazole. There were no other comorbidities and no significant family history. On general physical examination, she was found to be overweight with a BMI of 26.38 kgs per meter square. She had hyperpigmentation over the interscapular area, which was initially thought to be cutaneous lichen amyloidosis, but was appropriately evaluated and found to be a fungal infection and treated appropriately. There were no eye signs and fine tremors were present. Her systemic examination was within normal limits. On examination of the neck, there was a solitary swelling non-tender, firm, well-defined, moving with deglutition in the right lobe, measuring 3 centimeters in its largest dimensions. The lower border was palpable and the trachea was shifted to the left. So we made a clinical diagnosis of a right solitary thyroid nodule in hyperthyroid state, possibly a right autonomously functioning thyroid nodule. On investigations, she was found elevated T3 and T4 levels and a suppressed TSH level. Her TRAb was also elevated. On ultrasound, there was a 3.6 centimeters well-defined heterogeneously hypoechoic lesion with increased vascularity and calcific foci within arising from the right pole of the thyroid, a TIRADS 4 lesion, and a well-defined 6.5 millimeter lesion in the left lobe, a TIRADS 2 lesion. We went ahead with the technetium 99 per technetate scan, which was suggestive of a diffuse toxic goiter with a cold nodule at the lower pole of the thyroid lobe. Her FNAC and cell block and IHC are up for discussion.
Good afternoon, everyone. For this case, first, a USG-guided FNA was performed from the nodule in the right lobe of thyroid. So these are the FNA smears. This is a low power smear where we can see that the smears were cellular, and they showed these disc of follicular epithelial follicular cells having showing moderate and isonucleosis, fine granular chromatin, inconspicuous nucleoli, and abundant amount of eosinophilic granular cytoplasm. So, on the basis of this morphology, the FNA was reported as suspicious for malignancy and a possibility of medullary thyroid carcinoma was given. Further, cell block was also prepared from the FNA. However, it showed predominantly hemorrhage and only a small focus of cells were identified, which showed the central to eccentrically placed nuclei with abundant cytoplasm, and an inconclusive report was given for the same.
So based on this FNAC report, we went ahead and evaluated the patient further, and the patient was found to have normal serum calcitonin and CEA levels. We also evaluated the patient for other syndromic association related to MTC. Her serum calcium levels were normal, and her 24-hour fractionated urinary metanephrine and normetanephrine levels were also normal. Prior to surgery, her thyroid function tests were normal. So we made a diagnosis of Graves' disease with a cold nodule, possibly MTC. The treatment options were discussed with the patient and relatives, and we planned the patient for a robotic total thyroidectomy via BABA approach. At surgery, there were multiple nodules in the right lobe, the largest measuring 3.5 centimeters in the inferior pole of the right lobe. The left lobe had a calcific nodule. There were no obvious lymphadenopathy. On cut section, there were multiple nodules in the right lobe with pale fleshy appearance and central scarring and calcification, largest measuring 3.5 centimeters in the inferior pole. The final histopathology is up for discussion.
So for the histopathological examination, we received the right lobe, left lobe, as well as the pyramidal lobe separately. So this is the gross image. The right lobe of thyroid was also received in the 3 separate pieces. One of the tissue showed a fleshy nodule which measured 3.5 into 3 into 2 centimeters. This is the cut, and here we have the cut surface of the left lobe, no definite nodule was identified in the left lobe of thyroid. This is a scanner view of from the nodule in the right lobe of thyroid. Here we can see that we have a tumor which is arranged in a weak nodular pattern and an uneven capsule around it. At places, there were areas of sclerosis in between the tumor cells, and we had these groups of tumor nodules present and some foci of calcification in these sclerotic areas. On high power view, we can see that these tumor cells show they are disposed in follicular arrangement in closely packed follicles. Further high power view, we can appreciate the morphology of the cells. We have these cells showing minimal and minimal and isonucleosis having a vesicular to fine granular cytoplasm, prominent nucleoli, and an abundant granular cytoplasm. And at places, we could also identify these calcific foci in between the follicular lumen. Here also we have this focus of calcification. And here in this image, we could see that the capsule is that these tumor cells are invading the capsule. And here also these tumor cells are almost merging with the adjacent thyroid parenchyma. This is the photomicrograph from the other representative photomicrograph from the other part of the right lobe of thyroid, which showed these variable sized thyroid follicles lined by locupoidal epithelial cells, and occasional lymphoid aggregates were noted. This is a representative photomicrograph from the left lobe of thyroid and from the pyramidal lobe. Since the cytopathology was reported as suspicious for medullary thyroid, calcitonin immunohistochemistry, but it showed a non-specific diffuse positivity, which was interpreted as negative. Further, CEA was also applied, which was negative. A diagnosis of an oncocytic carcinoma of thyroid, minimally invasive, in the right lobe was rendered.
Post-operative course was uneventful. She had no symptomatic or biochemical hypocalcemia. She was subsequently discharged on post-operative day 6 after removal of the drain. On follow-up, her 3-month follow-up calcitonin levels were normal, and we further planned to evaluate this patient with stimulated TG-ATG levels and a whole body radioactive iodine scan.
You expect the questions only to be from the moderators. So firstly, the question to surgeon here. Would you like to explain why in a patient who had hyperthyroidism is still being went ahead and did a FNAC here? What was the expectation or what was the intention why we did an FNAC on this thyroid nodule?
So the patient had a cold nodule on thyroid scan, and a cold thyroid nodule on a scan is indicative of there is a risk of malignancy in that. So which is why we went ahead with an FNAC for this patient.
That risk for malignancy higher than usual?
Yes.
That is what you're expecting. Yes. Then the follow-up question to the pathologist is, what morphological features raise the suspicion of this being a medullary question?
Sir, the dispersive clusters of cell having a plasmacytoid-like morphology with an eccentrically placed nuclei. So that led towards a suspicion of medullary.
Can I ask from the audience what was the opinion of the audience on cytology? Was there any discrepancy? Because ultimately it did not turn out. So based on cytology, it was earlier diagnosed as medullary suspicion. And everything was against us. Like CEA and the calcitonin, everything was wrong. So can we think of hypothesis that based on this?
Look like medullary carcinoma.
Another way, what you see oncocytic cells in cytology. So what will be different? Because they have to be different from parathyroid cells as well as medullary carcinoma sometimes and oncocytic variant obviously shows. So there are certain changes in cytology which need to be differentiated. Granular.
Some cells were large, similar looking cells. In between, some large cells were also there, so it was hard. Both variant medullary carcinoma.
My question to the surgeon said, when we diagnosed it as medullary carcinoma, there was no lymphadenopathy. So is it possible with the size of the thyroid nodule, there should not be any lymphedema?
There should be some, yes.
Second point is that if there was a link, why you have not searched for lymph nodes?
So we have searched for lymph nodes, and at surgery, I had mentioned that there was no obvious lymphadenopathy. At surgery and on imaging, so.
Patient was hyperthyroid. So medullary will be, I think, very important in that area.
So the question is that how often do we see coexistent medullary carcinoma in a patient with Graves' disease?
So there are in literature, there are about 11 to 14 papers that have been published about patients with hyperthyroid state with medullary thyroid carcinoma. So it is in literature, but it's rare. And these are all case reports.
And so then how often you can see the normal calcitonin and medullary thyroid carcinoma, because calcitonin must have been there.
So in literature, there was a case series, a retrospective study by Frank Roux et al., and it has about 800 plus cases. And in their study, they've shown about the percentage of non-secretory MTC is only 0.83%.
Again, my question is that suppose it's a serum calcitonin is high, so CEA is more important. In that case, you will never see normal CEA with that. So in these kind of cases, both the things should be done simultaneously. And that is why you will definitely be sure before surgery that we are not dealing with medullary. So that is the important thing that we have to do in the case.
But still, someone will see the cytology, will report again medullary thyroid carcinoma. That's what Dr. G is saying.
Well, cytology was not confirmatory of medullary, but it suggests that possibility. And that's why serum calcitonin and CA were done. But do we, as a treating team, do we do serum calcitonin as a routine in all patients, or do we do it selectively?
We would selectively do it, sir. And after this FNAC report is when we did a serum calcitonin level.
CA as well,
Yes.
both were normal.
Yes, sir.
So in this scenario where both calcitonin and serum calcitonin and serum CA are not raised, this is what you call the non-secretory medullary carcinoma. And as you said, there have been just a very handful of cases reported. So taking from there, the surgeon did not suspect this to be or did not agree to this diagnosis of medullary. This seemed more like either a follicular carcinoma within Graves' disease or something else, or just a benign nodule. And perhaps that was the reason why the patient was counseled for a minimal access surgery rather than a conventional local surgical procedure. And she was keen on minimal access, no scar in the neck kind of surgery, and she underwent robotic bilateral axillary breast approach prototype. Absence of raised serum calcitonin and CA, absence of any lymphadenopathy, these are all factors which suggested that there's something wrong with the diagnosis of medullary. Is that so?
Yes, sir.
And that impacted our decision for managing the patient the way we did. Unfortunately, now that we know this is an oncocytic carcinoma, minimally invasive. Sorry, before I come to that, question to the pathologist.
So the time is up, so I think we'll wrap it up.
Okay, wrap it up now. But last question to you is, but you said the rest of the thyroid parenchyma was unremarkable. This patient had Graves' disease. Do you expect some pathology?
Sir, occasional lymphoid follicles were there, but no other features of any lymphocytic thyroiditis.
Well, most of the time we expect primary thyroid hyperplasia to be evident on thyroid.
No features of
There were none. Well, that of course, that's the nodule which turned out to be oncocytic carcinoma.
Yeah, so that was a small subcentimetric 6.5 mm nodule in the left lobe.
Yeah. Okay, so the time is up. Do we go to the next case from the same team, or we?
Yes, sir, we go. Just
You can present your next case.
Our second case is of a 30-year gentleman who presented with the chief complaints of a swelling below the jaw for 3 years and initially small, gradually progressed to its present size. There was no history of hoarseness of voice, dyspnea, dysphagia, no symptoms of hyper or hypothyroidism, no other swellings anywhere in the body, and no history of any lesions in the oral cavity, scalp, or ear, nose, throat. He had gave history of betel nut chewing, pan, and tobacco chewing for the past 14 years. On treatment history, he was evaluated outside and an FNAC of the submental lymph node was done, which was suggestive of metastatic papillary thyroid carcinoma. On local examination of the neck, there was a well-defined vertically oval-shaped swellings noted in the anterior aspect of the neck, measuring 3 into 3 centimeters in the submental region, 3 into 3 centimeters in the left level 2, 4 into 3 centimeters in the left level 5, and a 1 centimeter swelling in the upper right paratracheal region. It was the overlying skin was normal. There were no scars, dilated veins, or pulsations. There was no thyromegaly. The trachea was central. His general examination was within normal limits. Scalp and oral cavity examination was within normal limits. On investigations, he was admitted and underwent an FNAC from the submental and cervical lymph nodes, which is up for discussion.
So for this, we first did a US guided FNA from the submental and left level 4 cervical lymph nodes. So this is a local view of the FNA smears. So here we can see that these smears are cellular, and we have these papilloid-like fronts and these clusters of epithelial cells, where we can see that the nuclei are enlarged and they show nuclear overlapping. However, definite nuclear features of PTC were not identified in the cytology smear, so it was reported as positive for malignant cells with a possibility of metastatic papillary thyroid carcinoma.
With this FNAC diagnosis, we made a plan that if the ultrasound shows a thyroid lesion, we would submit the patient to a total thyroidectomy with a CCLND and MRND. And if the ultrasound does not show a thyroid lesion, we would do a lymph node biopsy. So on ultrasound, there was no thyroid lesion, the thyroid was normal, and there were multiple enlarged cystic lymph nodes. A CT scan was done, which also showed multiple heterogeneous lymph nodes with internal cystic areas, and there was no thyroid lesion. So we did a left level 5 lymph node excision, and this is up for discussion.
So we received 5 lymph nodes from the left level 5 cervical region. So this is a scan of a view of one of the lymph nodes, which showed a completely effaced architecture and infiltrated by this tumor, which is arranged in this papillary configuration with intervening fibrovascular septum. However, we can appreciate the morphology of the cells where we have nuclear overlapping, fine chromatin and showing nuclear clearing at places. And at other areas, nuclear grooving was also seen. These are the representative photomicrographs from the other lymph nodes, which did not show any tumor deposit. So, a diagnosis of metastatic papillary thyroid carcinoma in 1 out of 5 lymph nodes was given for the left level 5 lymph nodes.
With this histopathological report, we made a diagnosis of occult PTC with cervical lymph node metastasis, and we planned the patient for a total thyroidectomy with CCLND and bilateral MRND. At surgery, as you can see in the image, the bilateral lobes were normal in size of the thyroid. There were multiple enlarged blue-black cystic central compartment lymph nodes and bilateral cervical lymph nodes. There were multiple superficial cervical lymph nodal masses in the submental region and another over the right strap muscle. On cut section, there was a vague brown firm nodule in the right low pole of the thyroid, and the left lobe was unremarkable. The final histopathology is up for discussion.
So next we received a total thyroidectomy with central compartment lymph nodes, left SLND, right SLND and submental lymph nodes separately. So this is a gross photograph of the total thyroidectomy with the CCLND specimen. Grossly, both the lobes revealed normal thyroid parenchyma. From the left SLND specimen, multiple matted lymph nodes were identified, and here we have a largest lymph node which measured 2.5 into 2 centimeters. So this multiple sections were taken from the right lobe and later the specimen was entirely submitted. This is a representative photomicrograph from the right lobe, which shows a normal thyroid architecture. This is a representative photomicrograph from the left lobe. And from the isthmus, where we can see these benign thyroid follicles. Isthmus additionally showed 2 lymph nodes also. This is a photomicrograph from one of the lymph nodes from the CCLND specimen, where again we can see the tumor infiltrating in the lymph node with a small lymphoid tissue at the periphery. Here we can see these papillary architecture lined by these tumor cells. This is a photomicrograph from left SLND lymph nodes, showing with a similar morphology. Here we have these arborizing papillae and as well as areas of calcification. Now this is a photomicrograph from the submen's lymphoid tissue here, and then we have a tumor arranged in this papilloid architecture. Another photograph from the submental lymph node, where we can see this tumor deposit along with this lymph node at the periphery. This is a representative photomicrograph from the right SLND specimen. So there was no evidence of any malignancy in the total thyroid lymph node, whereas 1 out of the 7 lymph nodes from the central compartment showed metastatic PTC, and from the submental and the left SLND lymph nodes also showed metastasis, whereas the right SLND, all 30 lymph nodes were inactive.
Post-operatively, the patient developed chyle leak on post-op day 2 and was managed conservatively. His drain was removed on post-op day 7 and discharged in a stable condition on post-op day 8 with suppressive doses of thyroxine. Post-discharge, his whole body radioactive iodine scan, thyroglobulin levels were elevated, it was 58, and his ATG was 12.9. His scan showed an uptake in the thyroid bed and was ablated using 30 millicurie of radioactive iodine.
So, in the research report, we had 3 steps in diagnosis for this patient. I mean, psychological and histological wise. Why did we need to do a level 5 excisional excisional biopsy of the level 5 lymph nodes? Why could we not straight away proceed from, based on the psychological diagnosis to definitive surgical treatment?
So we wanted to rule out if the origin of these metastases was really from the thyroid or not. Because sometimes the small salivary glands can also have papillary cancer, which is why we had planned for a lymph node excision.
But then these kind of metastatic nodes that we're looking at, large cystic nodes, they are quite pathognomonic of papillary thyroid cancer. What was so unusual that prompted you to do this extra step in diagnosis?
So this patient actually presented with a submental lymph node initially. And that is not the usual presentation of any thyroid or thyroid-related malignancy, because metastasis to the submental lymph node is rare.
Level 1.
Yes.
Level 1 and level 2A are not usually sites for metastasis. And then a question to the pathologist, with the papillary histomorphology, what other sites come to your mind, or what would you like to rule out before labeling it as papillary thyroid cancer?
Papillary carcinoma of the breast, but again the location won't be common for the submental.
But in this patient, none of these were considered. Why?
So the histomorphology, the nuclear features were very characteristic of papillary thyroid.
Did you find sufficient colloid?
Colloid was not.
No. Any other features that might have prompted pathologists not to consider other sites?
So
these nuclear features were very characteristic of the nuclear person. But usually in metastatic, we see aggressive subtypes. Also, those are more common in metastatic. This was less in this type of person, not close. Oh, do we see the thyroid, there is no malignancy of the in there?
Often we find occult metastatic papillary.
So it is rare, but it is present and it does present with skip metastasis. But in this case, what surprised us was that the thyroid showed it was unremarkable on the histopathology. It wasn't occult even, it was unremarkable. So
In literature, how often it is described?
it is present, sir, but I offhand would not be able to recall the exact details.
For pathology, what are the recommendations for how many sessions should be taken to reasonably so that there is no?
So, section per 1 centimeter of the thyroid should, but in this case we had a whole.
In this case, you have done whole thyroid specific process.
Sir, later, initially the entire specimen was not processed, but when we didn't find any tumor in the thyroid, then later the entire thyroid was processed. No evidence.
So it can be considered as adult thyroid.
Yes, sir. Ectopic.
So that is what we have seen earlier also, many cases of thyroid. We have not found any evidence of tumor in the thyroid itself, but we have seen it metastasis, frank metastasis like endoscopy.
Yes, sir.
Could this be a carcinoma arising from a thyroglosal left pregnant?
So on imaging, we actually asked the radiologist if this the submental lymph node, what we had thought, had a connection with the thyroid. There was no connection with the thyroid, and as Rinda has already mentioned, there were lymphoid follicles in the submental lymph node.
That lymph node will be effaced by thyroid cancer. Perhaps that we would not have been able to say that, but here we did have.
In the submental lymph node we found.
Historically, this is the kind of scenario where lateral aberrant thyroid used to be talked about. And this patient, we thought we have a median aberrant thyroid. Well, I mean, not really, this is not a well-known terminology, but similar to lateral aberrant, this patient did have a median submental lymph node.
So how do patients should be followed up and regularly service should be given?
The recommendations for how do we treat this patient beyond surgery? What are the recommendations for regimen treatment and then follow up?
So this patient was treated with radioactive iodine. We follow up these patients with we suppress the patient with TSH. We follow up with TG, ATG levels like we had done. And because the TG levels were more than 1 and these are stimulated TG levels. Stimulated TG levels more than 1. And there was uptake in the thyroid bed on the radioactive scan. So we ablated the thyroid bed remnant. And we will be following up these patients 6 monthly to yearly.
Why did you decide to follow? You were scared to call it metastatic previously straight away when you had so much medical. You only showed slides, had very deep fragments.
Yes, ma'am.
So what could you have done?
Give a confirmed diagnosis, number one. And again to the surgeon, if the submental swelling was the most dominant swelling, why did you not go and do a biopsy of that and you took a biopsy of some other lymph node? You can answer these questions.
Ma'am, actually, at the time when the FNA was reported, the USG scan, they didn't have any lesion in the thyroid. So that was one of the reasons at that time. Definite metastatic PTC was not given, and then again we can do. We could have made a cell block from the FNA smear, and we could have also applied for immunohistochemistry to confirm the thyroid origin of the PTC of the papillary carcinoma.
Ma'am, we had done a left level 5 because we wanted to keep it within the incision of a possible future surgery, which the patient did undergo a total thyroidectomy, and it was done in the same incision as the previous surgery.
An important reason, but perhaps also the sonographic features of level 5 nodes, which were cystic, enlarged cystic ones, that also was a factor why this was used. Okay, thank you very much.
So,
we can have the next team. the surgeon of the surgeon of this team, but it would be appropriate if you both of you introduce yourself.
Yes. Good afternoon, everybody. I'm Dr. Ganesh Bhatt from the Department of Endocrine Surgery here.
Good evening, everyone. Myself, Dr. Garima Yadav, JR2 Pathology Department, KGMU.
This case is about a stridor in a long-standing goiter. We got an emergency consultation from the Department of Pulmonary Critical Care Medicine. When we went to see the patient, this is what we saw. The volume is missing, but then she had acute respiratory distress with inspiratory stridor. She was refusing oxygen. She was very restless, very uncomfortable, and was literally suffocating to death. So when we asked the history from the relatives, she was a 70-year-old female with an anterior neck swelling since around 40 to 50 years, which was gradually increasing in size. They did not give a history of rapid increase in size of the swelling. She had dyspnea since the 3 months, which exacerbated in the last 1 week, which prompted them to take treatment. She had noisy breathing since the past 2 days. She also gave history of dyspnea and voice change since 2 weeks. She was a known case of hyperthyroidism with hypertension, and she was on treatment since 2 years, and she was a newly diagnosed diabetic. On general physical examination, her SpO2 was 90% with oxygen at 6 liters per minute. She was tachycardic, her blood pressure was 150 by 90 millimeters of mercury, and she had inspiratory stridor. On examination of the neck, the right lobe of thyroid was around 8 into 5 centimeters, the left lobe of thyroid was 10 into 6 centimeters. It had a nodular surface, it was firm in consistency, moving with deglutition, however the lower border was not palpable. On a bedside chest X-ray was done, the parenchyma of the lungs were normal, but there was slight deviation of the trachea towards the right with critical narrowing of the trachea, especially in the upper part. So in view of impending respiratory failure of the patient, we planned the patient for emergency total thyroidectomy. We counseled the patient's relatives regarding the disease that we were considering, the surgery that we would do, and the prognosis of the disease. The issues in this patient were she was an elderly lady with poor performance status, she was hyperthyroid, hypertensive, diabetic. We were not sure how the control was, but the indication of surgery was she was in acute stridor. The patient couldn't lie down. We shifted the patient to the operation theatre upright. On-table nebulization was done. We were suspecting it to be difficult intubation, so bronchoscopy was ready. We did awake intubation, but luckily the intubation was uneventful. Intraoperatively, the right lobe of thyroid was 10 into 7 into 4 centimeters. The isthmus was 5 into 3 into 3. The left lobe of thyroid was 12 into 8 into 7 centimeter with multiple nodules in both the lobes. The dissection of the right lobe of thyroid was uneventful. The left lobe, the majority of the gland was free from the trachea. However, in the posterior medial part, adjacent to the trachea, there was infiltration of the tumor into the 2nd to 4th tracheal rings, causing its destruction with sloughed off tracheal mucosa. So this is the representative image where posteriorly that area of dissection was difficult. When we finally ended up the dissection, the trachea was resected in that area, and as you can see, the rest of the tracheal cartilages was flimsy. There was sloughed off mucosa and there was evident tracheomalacia. So we placed a tracheostomy tube through the rent and we closed the wound because we did not want to do any reconstruction at this time.
So we received the gross as a left thyroidectomy specimen that measured 12 into 6 into 6.5 centimeter. On sectioning, 2 into 1 into 1 centimeter irregular white growth in the mid-region invading surrounding thyroid parenchyma identified. And in another container, the right hemithyroidectomy specimen, where the right lobe measured 12 into 7.5 into 5.5 centimeter, and isthmus measured 5.5 into 3 into 2.5 centimeter. So this was the gross, the left thyroidectomy specimen that we received, and in the center we can see this white, the grayish white area, and the sections were taken from this particular area. So this is how the normal histology of the thyroid looks like on microscopy, and this is actually the multinodular goiter. This is how the nodular goiter or the thyroid follicular nodular disease looks like on microscopy. So the sections that we have taken from the white area of the left thyroidectomy specimen, it showed that the highly pleomorphic malignant cells, and they were arranged in clusters in sheets. And these cells were having the round to oval nuclei, the granular chromatin, and prominent nucleoli. Along with that, eosinophilic cytoplasm, which was moderate in amount, was also there. And we can also see in one corner there is hyalinization, and also the eosinophilic keratinization that formed the keratin pearls. And this was taking place in the background of the colloid goiter. So this is how these cells they look like, and they are highly pleomorphic cells with round to oval nuclei, prominent nucleoli, granular chromatin, and eosinophilic, moderate amount of eosinophilic cytoplasm. So the tumor was found to be reaching up to the capsule at places, and no evidence of lymphovascular invasion, osteoclastic giant cells, sarcomatoid changes, or rhabdoid cells were seen. Representative sections from rest of the left lobe, right lobe, and isthmus showed multiple colloid-filled nodules lined by flattened to cuboidal epithelium. Intervening stroma showed mild inflammatory infiltrates. So the differentials that on the basis of clinical and histomorphology that we basically made were anaplastic thyroid carcinoma, squamoid variant, the medullary thyroid carcinoma, metastatic carcinoma to thyroid, and riddles. So basically, the metastatic carcinoma to the thyroid was ruled out because there was no any pertinent history in the patient, and medullary thyroid carcinoma was ruled out because calcitonin was negative, and renal thyroiditis was also ruled out because there was no extensive fibrosis seen on macroscopy. So the diagnosis for the left lobe was anaplastic carcinoma thyroid squamoid variant arising in a background of colloid goiter, and right lobe and isthmus was thyroid follicular nodular disease.
The patient required ventilatory support for 24 hours post-operatively, was gradually weaned off and shifted to the ward. We spoke to the Department of Pathology because we did not have a pre-operative diagnosis of malignancy, and we got an early report of anaplastic thyroid cancer. So by post-operative day 6, we started radiotherapy to the neck. She received 32 gray in 8 fractions. The post-operative, we did an imaging, cross-sectional imaging for staging, and she was found to be non-metastatic. We also did molecular profiling of the tissue blocks of the anaplastic thyroid cancer, and we got a clinically relevant variant of loss of function in the third promoter region. Its basic utilities, it was diagnostic, and it told us that the ATC was going to be very aggressive. As there were no other targetable genes found, we started her on cabozantinib, which is the tyrosine kinase inhibitor. Currently, it's been 4 months since her surgery. She's healthy on tyrosine kinase inhibitors with no local regional recurrence. In view of anaplastic thyroid cancer, we've currently planned her to keep the tracheostomy permanently, or just in case if her prognosis improves or if she survives, we would probably think of reconstruction later on when the tracheomalacia component comes down. She ended up coming to the OPD today, and this is how she is today. And so the highlights of this case was we wanted to tell how a long-standing goiter ends up being, how it presents to us sometimes with stridor and respiratory failure, the association of hyperthyroidism and malignancy, which is rare, the comorbidities in these long-standing patients because most of them are elderly, the importance of quick decision-making here. We did not wait for the usual protocol of doing an imaging and then doing a cytology and then deciding regarding surgery. The importance of good communication between the surgeons and the patients, the possibility of malignant transformation of a long-standing goiter, the importance of interdepartmental cooperation between endocrine surgery, anesthesia, pathology, radiotherapy, and critical care, and the importance of multimodality treatment in the management of ATC. Thank you.
The surgeon, you decided to take up the patient for an emergency bariatric surgery. What other options do you have? The patient presented with stridor, and what options do you have for managing such a situation?
So the other option would be probably just doing a tracheostomy. or a cricothyroidotomy just to tide off the emergency. But then we also thought that it was moving with deglutition. We thought it was operable, and we thought if intubation, we were anyway planning to intubate the patient and then do a tracheostomy in prop. So we thought, why not do the resection? If we are able to, if it was a benign goiter, multinodular goiter with just tracheomalacia component, it would have been resulted in a cure of the patient without the tracheostomy, probably with something else.
Question to the audience, that how will you differentiate it from the squamous cell carcinoma of trachea? So that is, first you have to differentiate it. Because this tumor was in the trachea and extending towards the, and it was eroding and reaching up to the under surface of the thyroid. So was any workup was done before labeling it as anaplastic cancer?
That's 10 centimeters was thyroid, and your tumor was only 1 centimeters, whatever you said.
You think that was the reason for the stutter? The ADC? Is that the cause of the stutter? Was the location of that anaplastic thyroidcarcinoma important? And did you determine that that was the one which was actually, extending Dr. Krishnani's question, was there, did you see any tracheal epithelium at all in any of your slides? Was any part of the trachea, it also come with thyroidectomy specimen?
No, ma'am.
And based on the location of the tumor, could you now say that that is the cause for stridor? Or was it simply compression due to long-standing goiter?
Ma'am, the tracheal epithelial was not seen in any of the slide that was submitted, and basically it was mainly due to the long-standing goiter that was causing the compression, and also the anaplastic, the changes that were happening.
The surgeon can perhaps mention here, you did a full thickness excision of the tracheal wall.
Yes, sir.
So how is it possible that it was no tracheal component submitted for histology?
It was the anaplastic tumor cells probably invaded the trachea and destroyed the tracheal rings. And probably there was some component which was grossly seen, but most of it was the cartilage which was just tearing away. And that was the slough of mucosa was there. It looked more like the thyroid entering into the trachea rather than the other way around.
Did we see an histology? Was it just?
No, sir.
This substantially lost to see those areas where some degenerated cartilage or some insufficient mucosa for WC. Slough mucosa.
No, sir, it wasn't seen.
We have to see all these things.
This molecular marker was done, so that will not be considered insufficient sponsor.
What was that tyrosine kinase directed in this picture?
Ma'am, it's a multi-kinase inhibitor. It targets all VEGF receptors and EGFR, yeah. MET also.
Why was she not
Ma'am, considering her age, ma'am, 70-year-old female, she received and a tyrosine kinase inhibitor, which is accepted for. Yes, ma'am. It approximately comes out to around 8 to 10,000 a month. So they were affordable.
Say that you were fortunate with this patient, that she didn't have any metastatic disease. You did not elaborate what cross-sectional imaging was done based on which you decided it is free of mets. But for the anaplastic carcinoma, well, the tumor size perhaps is just 2 centimeters, as you said. That can explain why the patient still doesn't have metastasis. But long-standing goiters, presence of anaplastic carcinoma, well, a few questions remain unanswered. What was the cause for the stridor? We'll go on to the next case.
Thank you.
Please introduce yourself.
Good afternoon, sir. I'm Dr. Rizin. I'm senior resident in endocrine surgery.
Hi, I'm Dr. Vaibhav Gupta, senior resident in pathology.
Good afternoon. I'll be presenting a case from KGMU. So my name is Dr. Rasin. I'm a senior resident in Department of Endocrine Surgery. So my case is a 35-year-old female patient who came with complaints of upper abdominal pain since 2 months, with history of palpitation, intermittent, which was occurring 4 to 5 times per day since the past 2 months, even at rest. The patient also had frontal headache and sweating since the past 2 months. The patient did not have any history of did not give any history of visual disturbance, galactorrhea, amenorrhea. She gave no history of bone pain, bony swelling, fracture following trivial trauma, no history of loin to groin pain, hematuria, calcaluria, UTI. She gave no history of epigastric pain, vomiting, dyspepsia, no loss of memory, low affect, or polydipsia or constipation. So a detailed family history was taken. She was second of 7 siblings. 2 of her sisters had expired because of in a young age, and a younger brother also had expired at a younger age. On general physical examination, there was a scaly pruritic lesion in the upper back. She was normotensive. Local examination, the abdomen was normal. There was a hard nodule in the right lobe of the thyroid. She also had bilateral cervical lymph nodes which were palpable, and there was no postal hypertension. This is a picture showing the scaly pruritic lesion in the upper back. So biochemical workup was done for the patient. A baseline serum cortisol was done, which was normal. Overnight dexamethasone suppression test was done, which was normal, but there was suppression of the cortisol level on giving 1 mg of dexamethasone. It was 1.2 microgram per deciliter, which was a history of a normal hypothalamic-pituitary axis. But 24-hour urinary metanephrine, norepinephrine was elevated. So this was pointing towards a functioning pheochromocytoma. Also, the patient's calcitonin was also done because the patient was having a thyroid nodule. So the patient's calcitonin also was markedly elevated. Normal value would have been less than 5 microgram, but the patient's was 1074. Serum Ca was normal. Serum calcium, phosphorus, vitamin D was also done, which was all normal. The thyroid function was also done along with this, which was also normal. So we went ahead with imaging for the patient. So imaging showed a heterogeneously enhancing lesion. The abdominal CT shows heterogeneously enhancing 6.5 into 7 centimeter lesion in the right adrenal region, and a 2.1 into 2.2 centimeter heterogeneously enhancing lesion on the left side. On the ultrasound CT neck showed a heterogeneously enhancing lesion in the right lobe of the thyroid and multiple cervical lymph nodes also. So we went ahead with an FNAC of the thyroid nodule, which came out to be medullary thyroid carcinoma, whether it's a 6. So we concluded that the patient was having a multiple endocrine neoplasia type 2A with medullary thyroid carcinoma, bilateral pheochromocytoma, and cutaneous lichen amyloidosis. So we went ahead with the genetic testing for the patient. So in MEN2A CLA variant type, we went ahead with the targeted testing for 634 mutation, which came out to be positive for this patient. So we took up the patient book for bilateral cortical sparing open adrenalectomy and the transperitoneal approach on August 2021. So histopath report was a pheochromocytoma with a PAS score of 2. The details will be explained by my colleague. So we had done a targeted, the patient had 4 children. In that we had done targeted codon 634 testing for all the 4 children. In that 2 of the children were found to be positive for codon 634 mutation. So once this was done, the patient, the same patient after the pheochromocytoma surgery for the open transperitoneal adrenalectomy, we had taken the patient up for total thyroidectomy with bilateral central lymph node dissection with bilateral lymphopathodectomy. So histopath report had come out to be medullary thyroid carcinoma, pathological T2N1B. Details will be explained, and bilateral pathoid gland was normal. So follow up the patient. The patient is right now on calcium supplementation and also on steroid and on prednisolone and fludrocortisone. One of the child with normal urinary metanephrine, normetanephrine, had elevated serum calcitonin and underwent total thyroidectomy with central lymph node dissection, bilateral MRND. The other child is yet to come for follow-up.
We received a specimen in August 21. First is adrenalectomy. Bilateral adrenalectomy is received, right measuring 6.5 into 5 into 5 centimeter and left measuring 6 into 4.5 into 2.5 centimeter. On cut surface area, there is yellowish nodules area on both the right measuring 6.5 into and left measuring 3.2 with focal areas of hemorrhage. On looking the microscopy, we can see that there is a well demarcated lesion and cavity is encapsulated, showing tumor and the capsular areas with focal areas of hemorrhages. As we can see, as we want to proceed, we can see that there is a on low microscopy we can see organoid pattern of the and like cell pollen pattern, ball of cells separated by the fibrous septa. On looking on the higher vision, we can see that there are polygonal cells having coarse chromatin, conspicuous nuclei, and abundant granular cytoplasm. So on the morphologically basis, we apply the path scope, which comes out to be +2 for cellular monotomy, and it is a bilateral pheochromocytoma, broadly benign on the basis of morphology. Next, after the 1 month, we receive the specimen of total thyroidectomy with central component lymph node and right MRND, left MRND, and bilateral parathyroid. The right thyroid measuring 5 into 2.5 into 2 centimeter. Cut surface shows a firm gray area measuring 3 into 2 into 1.5 centimeter involving only upper and middle bone. And the left thyroid is 3.5 into 2 into 1.5 having ill-defined firm gray areas measuring 1 into 0.5 into 0.5 which is at the upper pole. So as we can see in the microscopy, there is a capsule stripped off and showing as a vascular capsula invading at the places. The tumors, second imaging, that they are also showing that capsule is stripped off and the tumor is coming out of the capsule. Next, we can see that alveolar pattern and the follicular pattern of the tumor. Cells are mainly pilocytoid to the spindle cell cells at the focal areas. We can see few spindle cell cells having coarse chromatin, spipple type chromatin, and the prominent nuclei. Few of them are showing nuclear grooving. And in the lymph node, we can see that tumor is invaded into the lymph node with focal calcification. We applied the calcitonin in the tumor cell. They are came out as an intense strong positive. So the and we applied TTF1, which is weak positive, PAX8 is focal positive, thyroglobulin is negative, and Ki67 is 7%. So the final diagnosis is medullary carciothyroid. Lymph node are central component 4 out of 4 positive, and left MRND 5 out of 19 out of 5 is positive. Right MRND is 3 out of 16 is positive, and bilateral parathyroid is unremarkable.
So the learning points from our case presentation was the importance of detailed history and physical examination. The pruritic lesions on the back, we were able to come to a diagnosis of CLA variant of MEN2A. So we could go ahead with genetic testing for children, and we could go ahead with the targeted colon-directed surgery for the children. One of the child was operated. The report came out to be T2N0 medullary thyroid carcinoma for the 11-year-old child. So that is the learning point from our clinical case. Thank you.
For the next patient, for the mother, you said you did bilateral cortical sparing.
Yes, sir.
For a tumor size of 6.5 centimeters.
Yes, sir.
Why cortical sparing? And what was the result? Did you achieve something by sparing the cortex or any?
Sir, the cortical sparing adrenalectomy was, sir, we had, after the patient was followed up after 6 months, so we had tried to wean the patient off the steroids. So that time the patients with pituitary axis, so we had kept the patient, continued the patient on steroids. But in view of the young age of the patient, we had tried cortical sparing adrenalectomy, sir.
Whereas histology, this was a 64 mutated.
Yes, sir.
Yes, sir.
For the pheochromocytoma histology, you said the passcode was 2.
Yes, sir.
And probably benign.
Yes, sir.
Why would you consider malignancy in this patient when you have a reputation 64 mutation?
Most of the cases are benign, but a handful of the cases, like 5% or 6% cases, are malignant also. That's why I'm considering that in MEN2 syndrome.
5% of pheochromocytoma and MEN2 are malignant.
Yes, sir.
this thyroid, normal thyroid histology was in normal area.
So normal thyroid was present at places, but we couldn't have the picture for that.
So there are some abnormality, but there will be some cues here, which will suggest that patient is abnormal.
Sir?
Have you seen any evidence of hyperplasia?
No, sir. We couldn't.
That is what we have to look for.
Yes, sir. But we couldn't find the C-cell hyperplasia. We have the whole tumor areas in that, and at the focal places we can see normal thyroid. But there is no C-cell hyperplasia in the tumor, rest of the portion.
In every case, it's not work up. So once you see clearly, this normal thyroid here for C-cell hyperplasia.
Yes, sir.
What about the other siblings?
So the other siblings were negative. There were 4 of them. In that, 2 were positive for 634 mutation. So the first patient, the elder one, was 11 years old. So we had done a ultrasound and calcitonin. It was elevated, and we had taken up the patient for total thyroidectomy CCLND. So the patient's histopath report came out to me medullary thyroid carcinoma.
And what about the other siblings? And what's the age? And at what time should be done?
Sir, the second one is 4 years old. So we have explained to the patient about the need for prophylactic total thyroidectomy for the age of 5 years. But in view of financial constraints, they have delayed the.
Can't it be done earlier? Even in 634. Why to wait for a longer period? Even at the age of 6 months to 1 year, one can go for surgery.
What's the recommendation?
What's the recommendation?
So recommendation is 634 comes under the high risk group. So prophylactic thyroidectomy is usually advised before the age of 5 years. Whereas if it is highest risk group, where it is 918 mutation, it has to be done before the age of 1 year.
My question to the reception is, I can understand prophylactic thyroidectomy.
Yes, sir.
But why do they also recommend prophylactic techniques? I mean,
Ma'am, in
and
this,
in the previous case, were the lymph nodes involved?
ma'am, the patient's calcitonin was elevated. The child's calcitonin was, for the index patient, ma'am, the calcitonin was 1074. So that for that patient, total thyroidectomy, CCLND and MRND is indicated, ma'am. For the child also, we have done an
Five. And for the other patient, when you're planning,
ma'am, the patient had elevated calcitonin, and also the CCLND is indicated, ma'am. FNAC is, ma'am.
You said that parathyroids were of unremarkable histology. Were these intended to or?
Sir, yes. Sir, the vitamin D was 13. PTH was marginally elevated. It's around 98. It was in August 2021, with the time of the surgery was. So that time, we were suspecting MEN to a CLA variant. So we were expecting parathyroid adenoma. But in view of... No, calcium, sir, calcium was normal, sir. Calcium was not elevated. Sorry, sir. PTH was marginally elevated, sir. But in view of logistic issue because of the COVID situation, we didn't go ahead with a MIB scan to diagnose a parathyroid adenoma. We intraoperatively found that 2 parathyroids were enlarged. So we removed that, but that came out to be normal. Normal parathyroid.
Any idea? Because you are seeing larger in size. So simply being a larger itself becomes a parathyroid hyperplasia or something. So very difficult to say that it could be a normal. Because you are saying it morphologically and during intraoperative surgery you found you saw it enlarged.
Yes, ma'am. Yes, sir.
So have you taken the weight of that parathyroid? If any of the gland is more than 35 milligrams, then it automatically becomes normal. Irrespective of normal. Becomes normal, it looks like normal. Difficult to differentiate.
Yes, sir.
So it should always be, weight should always be taken for any parathyroid which is taken.
Yes.
About the post-operative PTH levels.
Yes, sir. The post-operative PTH levels were normal, sir. So, Thank you, sir.
Thank you so much, sir. I would now request Krishnani, sir, to please felicitate our expert panelists, Dr. Gaurav Agrawal, sir, and Manoj Jain, sir.
I would also request our HOD, Professor USC sir, to please come on stage to give awards to the winners of the poster presentations and the case presentations. I would request Gaurav Agrawal sir to please stay for some time with us. For just for 2 minutes. To give the prizes, all the judges, to give the prizes to the case winners and the poster winners. We'll be giving prizes to the first 3 winners of the poster presentation that we had. It was judged by Aarti Bhattacharya and Deeparani ma'am. So I would request Dr. Isha Makkar to please come on the stage. Her poster was on analysis of BRAF turtle NRAS gene in papillary thyroid carcinoma, a study by Sanger sequencing.
Sir, सामने
Next, I would request Dr. Richa Singh to please come on the stage first. And the third prize is to Dr. Gulshan Kumar. Dr. Richa's poster is on metastatic infiltration in thyroid gland, a multi-institutional study. And Dr. Gulshan presented an unusual case of secretory carcinoma thyroid without a classical EGB LTR6 fusion mutation. May I also request Radhika Srinivasan ma'am to please join to present the prizes to the winners of the last session, the interesting case clinical pathological session that we had.
So the best 2 teams are there. They slightly clash, so there is no first and second. The one is team from SDPGI, second case, Dr. Linden, and the pathology resident, please come forward. And Dr. Ganesh and Dr. Garima. So these 2 teams got the highest scores. Your each certificate will be sent by email. I will be getting the prizes then.
Who got the first prize? Ganesh. First prize. Second year मिल ना 19. अच्छा 19. See properly. This is 1 number 2. Yes, SPJ is Garima audience.
I now. I now request all the dignitaries on the dais to please felicitate our members of organizing committee, Dr. Chandrana ma'am,
Dr. Pooja Ramakan, ma'am. Dr. Shalini Halla, ma'am.
May I also please request Deepa, Articulate Carrier ma'am and Deepa Rani ma'am. They were the judges of the poster presentation. Deepa ma'am and Arti ma'am, please come on the stage. There is an important announcement that our education want to make.
On behalf of Department of Pathology and also Department of Endocrine Surgery, KGMU, we are thankful to everyone present here and also the persons who are online seeing our programs. And this program has been a grand success because of the participants, because you have come, because you have become the delegate of this function, the speakers who have come from very far away places. Everyone participation has made it a grand success. We want to repeat it again and again, and Dr. Chanchal and her team will be there to do it as soon as possible, at least annually, once at KGMU preferably. I have some other announcement, and this would have been better to be announced by the organizing secretary, but unfortunately due to their some engagements, they are not here. So on behalf of the organizing secretary, I invite you all on the UP Cytocon 2023. This was conferred to KGMU by the Indian Academy of Cytopathologists, UP chapter, and the date decided is in September. The dates are 15 and 16 September 2023, and the days again will be Friday and Saturday. So I will request that please do come to attend this again a good program, good CME, because the cytopathology, now has become, very important, and almost we can diagnose by this for the definitive therapy. So right from the tumor identification to the grading and everything, so many things has come up, and I hope that you will come. For those who are faculty at different places, For those who are senior consultant at different places, we request them to spread this news so that more and more people participate in that. And we wish that your blessings are there, your best wishes are with us, so that we can do the Cytocon 2023 also in a grand manner. Now, there are no words for today's function. As I have already said, that all the residents, all the junior, senior residents, staff, employees of my department, as well as Professor Anand Mishra's department, their faculty, and especially the organizing secretary, Dr. Chanchal, Dr. Shalini, Dr. Reddy, and if I keep on naming almost all the 18 faculties, name will be there. They have worked with great enthusiasm, without any directions, with their innate intelligence, and they have put, say, so much of the labor and everything you can imagine. So let us give them a great applause, and thank you very much to all of you.
I would like to invite Anand Mishra sir to please for a vote of thanks. And this is one thing I would like to say, that none of it would have been possible without the support of Anand Mishra sir and USC sir. They have been the guiding force behind the entire event.
So, a very good evening. It was a pleasure to be associated with this conference. In fact, we conceptualized this conference way back in January, probably, and we thought we will have, and started thinking of different sessions. How can we make it interesting and more useful and more academic? And I'm very happy that so many delegates and so many PCs have attended this conference, and probably they will enjoy more tomorrow's and day after tomorrow's workshop. You will be more enlightened on this thyroid pathology. At this juncture, I would like to thank the faculty who have traveled from far and distance. Ma'am, you have traveled from Chandigarh. Thank you for giving so much of time to this conference. And I thank all the faculties involved in this conference. Delegates, this conference cannot be without you. So a lot of thanks to you. You have shown interest, and definitely we would like to have a feedback after 2 days. When you go back, just give feedbacks. What were the strong points of this conference, and what were more we can incorporate in next future conferences, which will be more useful to you. And with this, I thank the Shatabdi administrative people, CMS of this building, and then university administration for giving us all the support for this conference. Lot of applaud to organizing team, and especially Dr. Chanchal and Dr. Shalini from the pathology. Basically, if you say 100% work was done by them, we are only the percent sign only. Thank you.
Thank you so much. I will request everyone to please proceed for the high tea.
बच्चों मेरा मोमेंटो अच्छा